liver disease, we had to stop anticoagulation. So what we did angiovac, and we sucked the device out with the distal protection device in the carotid, and then I did perform AF ablation, and he has done well since this. This is 2 years ago. So after device implant, I mostly keep them on DOAC for 6 weeks. As a protocol, we do a TE, and if the TE is clean, there is no peri-device leak, there is no thrombus, then we start DAP for up to 6 months, and then aspirin. This is also true for AMOLED, but you have a choice that you may not use DOAC. You can just start DAP for 6 months and then switch to aspirin. So conclude, LAO is an effective strategy for stroke prevention in patients with non-valvular AF who are unsuitable for long-term anticoagulation. AF ablation plus Watchman is non-inferior to AF plus oral anticoagulation. That option trial showed. There are few recent trials. The closer AF which showed not much benefit, but it is not published yet. And there is ongoing Champion AF trial, which will be published next year. This is a long-term study with Watchman versus DOAC in patients with AF. With that, thank you very much for listening.
Thank you, Mithlesh. Thanks a lot for a wonderful deliberation. Can we have a quick comment or anything from panelists? Yeah.
Sir, how many patients you are seeing with persistent episodes of embolization post-implantation of this Watchman or amulet after 6 months also, when the patient was on aspirin only?
Yeah, so we have done in our center, we have done 905 cases. And we have seen only one embolization so far. But the risk of embolization is like 1% if you are doing well. Because the liver devices and our reps are very particular about looking at all those. So they also help us to make sure the device size is important, is done well, is delivered well, and then most of the device initial implant, the initial implant is 5 minutes. You have to watch it when it's live. And then it rarely discharges after 6 months.
Thank you, sir.
So, can I request Dr. Narasimhan to have his comments? Yeah.
Hi, Mithlesh. Very nice talk. Nice talking to you. Good morning. So again, I would like to emphasize, when you have a person with CHAD score of 2 or 3, and he doesn't have atrial fibrillation, if he's in sinus, there is no need for anticoagulation. So there is an increasing evidence that restoration and maintenance of sinus rhythm significantly reduces the risk of embolic stroke, reduces heart failure, several endpoints come down. The reason why this is important is there is a predictable outcome nowadays with AFib ablation with one-shot devices close to 90 to 95%. And you can monitor if they have a successful outcome, the need for anticoagulation comes down significantly.
Exactly.
Any other comment from the audience?
Sir, can I have a question, sir?
Yes, please.
Thank you, sir, for the opportunity, sir. Sir, I have a question, sir. What is your experience about the PFA versus normal traditional RFA, sir, in case of the AF ablation?
Well, this question to me? Yeah, so I have been using RF for like 25 years. And now we switched to PFA for the last 2 years. I have stopped doing that. The reason is that our recurrence rate, we have not published yet, is much less than ours. Second thing, we can be done in 1.5 hours with the Feather's hand itself. We don't worry about esophageal issues or phrenic nerve issues with the PFA. And the one we are using mostly nowadays is Afera, which we can switch the energy in the same patient, in the same place. So in thicker areas, we sometimes do double. We can do that. It's good for AF. It's not yet available for VT ablation.
Thank you, sir.
So thank you very much. If no questions, we move to the next topic.
Thank you, Dr.
Thank you very much.
Thank you so much, Dr. Das.
Thank you, thank you. Have a nice day.
So with that, we move to our next speaker, who is Dr. Shanmuga Sundaram Ponuswamy. He is a leading researcher in the left and LBP pacing from Vallamal Medical College in Madurai. He's done some extensive work. In fact, he was one of the first in the world to describe lead placement guided preventricular beats during the procedure. And he's going to talk to us about LBP area pacing, New Horizons. So over to Dr. Ponuswamy. He's just going to join us virtually soon.
For giving me this opportunity. So for the next 10 minutes, I will briefly discussing about the role of left bundle pacing for patients with symptomatic bradycardia and heart failure. These are my disclosures. The various aspects of cardiac conduction system fibers can be targeted for providing electrical and mechanical resynchronization therapy for the heart. The H-bundle can be targeted at its proximal end, just superior to the tricuspid annulus, or at its distal end, just below the tricuspid annulus in the luminous septum, which separates the right ventricle from the left ventricle. Similarly, left bundle branch can be targeted either at its proximal trunk or one of its vesicles, be it anterior, posterior, or a septal vesicle. Very rarely, right bundle can be targeted by positioning the lead just distal to the distal bundle, or at the distal end of the right bundle where it's connected to the moderator band. Often we started performing an atrial conduction system pacing as well by putting the lead into the backbone bundle, which is the electrical communication between the right atrium and the left. So we have learned from our physiology days that the fibers inside the His bundle are longitudinally dissociated. So if you have any segmental disease within the His bundle, you can produce either right bundle branch block morphology or left bundle branch block morphology. So if you could position the lead just distal to the site of block, either in the distal His bundle or in the proximal left bundle, you'll be able to correct the white QRS, resulting in normalization of the QRS morphology and improvement in heart failure symptoms. It's important to understand the fluoroscopic anatomy of cardiac conduction system fibers. Whether you're performing His bundle pacing or left bundle pacing, you need to know where exactly the His bundle will be and where exactly the left bundle will be. So it's our practice to place two catheters from the groin, whether you're doing His bundle pacing or left bundle pacing. The quadripolar catheter will be in the distal ends, and another catheter will be at the right ventricular apex for a backup pacing. Since we have a continuous visualization of the His bundle, we know where exactly the His bundle is. So if I want to deploy the lead in the His bundle, I just have to take the pacing lead at the distal end of that quadripolar catheter to look for the His signals. Or if I want to do a left bundle pacing, I have to go a little below 1 to 1.5 centimeter, just distal to the distal His signal towards the RV apex. If you don't have an EP system, if you don't have an EP catheter, you can put a temporary pacing lead right into the RV apex, and you can use the hump of that RV catheter lead, TPA catheter lead, as an equivalent of His bundle, and you have to go probably 1.5 centimeter below the hump of that His catheter. So how His bundle pacing corrects white QRS? So as we discussed, the fibers will be longitudinally dissociated. So you just have to map the His bundle to identify the disease-free segment. So what we do is look for the HV interval of the His bundle. So if you get a prolonged HV, that means that you are proximal to the site of block. When you get a normal HV, whether it is a left bundle branch block white QRS morphology or right bundle branch block white QRS morphology, if you could deploy the lead at a site where the HV interval is normal, we'll be able to correct the QRS morphology, whether it is RBBP or LBBP. So over the last 15 years, we have learned the limitation of the His bundle. Nearly 10 to 20% of the patients can have dislodgements or unpredictable rising threshold, resulting in premature battery depletion. The target zone which we are aiming is really narrow, so the chance of error is really very, very less. And in patients where they are pacing dependent, for example, a symptomatic complete heart block patient, you may have to provide additional right ventricular backup lead to avoid asystole and sudden cardiac death. So to overcome these limitations, Dr. Wang from China has introduced the concept of left bundle branch pacing, where the lead will be directly deployed into the left bundle fibers. There is some confusion in explaining the terminologies. The left bundle branch pacing means it's a pure conduction system capture where either the trunk or one of the fascicles of the left bundle will be captured along with the septal myocardium. On the other hand, left bundle branch area pacing not only includes the conduction system capture but also the LV septal pacing. So as a purist, I would go with the left bundle pacing or the left bundle area pacing, which provides a better electrical activation of the heart. But how to do left bundle pacing? We know the fibers are on the other side of the intraventricular septum, on the LV subendocardium. So we have to start from the right side, just opposite to the left bundle fibers. So how to identify the target site? I initially described the fluoroscopic anatomy of conduction system fiber. So that is one way of approaching it. The easiest way would be to go by an ECG localization. So take your delivery catheter along with the pacing lead to a probable site, do a pace mapping. If you get a W pattern in lead V1 and a discordant QRS complexes in AVR and AVL, but a predominantly positive QRS in lead 2, that means that would be an appropriate site to start deploying the lead. Remember, the most important step in doing conduction system pacing, whether it is a His bundle pacing or left bundle pacing, is to identify the His signal. I would say if you identify the His bundle signal, the exact location of the His bundle signal, half of the procedure is already done. So once you identify the target site, in the right anterior oblique view, pan the fluoro image I to a left anterior oblique view, and the deployment should be done in LAO view. So why? The LAO will give a better picture of the lead movement. So as the lead traverses from the right side to the left side of the septum, either you can do a continuous spacing or you can generate PVCs, and this PVC morphology will change from QS to QR in lead V1. Once you get a premature ventricular complex morphology of right bundle delay pattern in lead V1, that confirms that you have already reached the target zone. So this is probably the quickest way of doing conduction system capture. So here it is explained. You can see just follow the lead V1 as you give rapid rotation. The PVCs are getting generated and the morphology changes from QS on the right side to QR on the left side. If you get a specific M morphology of QRS in lead V1, this all the more confirms the selective capture of left bundle fibers. On the other hand, if you are not able to generate PVCs, you can do a continuous pacing. So with a stylet-driven lead, it is feasible because you'll be having a stylet where you can attach the alligator clip and do a continuous pacing. Look for changing QRS morphology. Just for simplification, you can just watch the lead V1, how the QRS morphology changes. As the lead moves from right side to left side, you can see the QS changing to QR along with a reduction in QRS duration and reduction in left ventricular activation time. So it's important to optimize the procedure for a better result, to provide a better resynchronization therapy. So how to get a perfect conduction system pacing? You should identify the right tools for implantation. Understand the anatomy. You have to identify the target site so that you avoid going for multiple attempts, and have your own implantation technique. Some people will go for rapid rotation, some people will go for continuous spacing, and it is important to have a very simplified criteria to confirm the capture of left bundle. If you Google it, you can see at least 20-25 criteria for confirming the conduction system capture in left bundle pacing, but I would go with these three important criteria. See, your pacing lead is on the left side of the intraventricular septum, capturing the left bundle fibers. So you should create a right bundle delay pattern in the surface ECG. I would take it as a major criteria. But along with that, I need to have one other additional criteria to confirm that it is left bundle and it is not LV septal pacing. The first one is short and constant LVAT in lead V6 and output dependent change in QRS morphology. So it can be either non-selective to selective or non-selective to septal. The left bundle potentials may or may not be seen, but in a patient where you would expect a left bundle potential, for example, if the QRS morphology is narrow or if the QRS morphology is a right bundle delay pattern, you would expect a left bundle potential to be there. If you are not getting a left bundle potential in a patient where there is an antegrade activation of the left bundle, that means that it is not left bundle pacing, it is more of an LV septal pacing. The quickest way to confirm conduction system capture is to measure the LVAT. So once you generate a right bundle delay pattern in lead V1, measure the LVAT at 8 volt and 2 volt. So if you get a short and constant number, that means that probably you are in the conduction system. I don't have any magical number to confirm that it is left bundle pacing or it is not LV septal pacing, though there are several trials, several studies have shown that less than 75 means it is conduction system capture in non-LV morphology and less than 85 means it is a conduction system capture in patient with LV morphology. Rather, it should be short and constant to confirm LVVP capture. Output dependent change in QRS morphology, you can see as the output is getting reduced, you will be able to see a change in QRS morphology. This happens because the pacing lead is capturing two different substrates. One is the ventricular myocardium, the second one is the left bundle fibers. Both has different electrophysiological properties. So as you reduce the pacing output, at one particular point, either the septal myocardium or the left bundle fibers will lose its conduction property, but that will be reflected on the surface ECG as a change in QRS morphology and change in local electrogram. So you can see here the first two beats are non-selectively captured beat, the local electrogram showing a pacing artifact along with the ventricular electrogram together. But once you reduce the output and when it becomes selective capture, you can see the ventricular electrograms being pushed out of the pacing artifact. Similarly, you can see a change in QRS morphology. The lead to predominantly positive has become predominantly negative. And there is a subtle change in QRS morphology from QR to RSR. And there is an appearance of new S wave in lead V5, which was not there before. But the most important thing to look for is the retrograde wrist bundle potential. So as the left bundle is getting activated, it quickly gets conducted retrogradely to activate the S to produce a retrograde S at a very short SH interval. So this all the more confirms that it is a conduction system capture and it is not LV septal pacing. In patients where there is an antegrade activation of left bundle, for example a narrow QRS or a baseline right bundle branch block, you should be able to demonstrate a left bundle potential. For example, if there is no left bundle potential, when the QRS morphology is either normal or right bundle, that means that it is not left bundle pacing. So once you have confirmed the capture of left bundle, once you have made sure that it is left bundle capture, then the next thing is to remove the sheath. So I would go for a rapid removal of sheath to avoid either micro or macro dislodgements. So previously we used to have some sort of micro dislodgements while removing the sheath in patients who are getting a lumenless lead because the lead will be slender. But when we started adapting this rapid removal technique where the initial hub removal will be little slow, delayed, but once the hub part is slitted, then the remaining part can be rapidly removed so that you will have a very stable lead in the left bundle. The clinical implications, the left bundle can be used to correct either left bundle branch block or right bundle branch block morphology. Sometimes we may be clubbing both his bundle and left bundle. For example, a right bundle branch, LV dysfunction, dilated cardiomyopathy. It's always better to attempt for his bundle where it provides complete correction of right bundle branch block and complete synchronized activation of both left bundle and right bundle. So very rarely we do a capture of a right bundle branch block, right bundle fibers either at its proximal end or at distal end. This is one of the patient where the patient had an ischemic DCM based in wide right bundle with left axis deviation with severe LV dysfunction and predominantly scarred ventricular myocardium. Luckily, we could enter into the left bundle through probably a disease-free segment in the interventricular segment. And fortunately, our ICD lead got into the distal right bundle fibers, which corrected the right bundle morphology. Since it was a DF1 ICD lead, we had the luxury of using 4 leads. We put traditional lead into the coronary sinus, and a lot CRTD was done, which had significantly narrowed down the QRS duration from nearly 200 milliseconds to almost like 120 milliseconds. So after it, we started doing conduction system pacing for the atrium, so which can be clubbed with the conduction system pacing for the ventricle. So here the fibers of the backbone bundle will be targeted. It starts from the SA node, then circles around the ostium of the sinus with superior vena cava to reach the other end at the interatrial aspect. So from there it goes little down to reach the superior limbus of the fossa ovalis, where it gets penetrated into the left atrium. So this is probably the important electrical communication between the right atrium and the left atrium, and there are a lot of patients where you can have interatrial conduction delay because of the diseased backbone bundle. So once you capture the backbone bundle, you will be able to narrow down the P wave duration. You can see here the baseline sinus rhythm showing a notched P wave. The lead is exactly positioned over the backbone bundle. This is a HL electrogram. This is a backbone bundle potential. So as we stimulate the backbone bundle, you can see the correction of the interatrial delay from notched P wave will lead to the P wave, near normal appearing P wave, which is tall and positive will lead to 3 AV has been generated. So this can be clubbed together with ventricular conduction system pacing, especially useful for patients with diastolic heart failure and sinus node dysfunction. So what are the indications? It's rather difficult to enumerate the list of indications for conduction system pacing, but I would rather say what are the patients where you should not have for conduction system pacing. For example, a sinus node dysfunction patient where the ventricular pacing is not required. The majority of the patients may need a ventricular pacing, but there are some specific subsegment of population where the ventricular pacing will not be required. It's all pure sinus node dysfunction. A cardiomyopathy with transmural scar, it's always better to get the help of cardiac MRI. Though it may be an LED therapeutic far, there may be some patchy islands of normal appearing myocardium which can be easily picked up from cardiac MRI. So if you have that patchy normal zone, still you can go for a left bundle pacing by deploying the lead into that normal appearing zone. Infiltrative cardiomyopathy, I would rather step back from doing a his bundle pacing because there is a high chance for future development of conduction system disease distant to the lead deployment. But with the left bundle pacing, even though the disease might develop in the future, there will be an intact septal capture, so the patient will not develop asystole because of the disease progression. But remember, these patients may need a lot CRT if they have a wide QRS. A simple dual chamber with lumbar branch pacing may not provide a good resynchronization therapy in patients with infiltrative cardiomyopathy. Thank you for your patient listening. I'll be happy to take questions. Thank you.
So, thank you very much. No question is possible because, he's offline.
So he sent that presentation just 2 hours prior because he was traveling in the flight, so that's why. So further questions, because we have Dr. Narasimhan sir here with us and he is having on the next presentation. He is the best person to answer any questions regarding left bundle pacing.
Any question or comments from panelists or Dr. Narasimhan or any of you sitting here?
Sir,
Yeah, sure.
Sir, I just wanted to know, good morning sir, that what are the technical difficulties that one may encounter while doing left bundle area pacing in a patient with a persistent LSPC connection?
We have done only one patient for this. We have done hundreds, we have had only one patient. Main thing is to make sure you don't jail the septal leaflet of the tricuspid valve. So the way to know it is when you make a reverse loop, come against the septum, puff a little contrast to make sure that you are against the septum. If your lead is just exposed and you start pacing in a unipolar fashion, if you're jailing the septum, you'll still see the electrogram, but you can't capture it because it's through the fibrous tissue. You need to ensure that you're against the contact, look at the ST elevation, and because one of the complications of left bundle pacing, if it's done too proximally, is to jail and cause more TR. That is something you need to avoid.
Thank you, sir.
So our next topic is VT storm. The name sounds stressful. It's extremely important. We are all have been in that situation. So I would like to welcome, it's our honor and pleasure to welcome Dr. C. Narasimhan from Hyderabad to speak and guide on this topic.
Good morning. Thank you all for the kind invitation, and indeed it's a great pleasure to join you at this meeting. Over the next couple of minutes, we'll just set up an approach to VT storm, and all of you know that it's a clustering of VT within 24 hours, anywhere from 3 or more episodes or recurrent ICD shocks, which cause ATP failing and repeated shocks. These are not theoretical concerns even in patients with ICD, because each shock causes myocardial injury and there is a higher incidence of heart failure death if you leave it untreated. So the clinical implications are 20% of these patients are going to come back with recurrent VTs, and more importantly, once they have an electrical storm, there is almost a 5-fold increase in mortality over the next 3 to 4 months. So it is a serious disorder. When we try to escalate medical therapy, more and more and more of amiodarone, what happens is generally the VT cycle length slows down. What was a rapid VT getting a shock will become a slow VT, and patients will very often present with heart failure. So let's start with the first patient. This is a patient who was seen to us, we saw her several years ago with recurrent VT following a PCI to LAD, and she came with recurrent monomorphic VT. And as usual, the main thing is to sedate the patient, ventilate the patient, ask the anesthetist not to use too much of muscle relaxants, because it's extremely important to make sure the patient is adequately sedated and not very paralyzed. And so you need to have your anesthetist who knows what he's doing. And we use a combination of lidocaine and amiodarone for this patient, and you cannot overemphasize the importance of a beta blockade. There is increasing evidence that non-selective beta blocker like propranolol is superior to the selective beta blockers in this condition. And there is data to suggest that it not only reduces the episodes of VT and VF, but also improves survival in patients with VT storm. And the selection of hemodynamics are extremely important in these patients. Try to use the lowest dose of noradrenaline and avoid other drugs like dopamine. Again, there are several studies which shows the other inotropes have an increased arrhythmogenicity. One of the important things that you need to, because very often these patients are managed by critical care individuals, don't go just by their POCUS and assessment of IVC. And you need to see if the lung compliance is good, static and dynamic compliance of the lung is good. You first correct the volume, make sure that the patient is not having any component of hypovolemia. And a very low threshold for IABP if a person has a mitral regurgitation. And we put a pacing lead in the atrium if possible through a coronary sinus to keep the atrial rate at about 80 or 90. Because pure ventricular pacing, while you'll be able to suppress the VT, you can worsen the ventricular function. And most of these patients benefit from sympathetic blockade. If beta blocker alone is insufficient, you can choose to do a left stent percutaneous blockade, and most of the anesthetists with an ultrasound guidance can offer you this. Despite this, if the patient persists to have recurrent VT and VF, we can offer a catheter ablation. It's highly effective once all these things are taken care of. This is a large area of infarct in the anterior wall. Around the area of the infarct, Purkinje potentials fire rapidly and cause ventricular tachycardia. Now, more importantly, when you have a person with recurrent VT and VF, it's important to look at the ECG. These patients have, by the time they reach your ICU, they would have been loaded with amiodarone. QT is generally prolonged. Now, a prolonged QT and VT does not automatically mean that it is due to amiodarone. For example, this patient's QT is 480, but look at the coupling interval. Whenever you see a coupling interval that is very short, this is a fundamental difference. When you have a long coupling interval, the mechanism of VT is usually re-entry, and they respond well to amiodarone, sotalol, beta blocker, so on and so forth. When the coupling interval is very short, it comes from the Purkinje system. They seldom respond to amiodarone. And the drug of choice for this, luckily now it's available, it's quinidine. If quinidine is not available, you can use good old phenytoin for this situation. When the coupling interval is very short, phenytoin, or you can use quinidine to suppress this VT very effectively. The second thing is you need to have a diagnostic framework when a patient comes to you with VT and VF. I'm going to spend a little time on this slide. First of all, when you have a person with recurrent VT and you're called into the ICU, you need to decide whether this patient has a terminal heart failure and then he's having VT and VF, progressive heart failure, and in these patients the emphasis would be to stabilize and send him for an LVAD or a transplant rather than considering just a VT ablation. On the other hand, if you have a person who has come to you post-MI, you have revascularized the patient, despite that he is having recurrent VT and VF, this is called electrical hibernation. That is, when you have a person with a large infarct, and most of our patients present after, say, about 12 hours, 14 hours, the myocardium is necrosed, but the Purkinje system surrounding the myocardium is generally resistant to ischemia. And so you have a surviving band of Purkinje tissue coursing through the myocardium, which keeps firing again and again. And that is the reason why you need to start looking at the coupling interval to decide and choose the medical therapy. And ECG to decide whether this patient will tolerate the drug that you're going to give. For example, if a patient has a low sinus rate with shock or a low, very prolonged PR interval, upfront you need to put in either an AV or a temporary pacemaker through the jugular into the coronary sinus so that you can make the atrial rate for hemodynamics. If they have significant mitral regurgitation or PAH, recurrent heart failure, have a very low threshold for inserting a balloon pump or sending them for a mechanical support. And the second thing is to identify what is the cause of this problem. Is it commonest is coronary artery disease? Of course, make sure that there is no residual ischemia. You should have adequately revascularized the patient. One subset which comes to our mind is hypertrophic cardiomyopathy. Please do not go by the ejection fraction in hypertrophic cardiomyopathy. When the HCM patients develop a EF of 55%, they already have significant LV dysfunction. Second, they don't tolerate, because they have thick hypertrophic septum, they don't tolerate tachycardia very well. So this, I'm sure all of you would have seen a patient with HCM, epicardial vessels are pristine, but he has a large anterior wall infarct. When a patient develops atrial flutter or fibrillation in patients with HCM, they develop severe microvascular ischemia and they can infarct the tissue. There's a lot of tissue acidosis there, and they can go into electromechanical dysfunction if you keep loading them with antiarrhythmic therapy. Of course, DCM substrate characterization is important. I'm going to dwell on this a little bit. First of all, your choice of therapy depends on whether its coupling interval is short, is it varying, or it's long. If you have a person with varying coupling interval, that is generally seen in coronary artery disease with residual ischemia. If there is no coronary artery disease, these patients are at high risk of sudden death. Even though you suppress the arrhythmia, it's commonly seen in two specific mutations called phospholamban mutation as well as a patient with LMNA mutations. Long coupling intervals are usually due to re-entry. This is what commonly you see, and they respond very well to a combination of lidocaine and amiodarone. Second thing is, when a patient is in the ICU, go back through the log and see whether the patient had VT, non-sustained VT, when the patient was fast asleep. During nights, nothing happened. When the patient is woken up to check the vitals and the VT starts, this patient will respond very well for sympathetic blockade. Whereas if a person has nocturnal arrhythmia throughout the night, you are wasting your time just by sympathetic blockade. So it's important to see what the periodicity of the arrhythmia is. And third is to look at the morphology of the PVC. We'll come back to this. Varying coupling interval, varying morphology, you may still think of sympathetic blockade. So most patients with electrical storm, they have significant structural heart disease, and you need to look at the common variety of triggers, for example, electrolyte disturbance, chronic amiodarone use and thyrotoxicosis. Some of our Ayurvedic preparations that they use contains digoxin-like alkaloids, and they can cause persistent, the clue is varying coupling interval, long coupling interval, and very narrow skinny PVCs. And they respond, this is predominantly activated by ryanodine receptors, and they respond very well to carvedilol and phenytoin. So I think I just wanted to kind of have a framework as to how to approach these patients. You need to correct the hemodynamics, have a low threshold for cardioversion, and start antiarrhythmics. Garden variety of recurrent VT and VF is carb-based re-entry. This is very predictable ablation now, close to 80 to 90% you can offer success rate. When the coupling interval is very short like this, when you give amiodarone, coupling interval PVC will still persist. You will only mechanically prolong the QT. These patients again will have recurrent VT, and Purkinje triggers can be easily gotten rid of. One subset in young patients with VT and VF is very often is channelopathy, and they are often admitted under neurology as seizure disorder and status epilepticus. The reason why this is important is sodium channel blockade that they give, like Eptoin, will worsen the problem. So this is a patient with Brugada syndrome where they were loading with phenytoin, and he had recurrent VT and VF, and he had to be taken up for an emergency epicardial ablation. So electrical storm has high morbidity and mortality, and most of the patients sympathetic blockade and sedation works well, and you need to sedate, mechanically ventilate the patient. If they are unstable, offer mechanical circulatory support, avoid QT prolonging drugs which can be pro-arrhythmic, and despite all these things, if patient has ventricular arrhythmia, have a low threshold for catheter ablation. Thank you very much for the patient listening.
Thank you, Dr. Narasimhan, for a splendid lecture. Can we have a quick comment from one of our panelists, if you want, or else we'll take comments from. So, any comments from any of the people sitting here?
Sir, can I have a question, sir?
Yes, why not?
Yeah. Sir, I have a question, sir. One patient actually in our hospital, he has a storm, VT storm, sir. But they are not interested to put a ICD. So they opted for the RFA ablation. So can we opt for the RFA ablation, or we should convince the patient for the putting the ICD further?
Yeah, because VT storm is one situation where you don't want to put an ICD. Within 2 weeks, the ICD will get depleted and he'll have recurrent shocks. You need to temporize the VT first, get adequate control of VT, whether pharmacologically, sympathetic blockade or catheter ablation, and then only offer ICD.
Thank you, sir.
Yeah. So mexaltine is one particular drug which has been proven to be very effective in combination with another class 3 drug. It's very safe to combine with a class 3 drug and mexaltine. For example, sotalol plus mexaltine, amiodarone plus mexaltine. Patients typically are the ones they respond very well, or post-CABG patients who go into VT storm after 48 to 72 hours. There's a distinct subgroup of patients. They respond well initially to lidocaine, and they can be discharged on mexaltine. And it works well. There's no, in fact, they are complementary to each other. Thank you.
So thank you, sir. Now we move on to the next speaker, Dr. P.K. Hajra, and he would be speaking on knee generation leadless pacemakers. Over to you, sir.
Thank you. I think in India, Dr. Narasimhan is the first doctor who introduced leadless pacemaker in the country, and we have Dr. Anil Mishra, who is my proctor for few, and Dr. Dilip Kumar from Calcutta. And I have done almost more than 150 cases so far, and Abbott one, please have my, Abbott one is the latest one. So this patient was having ICD done by Professor Mishra, Anil Mishra, and had got infections. And he had to undergo CLEEP, the LVAD, AR, etc. Ultimately, for 600 syndrome, he had a micro pacemaker implantations. The double chamber micra, you can have immediate AV conductions, but if you look at the lower bottom, if you take it as a hemo, once you puncture the femoral vein, you usually do not check the pressure of the vein at all in any procedure, except this large bore device from the femoral vein. If you attach your hemo, the pressure hemodynamics, with the 6 French venous sheath and gradually withdraw, and if you see a sudden jump, you should avoid that puncture. 100% sure there is anterior small artery we have gone through. The ultrasound cannot decide whether you have gone from this artery to vein. So this can avoid main complications like AV fistula and local hematoma. And the size of the pacemaker has gone down significantly from your conventional to 38 millimeter with Abbott. There is modification in the fixation mechanism. You have one helix and double helix in the atria. And when we got ourselves trained that you have to look at the RA and the RV, LAO and RO. So yesterday I have decided that instead of choosing the pigtail catheter, it's so cumbersome to enter into the RA appendage. The device itself is so easy to enter in the appendage. You flex this device and go to the LAO, and you can decide whether the appendage is there or not there, post CABG, it doesn't matter. You have to have certain amount of stump. If you have a device like a DDD pacemaker, you can look at the atrial pacemaker and you can go there. So the appendage, you usually choose the lower one, not the typical position of the DDD pacemaker. So apex is the red zone, green and green and maroon. And usually we go for either upgradation of your single chamber pacemaker or a atrial single chamber pacemaker for 600 syndrome. If you are really going into the ventricle, it's better to take this angiogram, whether doing AVR or micra. Usually the septum is the best place to place this pacemaker, put this pacemaker, because if you produce a perforation, you will have just small VSD. But if you go anterior, you will be devastating, because this AVR has a large screw or mechanism. So large screw can perforate the anterior wall and you have to call the surgeon. So this case, we have entered the coronary sinus. So I mean, abnormal courses of the micra or AVR or Abbott both, you should give some injection to the device. Now this device can take good amount of dye. So if you are going into the coronary sinus, you should avoid this. Now this is not playing anyway. So this previous video was, I have entered the left-sided SVC. If you have a left-sided SVC, it's really difficult to enter in the RV. This inadvertent entry in the LV, if you have ASD. So this device, it is flexible. From femoral vein, you can enter into the LV. So be careful. You have to check in different position. You have to inject. Now it is the fall from above. Most of the things can be done from below. But if you go from below, there is always a chance of kinking the device. Once you kink, the whole mechanism is lost. You have to remove the device and you have to massage the device again, so the kink is again comes back to normal shape. If you have any difficulty of negotiating this large bore device into the ventricle, you can take the help of the gooseneck, but usually it's not required. If you see this kind of kinking, better to take it out, understand the anatomy, take help of this gooseneck snare. You can put the gooseneck snares like TAVR or any other difficult device to entry or exit, and usually it is possible. If you are not happy with the position, or it has embolized, or it has got endocarditis or some dysfunction of the pacemaker, you can remove it by your same sheath supported by the Abbott company. It is very very easy to remove this device from the system. This is unique. They supply both the implantations and the retrieval sheath along with you, free of cost. The retrieval is free of cost most of the time. And you should go very close to the device. This is snare, and retrieval is possible. The same device can be put back on the same day if you have not damaged the screw. If you leave a hole, usually it heals, but there is a scar. And the latest is Ono. You know, this Ono device is not available in India. It's a game changer for any embolization in these human beings, whether it is TAVR, whether it is LA closure device, whether it is Micra, a bullet in the heart. You have any device from venous system or artery system. It is usually 12 French. You have a snare in it, and it comes in a basket. So these are very useful. I'm sure one day we'll see this. And once you put this device, usually on the table, you can have different programming. Either the ventricle can pull the atrial pacemaker ear, or atria can pull the ear of the ventricle. Both can be silent. One can be silent. One can be programmed to higher rate. Rest can be programmed to lower rate. For example, atria 60, ventricular 40, and vice versa. Extraction I have mentioned, 2 devices possible, up to 3 devices possible. So this patient I think had some dysfunction of high threshold, so we had to put second device after 6 weeks. That is only reported high threshold exit block so far in India. I have done more than 150, no embolizations, no death on the table. So there are some people who can do from superior vena cava, for example, interrupted IVC. You can usually go from the left or the right. If you have, like there are TTVR nowadays, you have to have most of the time right femoral access, but if you have a height problem of the TTVR device, you can from the left. Initial days, they are told that it should be done from the right femoral. We have done from the right femoral, left femoral, your jugular vein, or people have done from axillary vein. So this is the sweet spot on the LAO, and this is the sweet spot on your RAO. The device injection itself is temporary pacemaker for piggybacking. So temporary pacemaker usually can cause some ectopics. That is not warranted. That is not a usual. I mean, this is not the good thing for AVR, but it's a very good thing for a pacemaker support, because once you hit the septum, either you're doing a conduction system spacing. We have done around 300, more than 300 conduction system pacing, LVV pacing. And most of the time, if you hit the septum, patient can go complete asystole. So better to have this pacemaker support with Micra. It's not so required with the Abbott, because Abbott has got some backup pacing. This is completely different from the routine threshold checking. Initially, you get a lot of injury, but with time, it comes down. So if you get 4 threshold, you should not be bothered if your injury, myocardial injury, is very high. Whether it is atria or the ventricle, usually comes down maybe in the next morning. So there are different features of AV and this double chamber AV. This is the only pacemaker which is really double chamber pacemaker. And one life, one pacemaker is slogan from me. The single chamber pacemaker for 600 syndrome can last up to 30 years if you keep the rate at 45 to 50. So these are the things which are very beautiful with this leadless device. You know, it can be put through a tricuspid valve, mechanical valve, or tissue valve. It should be done from the jugular root. Now the next innovations will be leadless conduction system pacing. This is coming from Abbott again. As I mentioned, these devices sometimes difficult to find the proper area of left bundle branch pacing. So the leadless, this screw, it has a screw at the front of the device. This is the first case done in Sweden, and usually it is effective. Now, some of these pacemakers, both are Micra, and it has to be upgraded from single chamber to dual chamber pacemaker for AV synchrony in a patient who has got LV dysfunctions. So all these things are possible, different routes are possible, subclavian routes also possible. Jugular route is also possible. Boston is coming up with Empower, another leadless device. So friends, to summarize then, Abbott is the only leadless device which is really double chamber pacemaker. But if you put a double chamber pacemaker, the longevity comes down significantly. You have to know the algorithm, and the programming of the pacemaker is very important to improve the longevity, infections, dialysis patients, those who have thrombocytopenia, elderly people, frail people. These are the people who should have a leadless pacemaker. And you know, everything takes time. Google took almost, to reach 100 million users took around 78 months, and the Uber took 70 months, but TikTok took just 9, and ChatGPT took only 2 days to reach 100 million users. So friends, the leadless pacemaker is not my order for each and every patient. It will take some time to be the preferred pacemaker in all patients because it is costly. The cost is coming down, acceptance is increasing. The Micra Medtronic has crossed more than 1,000. Abbott has crossed more than 35 in dual chamber pacemaker. I hope the new generation will adopt to the new technique and technology to give the best benefit of science and innovation. Thank you very much.
Any comment from our panelists or any question from the audience?
Sir, I would like to ask, what is the acceptable threshold at the initial implantation?
Right. So if you have atrial, like if you have a paroxysmal A and you have put a atrial pacemaker, need not bother about this threshold. It can come to sinus rhythm because on atrial fibrillation you cannot get the threshold. So you have some experience leaving the pacemaker, atrial pacemaker, irrespective of the threshold. Usually it comes back on the second day or third day. The ventricle, if your current of injury is very high, you have a high impedance, then on the table you check from 0.4 to 1 millimeter, then 1.5 millimeter pulse width. If it comes down to 2 to 3 minutes, you can just leave it there, high threshold, 3 volt or 2.5 volt. Next morning, you can see a 0.25, 0.5. So it is very unusual to have those kind of high threshold remaining on 24 hours. So it's a completely different mechanism and the physiology of AVR or Abbott. Usually comes down.
So thank you very much, Dr. Hajra.
Yeah, thank you.
Can I request Dr. Rajit to summarize?
Yeah, sure. Thank you so much. Thank you to all our speakers, Dr. Das, Dr. Ponuswamy, Dr. Narasimhan, Dr. Hajra, for the exciting talk and the road ahead for some of those challenges that we discussed. And we look forward to future deliberations in the same field. Thank you so much. And we move to our next session, which is on radial intervention.
In between we will be having felicitation of all the chairpersons, speakers and panelists, and then we will move on to the next session. So I will request Dr. Ajay sir to felicitate our chairpersons and our panelists and moderator. Dr. Poppy, she's our moderator. Dr. Mitu. Dr. Suven. Dr. Rajan Narayan sir. Dr. Suman. P.K. Hajra, sir. Dr. Narasimhan, sir. Dr. Kushal Vikram. And I will request Dr. Raja Narayan sir to felicitate Dr. Ajay Kumar Sinha sir. So next session we will be starting for radial intervention. We have Professor James Nolan with us. He is a pioneer for radial intervention, and for that to moderate this session I will be having Dr. Shaheen Ahmed. For chairpersons I will be having Dr. Ajit Mulasri, Dr. Pramod Kumar, Dr. BP Singh sir. As a panelist we will be having Dr. Dipankar Das, Dr. Jyoti Karn and Dr. Tutan.
देने के लिए टीवी पे देने बोलिए सर दिस
Very good evening, very good morning. We have our speaker, Professor James Nolan. He is a leading figure in UK cardiology, serving as a professor of intervention cardiology at Keele University and a consultant at University Hospital of North Midland NHS Trust. He is one of the UK's foremost experts in intervention cardiology, combining a busy clinical practice with an active research program. Professor Nolan is particularly renowned for his work promoting the use of transradial access for coronary intervention, a technique he helped stimulate major changes in UK practice, leading to a significant patient benefits. Now hand over to our chairperson to start the session.
It's really a privilege for all of us to have someone like Dr. James Nolan present here. And it's a little strange that we are talking about radial. You know, everyone accepts and feels that we know everything about radial. But I had a little discussion with Dr. Nolan, and I learned so many things. I have been practicing radial for the last 35 years, but still there was so much to learn. And I'm sure Dr. Nolan will enlighten us and tell us the fine art of transradial interventions.
Okay, thank you. It's a real pleasure to be here in your fantastic country. Thank you to the organisers for asking me. So this morning I'm going to talk mostly about radial access complications rather than the radial technique itself. Can I have the slides up, please?
Can we have Dr. Nolan's slides, please?
Thanks. Do you know how to get rid of the presenter view for the presentation? Sorry. That'll do you. I'm happy. Yeah, that's fine. Okay, thanks. So yeah, radial access complications. So I mean, there are lots of different radial access complications, but what I will talk about this morning are the more significant complications, those that require surgical or interventional radiology intervention, ones associated with hemodynamic disturbance, hypotension, needing a blood transfusion, complications that cause limb ischemia or neurovascular injury or even death, and those that prolong hospital admission. So the first question is, how frequent are these type of complications in radial access? So this analysis of almost 13,000 consecutive radial procedures by colleagues in Italy found a significant radiovascular complication rate of 0.5%. And this is exactly mirrored in this meta-analysis of 7 randomized trials of almost 11,000 patients. They also found a significant radiovascular complication rate of 0.5%. So you can expect to see these events in about 1 in 200 patients. If you have a large radial program, you are going to see significant complications. Going back to the Italian study, the most common complications were hematomas and pseudoaneurysms. These account for 50% of the significant complications. Most of them, 80%, can be managed conservatively, but life and limb-threatening complications do occur in up to 1,000 patients. This is a perforation of the radial artery, and when you get a perforation like this, you can have uncontrolled bleeding and a forearm hematoma. Hematomas are categorized into grade 1 to 5. Grade 1 and 2 hematomas are distal events located around the puncture site. Grade 3, 4, and 5 hematomas are much larger episodes that involve the whole of the forearm. These are the type of factors that increase your risk of having an important hematoma. They're more common in females. They're more common if you have a patient with intensive antithrombotic therapy. Multiple puncture attempts are associated with hematoma formations, complex procedures, and having a prolonged hemostasis time. In contemporary practice, hemostasis should be complete after 2 hours for most of your patients. Most hematomas in this study from India are distal, localized to the puncture site, so grade 1 and 2, and related to hemostasis failure. The frequency varies depending on the patient population that you're treating and the operator expertise. So less experienced operators have more hematomas, and hematomas are more frequent in complex patients. They tend to present early, within the first 1 to 4 hours, and then managed distal hematomas by repositioning the compression device. And to do that effectively, you need to blow a blood pressure cuff up on the arm to stop antegrade blood flow and then reposition your device. Proximal radial perforations are a different matter. We've written about treating these by tamponade with catheters. This is a patient with a large perforation, extensive bleeding around the antecubital fossa. Early on, I used to stop procedures when I saw this, reverse the heparin, elevate the arm, apply compression, and plan to do the procedure again on another day. Now we cross the perforation with an angioplasty wire, use balloon-assisted tracking to deploy a catheter distally. The catheter itself will then tamponade the tear in the vessel. And this is the picture at the end of the procedure. It's completely sealed. Catheter tamponade may fail. We tried tamponade in this, we knew there was a perforation in this patient at the beginning of the procedure. We performed the procedure, but at the end, there's a very big bleed here. And this will lead to a compartment syndrome if it's not actively treated. The way to treat these is with a coronary covered stent. So you can see the stent being deployed here, and in the right-hand picture, you'll see the end result, complete sealing of the perforation. So radial arteries are usually in the range of 2.5 to 3.5 millimeters in diameter, and they respond very well to coronary covered stents. If you have uncontrolled or unsuspected proximal perforation, then you will end up with this kind of situation. The entire arm is swollen. You can see the beginning of ischemic changes in the fingers of this patient. Large grade 3, 4 or 5 hematomas are rare. Incidence rate is probably about 1 in 5,000 cases, and they relate to uncontrolled bleeding into a closed forearm compartment. This leads to an acute rise in compartment pressure. It impedes venous flow, it impedes arterial flow, and you can get irreversible vascular or neurological damage within 4 to 6 hours. So this is an absolute limb-threatening emergency. They present with extensive swelling. The patient usually has severe pain. There are variable neurological symptoms, including paresthesia and sensation loss, circulation disturbance with loss of pulse. If the pulse disappears, it's very late in the stage of the disease. It's not something that happens until you've got severe compartment syndrome, and it is a limb-threatening emergency. So the immediate management is to call your senior colleagues in. If it happens in your cath lab, it's not something that the nursing staff or the middle grade or junior doctors can deal with. You can immediately inflate a blood pressure cuff to systolic pressure minus 15 for 15 minutes. It's not very easy for the patient to tolerate though. And consider reversal and withdrawal of anticoagulation. And this is the way that you manage a blood pressure cuff inflation, 15 millimeters below. I have to tell you that this is a potentially dangerous thing to do because it rarely will completely seal a large perforation. This is a case report in which repeated attempts were made to control a perforation by blood pressure cuff inflations, leading to irreversible neurovascular damage in the hand. So if you suspect a compartment syndrome or uncontrolled bleeding, you need urgent consultation with the surgical team. It may be the vascular surgical team. It may be the orthopedic team in your hospital. It depends who normally deals with compartment syndromes. They can directly measure the pressure in the compartment with a manometer and a small needle. And if the pressure in the forearm compartment is greater than 30 millimeters of mercury, then that is an indication for emergency surgery. This is how you treat a developing compartment syndrome, by fasciotomy. Another way to treat it is with medical leeches. I mean, you probably have them in your hospital. They exist everywhere. If you don't manage it well, this is what happens to the patient's arm. And I know of cases that have led to an amputation. It's also important to note that 54% of the patients need repeat surgery, and 25% of patients with an upper limb compartment syndrome die in hospital. This is a radial pseudoaneurysm. You can see here on the ultrasound, there's a thrombus containing pseudoaneurysm with flow. This is a CT reconstruction of another pseudoaneurysm. They can be very complex. This one is multilobular. You can see that it can be difficult to treat these by local procedures. They're associated with multiple radial punctures, big sheaths, intensive therapy, antithrombotic therapy, and poor hemostasis technique. And they usually present a few days after the procedure, on average 5 or 6 days. They can usually be managed without any long-term effects, and half of them can be managed with local compression. And here is it can be very difficult to compress the neck with an ultrasound probe. It's painful for the operator and painful for the patient. In this technique, you deploy a TR band either side of the hematoma, aspirate the blood with a needle and a syringe, and place a third TR band to compress the pseudoaneurysm puncture site. It's not always possible to do that. This is a pseudoaneurysm from our center that didn't respond to local compression. And once again, a coronary stent can be deployed, 3 millimeter covered stent with full resolution of the pseudoaneurysm. They can get very big if they're not treated. This one is eroding through the skin. You can see why surgery was needed in this case. They can have local neurovascular pressure effects. This is an ischemic hand. Hand ischemia is about 1 in 10,000. Patients present with pain, paresthesia, pallor, discoloration, absent pulses, swelling, temperature loss, and it can progress to severe injury, as you can see in this patient. This is a case series of hand ischemia cases after radial cannulation. They were most common when a complex procedure was performed in a complex patient, particularly patients with connective tissue disorders. In every case in this series, the Allen test was normal pre-procedure. The Allen test tells you nothing. The treatment options, you need to urgently review the patient with your vascular, surgical, and interventional radiology colleagues, assess radial flow with ultrasound or vascular imaging, consider anticoagulants and vasodilators. Thrombolysis has been proposed for some patients. A nerve block may help, or revascularization. This is a recent series showing that you can successfully revascularize the majority of occluded radials by a distal radial puncture with a low complication rate acutely. You have to be aware that reocclusion is quite common in these patients. Here at 29 months, 3/4 of the radial arteries are reoccluded, and usually the distal radial occludes at the same time. So it's not completely benign to try and reopen these. 1/3 of the patients with acute hand ischemia will end up with an amputation. Intrathoracic vascular injury, it's not something I've ever seen, but it's reported to occur with an incidence rate of about 1 in 1,000. Patients present with unexpected and unexplained chest pain and breathlessness. They may be hypovolemic, dysphagic, normal routine investigations. You need to confirm it if you suspect it on a CT scan. A common precipitating factor is subclavian tortuosity. I caution you against using straight-ended hydrophilic wires in those situations. In this series of 10 intrathoracic bleeding events, every single one was related to the use of a straight-tipped hydrophilic wire. If you're going to use a hydrophilic wire in a case of subclavian tortuosity, then the baby J wire with its loop tip is much safer. You can see here the hydrophilic wire has entered this superficial branch, and this resulted in a large expanding external hematoma, 6 centimeters in circumference and diameter on the CT scan. In this patient, the bleeding occurred into the pleural space, and in this patient, all this grey matter that you see on the CT scan is bleeding into the mediastinum. The purple arrow points at a ET tube, which is the only thing that's allowing this patient to breathe. If you suspect intrathoracic bleeding, then you have to secure the airway, transfuse the patient, stop the anticoagulants. You need an urgent CT and intravascular imaging to make the diagnosis. You can coil or covered stent bleeding points if you can see them. Sometimes the hematoma will tamponade the bleeding point itself. If the bleeding can't be controlled, surgery is an option, although I don't know anyone who's ever done that. This is a patient with a big extrapleural hematoma. The operators had passed a straight-tipped hydrophilic wire down the internal mammary artery, caused a bleed here, which was successfully coiled using intracoronary coils. Just the last couple of things, catheter kinking can occur. These are the types of kinks we occasionally see in patients who have subclavian tortuosity. It's associated with difficult catheter manipulation, vascular tortuosity. If you are dealing with a patient with those factors, then I advise that you put an 035 wire into your catheter before you get the kink. Or consider changing your access site. For subclavian tortuosity, it's 4 times more common on the right side than the left side. So if you're having that problem, you can switch to the left arm. Loss of the pressure tracing indicates kinking. You need to rotate your catheter back. You can usually get an 035 wire into it. There are lots of ways that have been published to treat a kinked catheter. My advice is to do a puncture on another access site, a femoral or the other radial, and use a snare to catch the top end of the catheter. You can then fix the top end of the catheter, and by pulling on both ends and rotating the catheter slightly, you can undo the kink. As you pull, it will come out, and you can then retrieve the catheter. You can get catheters trapped in patients with severe spasm, vascular anomalies, where you've had excessive catheter manipulation, big diameter equipment, particularly in complex procedures. The sheath here, these are both 11 centimeter sheaths. The one on the left-hand side has been forcefully retrieved and elongated. You can also rupture the catheter. And if you do that and leave a catheter segment behind, you will inevitably get infection, and the patient will need an operation to remove those catheter segments. If you pull really hard, you can avulse the radial artery. This is a real problem. If you pull the radial artery out, you're going to get uncontrolled bleeding. So if you have a catheter trapped, you have some options. You need to sedate the patient as heavily as possible with a benzodiazepine, give intravenous powerful analgesics, set up a nitrate infusion to dilate the vessels, give some intravascular calcium antagonists, put a warm dressing on the patient's arm. The most important thing then is to go away for a while, go to your office and have a coffee and wait for the treatment to start working. Because if you try to pull the catheter immediately, you'll reinitiate the cycle of spasm. If those things fail, all 4 cases in this series responded to intravenous doses of papaverine, 3 milligram doses. It's a powerful alpha blocker. Another option is to try and use flow-mediated vasodilatation. You blow a blood pressure cup up, you leave it up for a while, you let it down, you will get dilatation of the vessels. If those things fail, regional nerve block in the axilla can relax the artery. If you've pulled the radial artery out, there's a big risk of a compartment syndrome. People have managed it conservatively, but if there is active bleeding, you have to use the strategies we discussed earlier with blood pressure cuffs and look to coil occlude the proximal segment of the artery. If that doesn't, from another access site, if that doesn't work, your only option is surgery. Okay, so major radial complications are infrequent. They can be avoided by best practice procedures. When they occur, early senior review and active management will minimize the risk to the limb and the patient. Most of them can be managed without detriment to the patient. Hand ischemia and compartment syndromes, they're dreaded complications, and they are major limb and life-threatening issues that need urgent multidisciplinary management. And when you have unexplained hypotension, post-radial access, consider concealed intrathoracic bleeding. It's the radial operator's equivalent of a retroperitoneal hemorrhage. Thank you.
I think that was an excellent review of all complications can go through radial access. And I think each of these, some of us must have seen who are good large volume radial operators. Some of the other techniques which can happen when you coil a catheter in the, not inside the subclavian or in the axillary, but if it's lower down, is to just tie a BP arm proximally, inflate the pressure so it acts like a sort of a snare, and then gently straighten it out and pull it off. The second issue is I've had once to use a median nerve block to get the catheter out, just to relax the spasm. So that could be done. And I think we have to say that we should not be very, radialists all the time and move to the femoral. Right now with ultrasound access and micropuncture, the chances of major problems even in femoral access is very low if you can do it safely. So.
Yeah, if the kink is low enough down, the blood pressure, or you can just press approximately, you have to fix both ends of the catheters, otherwise they'll simply rotate. And you make a good point there that some people are better off with a femoral puncture. There was a recent case series presented at TCT recently of doing radial procedures in people with advanced Raynaud's disease and connective tissue disorders. I would never do that. I would do an ultrasound guided femoral puncture because the risk to the hand in a patient like that is severe.
Yeah, it's a beautiful lecture, I would say, after a long time. Now, you know, most of the complication, what you have shown here, either the artery size is very small, the high origin of the radial artery, or your artery has become small on the table because of the vasospasm.
Yeah.
So my question is, do you have any access to papaverine in your country? And if you have you ever used papaverine? Do you think which is the best vasodilator to use for vasospasm?
Yeah, so if I do my talk on how to do a perfect radial procedure, my advice is to do an arm angiogram after you've placed the sheath, because almost 15% of people have an anomaly, and it's better to know about it before you provoke the cycle of spasm. And the commonest thing you find is a high bifurcating radial. You saw that in one of the angiograms. It's better to know about those things and deal with them proactively before spasm and a complication occurs. So if you get into the cycle of severe spasm, we do have papaverine in the UK, we can get it, but usually it will respond just to a nitrate infusion, some intravenous verapamil, and the other measures of allowing some time, giving the analgesia, etc.
Right, so we have an experience of more than 50,000 radial, never seen any entrapment in last 20 years. Since we have started papaverine routinely, not nitroglycerin, just heparin, not verapamil, only papaverine. If you feel any spasm, catheter is not going, you inject papaverine, wait for some time, it works wonder.
Yeah.
So 30 milligram papaverine works like magic in radial regrets. And if it still fails, go for femoral.
Yeah, so if you only remember one thing from this talk, it is that papaverine is there and it's highly effective. I mean, most of those pictures, they're not my patients, I have to tell you that, and I haven't seen most of those things, but they do occur, and I've collected them over the years from other people in the centre.
Do you use papaverine intravenously? Because we tend to use intraarterial.
Well, I don't know the answer to that. When I've seen it used in the UK, I've called the vascular surgeons up because they use it in their practice. I can't honestly tell you whether it was IV or intraarterial. I don't remember the answer to that. I've only seen it used once or twice. Intraarterial, yeah. Yeah.
So most of the cardiac surgeons, the team will have papaverine on their shelf. Yeah, almost everybody. And again, you know, in almost, so if you have an active cardiac surgery team, they will always have papaverine on the shelf. Again, almost same numbers as Dr. Hajra said, 40, 50,000 radial interventions. I have used it only once. Never used, and that was almost 5-6 years ago. And we use frequently 7 French in radial, and with the complex, angioplasties. Rarely we go for a femoral. Even these days, the femoral has become much safer with the ultrasound guided puncture. So I think it's very important that you, the use of the new glide catheters, 6 to 7, 5 to 6, has made life very easy for using large size guiding catheters. And the complication rate again has come down tremendously.
Finally, a simple step, especially when training fellows, is watch your guide wire when you're putting a radial line. Some people just blindly push the wire and go somewhere, and especially these hydrophilic wires can perforate anything. So I think we need to be careful.
Yeah, this is a hydrophilic wire should be avoided because it can go anywhere. So if you use metal everywhere, the chance of hematoma, small vessel hematoma is very less.
Straight-tipped hydrophilic to rheumatoid wires are a menace in the radial artery because you get no feedback from them. You don't know if you're pushing them into the wall. You don't know if you're in a side branch. You would think it was impossible to put the wire down the internal mammary artery and not know about it, but it runs alongside the heart, so you don't get the radiological clues. The baby J wire, however, is a fantastic radial piece of kit. The loop on the tip stops it doing all of those things, so you maintain the hydrophilicity, the deliverability of the wire without the risk of the straight tip. So, there are other wires as well. There's an Asahi wire, which you can get, which has a similar tip and a lubricious coating. So, yeah, beware of the straight-tipped hydrophilic wires in radial cases. I mean, I've done radial angioplasties and angiograms since 1996, and I haven't seen most of these complications in my practice, but they definitely occur, and you need to, if you know a little bit about them, you'll be more tuned into picking them up when they happen, and will be able to deal with them proactively and stop the progression to severe hand injury or even an amputation.
Another thing that we must practice is keep a very, very low threshold for doing an angiogram. Very important. If you are facing even slightest of difficulty, a quick angiogram will, in most of the cases, it will solve your problem. You know what you should do and what you shouldn't do.
The last point, nowadays, you have mentioned the BAT technique by Tejas Patel, who has introduced this technique. But most of the time, we do not do this. Just use a mother and child, like 7, 6, 6 and 5, or a microcatheter, put the wire, and usually works. It can navigate the tortuosity. So BAT technique usually fails. Most of the time it fails, but the mother and child usually never fails. Newer technique, light shide, newer catheter can help to reduce the complication and spasm during the procedure and after the procedure.
Yeah, so my last point would be that, if you're a radial operator, you can still have devastating complications affecting your patients. It doesn't absolve you of the need to do everything with an optimized technique and to do everything carefully and to be tuned in and to look for those rare but devastating complications. Thank you.
So we move on to the next session. We will be having in between the felicitation. So our next session, we will start with left main bifurcation and imaging. We will be having 2 masters presentation and then 2 case presentation. The case presentation will be a hybrid kind of case presentation. The first presenter will only show the case summary and angio slides. And after that, the second presenter will show us that how he will do the case. Then finally, the first presenter, he will be presenting that how he has done the case, the complete case he will finally sum up. So for the next session, I will be calling our moderator, Dr. Anil Mishra sir. Chairpersons, we will be having Dr. Vijay Trehan sir, Dr. Nishant Tripathi sir, and Dr. Neerav Kumar sir. For panelists, we will be having Dr. Aditya Bhaskar sir, Dr. Amit Singh, and Dr. Meetu Kumari, if she is available here.
Well, it's indeed a pleasure.
So, Dr. Meetu is not available. Can I request Dr. Chandramanu Chandan to panel this session? Over to Anil Mishra, sir.
Thank you.
For moderation.
Thank you. It's indeed a pleasure to moderate this session of left main stem. We know some of the last bastions of coronary interventions have been left main interventions, bifurcation on top of that. And we have none other than Dr. Vijay Trehan, who is well known to everyone in the country, I suppose. You go to any cardiac conferences, and there's any problem, Dr. Trehan has a solution to that. So he's a master of masters. So it's a pleasure to have him here. And the other talk will be given by Dr. Pramod Kumar. We don't need his introduction to this audience. Everybody in the town and the country, and of course the state knows them. Following that, we have a very interesting 2 cases, so there will be a lot of interesting discussions. There are a number of ways of doing things, so we'll come out with many options and discuss advantages and disadvantages of each of them. With not much ado, I would probably change the order of this talk. We have Dr. Ajit Mulasari. Now, Dr. Ajit Mulasari is again one of the big stalwarts in the country. The STEMI program of Tamil Nadu has really been a very hard work done by him and path leading thing. So can we request Dr. Ajit Mulasari, who is again one of the pioneers of establishing STEMI programs in the country and has done a lot of other work in Madras Medical Mission and South, to take this talk on artificial intelligence as an adjunct to modern coronary imaging. We know artificial intelligence is coming in all fields, medical fields, in technology it is coming very faster, but for physicians, I think it may take a little longer to adapt to it. But in practical uses of cardiac imaging, this is really coming in fast, and we will probably have much easier life with these artificial intelligence thing helping us in analysis. Over to our chairpersons, Dr. Nishan.
Okay, so I've been asked to stand in for Rishi by Dr. Shamshad a couple of days ago, and I'll try my best to put this very quickly in. What is artificial intelligence, just to start off with, so it doesn't confuse people? So when you use routine intelligence, you know an input into your mind which has been trained, and you make a diagnosis of something which you have learned or you have trained with. In machine learning, the exact same thing is put onto a machine which responds in the same way. The next phase is deep learning, where the machine not only uses its intelligence, but it takes everybody else's intelligence which is available on the internet and makes a diagnosis. And artificial intelligence, which is the next phase, is it tells you what to do, which you may be wrong with your natural intelligence. Most of what we do today is in terms of artificial intelligence, is in learning about imaging. Now, when you look at imaging, and I'm asked to speak specifically on intracoronary imaging, today OCT has, and I'll talk on 2 things, OCT and intravascular ultrasound very quickly. OCT has class 1A recommendations for complex lesions, and these are the 2025 and 2024 guidelines for recommendation, and these are based on many trials, and these trials are basically based on subset analysis of the Illumin 4, the October trial for bifurcation lesions, and the Renovate Complex PCI for intravascular imaging. So basically, we now have clear evidence that by doing imaging, you're going to help your events rates, death and MACE, by using imaging, which was not so till about a year ago. Now, the next issue is, what do you measure on imaging? And in OCT, you measure what is called as MLD max, and I'll tell you what it means. It simply means how much of lumen and diameter you get after pre and post imaging in terms of decision making. Now, what is important is that if I use OCT and imaging, pre-PCI, some people say, oh, you need it only post-PCI. That's not correct, because 80% of the impact of imaging happens by a pre-PCI imaging, and 31% comes out of post-PCI OCT, and overall, there's an 86% advantage in MLE max. Now, in a pre-PCI, where do you use artificial intelligence? And I'll tell you how it does this. We were manually measuring all these the morphology of the lesions, the length and the diameter pre-PCI, and strategizing our strategies. Post-PCI, we run it for optimization for MAX, which is max, and totally we call it MLD max. And what we watch for M is medial dissection, A is for apposition, and X is for expansion. We were using this manually, putting the dots together, measuring those areas, looking for dissections, looking for lengths. But today, life has been made very easy. It's like Windows for dummies. You just put the artificial intelligence Ultron 2 package, you co-register, and you'll get this very simple image, where it starts, where is the end, what is the normal area, what is orange, which is calcium, what is white, which is the EEL, and what is the lumen, and all your measurements are there for you to see. So clearly what has happened is that the artificial intelligence has taken over what you would have manually done. It also gives you the morphology of the lesion. Look at this orange on the outside. That's where the calcium is. So you know where in the artery, in which part of the artery, and you have co-registered this so that I can clearly see where in the artery is calcium and where do I need the debulking device and where I should not use the debulking device. We also know the arc of the calcium, though I have to say the artificial intelligence is set to 180 degrees calcium, so sometimes if it is low calcium you may not see it and you have to change it. But very clearly you can shift in an Ultron 2 from an artificial intelligence to normal intelligence where you can make your measurements even normally. So again we measure the lengths, the diameters and the morphology. We can strategize by a score of calcium. Where there is high calcium, we know it's 180 degrees calcium with longer lengths, 0.5 millimeter thickness, 360 degree calcium or 5 millimeter length. And we have these various scores. The recent score is all of 5, and clearly we have a score of 3, which we can tell you that is calcium, and a score of between 2 to 3 shows you may require a debulking device, which could just be an NC balloon, a cutting scoring balloon, arthrotomy, or lithotripsy. And this is how the image looks like again, clearly where the calcium is, what to do, etc. There's instant visualization of calcium. I know in this whole length where is the calcium. And I can see it co-register where is the calcium. So clearly we can make out very, very quickly where the calcium is. We also need to know the morphology, and clearly it gives you very clear pictures of what is lipedic, what is fibrotic, what is severe calcium, and what is mild calcium. And I told you about the scoring. You can measure the thickness is 0.5 millimeters or more. It's 1 point. If it is an arc which is 270 plus a length, it's 1 more point. And if the thickness, which is the most important thing in my opinion, is more than 5, it means there is an issue. Nowadays, we know that from 3 onwards to 5 to 8, there are various debulking characteristics which we could look at. Again, for the MLD max, I told you, many of the times we cannot visualize the EEL on the OCT visually, manually. But the AI looks at it very, very clearly and gives you where the calcium is, where the EEL is. The EEL is the one which is seen in white. It also gives you the lumen diameters. You can see the proximal is 3.65, 2.75 is the EEL, and the lumen is 2.59 and 1.66. So clearly, we know clearly what is the lumens. We avoid the plaque burden more than 50% sites, we avoid the TCFAs, and we avoid those areas where it is. So in the live image, it looks like this. You can see very, very clearly in artificial intelligence, you can see the calcium very, very quickly, and you can see what is the arc on throughout the lumen. We can play it back and forth. We can see where it ends, and it's very, very simple now for an operator to decide where to start, where to end, what balloon to use, where not to post-dilate and get into trouble, and what size of stents to use. So the pre-PCI OCT we use to look at EEL or lumen. If we measure EEL, we downsize to what the next round figure. If it is a lumen that we use, we upsize to the number. So if it's 3.1 with the EEL, we go to 3. If it's 2.8 with the lumen, we go to 3. So this is how we use the lumen or the EEL for making the measurements. Again, as I told you, there's an automatic white picture, which you can see on the Ultron 2, which shows you where the EEL is, and the measurements are made from that. So an AI-enabled EEL detection is shown by a white dash, and instant visualization of these could help for lumen diagnosis. Now, the very important thing which I use on Ultron 2 now is the calcium detection, which I know is here and here when I co-register. So if I use a cutting balloon, I will use it here, or an IVL here, or IVL here, and don't use it somewhere near that, because I clearly know for sure where the calcium is on the imaging AI tool. We also get a dynamic angio, and I'll show you how that looks like. This is how we do the picturization. We pass the OCT catheter, we co-register it, and then we move, we magnify it. You can see beautifully how the artery can be seen. We place our zooms properly, we make our measurements clearly, and then we measure where the calcium is, what is the length, and what are the diameters in this patient. So the MLD max of Ultron post will also tell you how the artery has been treated. It will show you if there's any medial dissection. The apposition will be seen as these yellows. You can see these yellows. If they are malopose, if they are more than 3 millimeters off, you may need to do post-expansion of these stents. We also will look for stent end expansion. In general, for stent expansion, I want a MSA of 80% of the mean or 90% of the mean, which is optimal and acceptable. In Illumin 3, we use 80%. In Illumin 4, we use 90%. But remember, common sense has to override this. If you try too much, you may land up with a rupture. We can access the post-treatment stent in one shot. What I also like it, we can get a screen review. As I told you, you can see malposition highlighted in yellow, under expansion, which is in orange, where it is. We can see it here very, very clearly. And we can also have a comparative pullback. I can see the pre and post on one screen as to what I did. So what AI has helped is basically, at least at this stage, helped in calcium with the Ultron 2 software. It also is very good for the bifurcation, especially for the left main, where a wire is crossing the stent. So we need to have, whether it's proximal or distal. And finally, for intravascular ultrasound, a similar assessment tool has come with Avigo, and where you can see the we can see the pre-lesion, we can see what is the type of lesion, we can measure the diameters, we can measure the lengths, we can know the minimum, and we can just pick up the vessel lumen diameters, vessel profiles, and a minimum key prefema, place the proximal and distal, and measure the lumen area at the center, and measure the overall area. So what has happened with machine learning and today is that imaging in intracoronary is shown to be superior than a physician-based practice. Many of the trials non-inferior, but at least in calcium, it's shown to be superior. And finally, we'll have the next phase of Ultron 3, which will have acute coronary syndrome being added to the whole thing. The true potential for machine learning is just happenings, and the Ultron 2 was done with 9,000 images. And we are now on a large study with many of the OCTs and intravascular NIS of a global 10,000 study of trying to help the AI use this whole thing. It also in the Avigo shows confidence border, because beyond the calcium, sometimes you can't see on an IVUS. This really traces out the border of the whole thing. So let me conclude by saying this: has artificial intelligence come mainstream? The answer is yes. Has it completely taken over? No, because you need data quality and standardization, validation, and evidence. I think AI will not replace humans, but humans who have AI and knowledge of AI will replace physicians who do not have that knowledge. Thank you very much.
Thanks very much. I think it was an elaborate explanation of what is today, as far as intelligence has become artificial. The stupidity is still original. if we go back as far as AI is concerned, I think all of us had been using AI in the ECG for the last 40 years or so. It tells you what's the heart rate, what's the QRS, duration. Nowadays, if you have to send a patient for or choose a patient for CRTD, then you're always looking for the duration told by the AI. And in fact, many of the things which sometime you can miss, AI will give you there in the ECG interpretation. And as rightly said, that that interpretation doesn't rule out that you will read the ECG for yourself. But I'm sure Ultrasound 2 is going to be the way to do an intravascular imaging, and I'm sure at least at this point in time, ultrasound is not able to keep pace as much. So it's going to make our life relatively simple, but I'm not very sure whether it will really translate into the clinical benefit, because so far we have not had any trial to show that. So thank you very much.
Any question from the panelist?
How much is the sensitivity and specificity of these artificial intelligence compared to the humans?
So the previous slide, I did show that it's about 98% specific as compared to cardiologists with 20 years of experience and at least 5 years of experience with OCT. So we can't doubt its capability, at least for calcium today. Not for yet for ACS, that's what Ultrasound 3 software will give us and many other technologies. But I think AI is going to be there. But I think the biggest danger of AI is the de-skilling of cardiologists. Because once you start depending on a machine to give you an answer, then you de-skill yourself, and when the real problem occurs, you don't know how to read it's simply like an ECG. Everything is going to give you an answer, nobody will read the ECG, and that's the problem.
That's just like if you have missed your phone, you don't know the phone number of your brother or anything. So you're de-skilled. Right? Previously, we used to have diaries in our pockets and at least remember some of the numbers by heart. So that will be one of the, I think, but I think it's going to have.
Yeah. For simple listen, I think the common sense and the simplicity will be superior than your AI and computer intelligence. But for complex lesions, complexity, definitely the AI will be superior than human being. So my question to you, how often the algorithm misses, the AI misses the MLD max? For example, if you have circumflex austere, severely calcified, venous graft, post-CABG, non-crossable lesion, C2, how often your algorithm fails?
That's AI, I think.
One of the limitations of AI is hallucination, which we are witnessing right now. That is one of the limitations.
Audiovisual team, can you stop the sound? Hello? Hello, audiovisual?
Can you put the sound? There's some sound coming from sound.
I think where artificial intelligence is score over the human intelligence is where there's large amount of data to be analyzed. There are multiple points here. That is where vast data is there. They can analyze it more accurately than a human mind can. But when it comes to one practice, one-to-one, then of course human mind is always going to be superior.
I think I agree with you, and I think that AI will depend on data sets. So like vein graft and other areas, we still don't have data sets which have helped us. But I really think, I was just fortunate to have the guy who got the Nobel Prize on AI talking about whether it will change cardiovascular medicine at IIT. And he simply said, even if you think a doctor will have more empathy than a machine, the answer is no. There's a large randomized trial of oncologists speaking to patients about end-stage cancer versus the machine, and the patients found the machine more empathic than the doctor. So I think that there's a day when it will all change, and maybe we have to be very, very clear that this will happen. Yeah.
Right, thank you very much. And now we have another talk on left main intervention, how to deal with LCX. I think we have Dr. Pramod Kumar who is going to address this. There's a little change. So Dr. Pramod Kumar will be addressing this issue. It's a very important issue and much talked about. The number of trials, I'm sure we'll hear all about them and learn something from Dr. Pramod.
So never seen Vijay Trahan backing out. this is the first time that he said, no, I won't do it. So, you know, as a last minute backup, I have to do that.
No, I can take the challenge right now.
Please do it. Please do it. See, he's 1 year junior to me. But, you know, the amount of work and the amount of skill which he has is far superior than mine. So I actually always, you know, seek his guidance when there is a problem.
So let's do a duel.
Yeah. So let Vijay do it. I don't mind it.
No, let's do a duel. I mean, once.
I think a whole cardiology community in the country knows Dr. Vijay Trehan. You have any sort of complication, any sort of problem, he always has several answers for them, and he has all the tricks to bail out from all situations. So he has a very vast experience, and we all respect him for that.
So I in fact had a preparation.
Can we have it on the screen? So what I'll do, I'll quickly show you a few slides and 2 cases, and then I'll hand it over to Vijay to take it forward. So quickly, why is LCX important when you're doing left main angioplasty? This is the data from the EBC main trial, which showed that the Achilles heel of left main is a still circumflex, and 61% of the problems have actually occurred over a period of time in the LCX artery. So with that in background, how do you deal with it? You know, the left main angioplasty is again, like what Dr. Mishra said, that is one of the last bastion which still needs to be conquered. We are still evolving, and it's a work in progress. So this is a simple algorithm which we feel that if you feel that your side branch or main branch is going to be compromised when you do it, you go for a 2-stent strategy. But if you feel that it's not going to happen like that, provisional strategy is probably the best. You have, you know, even in provisional, if you have problems after you have done you can bail out with different techniques. So some of the ways to define the complexity of the left main, one of the criteria which is used frequently by the Chinese people is the definition criteria. And for left main, they say that the side branch lesion length more than 10 millimeter and side branch diameter stenosis more than 7 is the major criteria, and minor criteria is moderate to severe calcification, bifurcation angle less than 45 or more than 70 degrees. One major plus 2 any minor criteria makes it a complex, and they strongly advocate that you should go for 2-stent strategy. What about the use of drug-eluting stent or drug-coated balloons? There are, this is a slide from which was recently shown in the TCT, that in the restenosis, both the drug-eluting stents and drug-coated balloons both work. And this is about the de novo left main bifurcation stenting. Both the drug-eluting balloon and drug-coated balloons have similar outcomes. And another trial, which is the DCB BIF trial, the drug-coated balloon was compared with a non-compliant balloon, and the drug-coated balloon had very good outcome compared to the non-compliant balloon. I'm sure you're all aware of the DK Crush 5 study. Now they have 5 years follow-up, 3 years and 5 years follow-up, and they continue to show, as you can see on the left-hand side, that the patients who had provisional stenting continue to have complications compared to on the right side, which shows that the complication rate continues to be very small in the DK Crush stenting. This is again the same thing. The red one is the DK Crush all the slides, they can show you that the complication, the MACE rate continues to be low. Whereas the EBC main, I mean, this is the European study which again has recently published the 3-year outcome. It shows that the provisional stenting continues to fare better than the double stent technology. Now the difference between DK crush and ECB is mainly that the EBC had less complex lesions compared to the DK crush, and most of the technique which they used was Culoet compared to the DK crush, which was of course DK crush. So with that in background, I'll just show you 2 cases. Now this is case number 1. This is a 54-year-old male with, I don't know whether this will play or not. Can somebody help me in? Okay, so this is Medina type 111 bifurcation lesion, and this guy has severe ankylosing spondylitis. He can't lie straight. It's almost 60 degrees, the kyphoscoliosis that he has. He had non-STMI, ejection fraction of 45%. We decided after talking to the surgeons, we decided to go ahead with an angioplasty. And in our lab, most of the time, we have shifted to drug-coated balloons for the sides, for the side branch, for the circumflex. If it is, if you decide that you have to do something to the circumflex, we always go for the drug-coated balloon these days. So this is just an example I'm going to show you that this is how we did. This is a Megatron 3.5 into 28 balloon in the left main to LAD. Then we did a kissing after cutting balloon to the side branch. We did a kissing with 4 into 15 and 2.75 into 15. Then now we crossed to the circumflex with a protege balloon. It was really difficult. We had very difficult time trying to cross it. Took us exactly 1 minute. But when I heard that you can take up to 2 minutes to cross the, when you're using a drug-coated balloon, you can take up to 2 minutes. And this is a very peculiar design. It is folded so that the drug is actually inside. When you inflate it, only then the drug is released. Otherwise, you can take time in crossing. So we were finally able to cross it. And then this is the final outcome after the stent in the, of course, pot and all those things were done. Pot, kissing, and repot, everything was done. And this is the final result. And this is the final result in the epicranial view. Now this is again a case done by my colleague Dr. Sahin. This guy had a left main to LAD angioplasty done about a year back, came back with angina and had, you can see here, very tight ostial left main stenosis. Again here also, we did the same technique. We used a cutting balloon and then the drug-coated balloon was used to dilate the circumflex and final pot was done. So this is what we are doing right now for the side branch. Hope it takes care of the circumflex. And now I'll hand it over to Dr. Vijay Trahan.
In continuation of the cases which have been shown, can somebody connect it?
Yeah, sure.
As rightly said, this is the Achilles heel. It is like to the biggest, the greatest, and the most renowned surgeon, if you give him an ingrowing toenail, give him a palonidal sinus, and so on, lookingly small things, they are almost very, very difficult, not only to handle initially, but on follow-up, the things are the same. So the circ os is either by God, the anatomy is such, the angulation is such, so that you do whatever, almost 1 in 5 will come back. And as rightly said that you are talking about in-stent restenosis. So if you don't put stent, maybe the bad points of a cage, like we have uncaged trial this time to show that if you do not cage the circ os, it's probably going to behave in a much better way than when it is caged. Connect? And we have also changed our practice, and there was a time when we always used to be happy looking at the circus shown wide open with the help of a stent. Now we started to accept circus which is good enough, reasonable, flowing well, and we want it to flow well in the coming time. This audio visual is also Achilles heel now.
So a quick question for Dr. Hajra. You know, let's say that there is a circumflex which is absolutely normal and patient has left main stenosis. You are stenting from left main to LAD. How do you end? Would you like to do a kissing balloon after you have stented, or you just leave it like that? If the flow is good, TIMI-3 flow, less than 50%, let's say, plaque movement or carina, new carina formation leading to 50% stenosis in the circumflex.
So most of the time it is angiographic visual illusion. So that is number one. Second, you are talking about 110 or 100. So imaging is very important to know whether you had any plaque which is more than 50%, plaque burden more than 70% to start with. And if you have those information prior that those are no plaques to start with, absolutely zero. 1 is basically on angiographic 50% stenosis by Dr. Medina, but not on the plaque volume. So if suppose you have a pinching now, you do the FFR negative, just come out. But you are not happy, the TIMI flow is 2. You just do a POBA, come out. TIMI-3 flow come out. But doing a POBA in the circumflex, again you have done some injury to the endothelium. It's better to give one drug-coated balloon, additional drug-coated balloon, to be very honest, that the future mass can be reduced just painting that circumflex ostium without missing the axial fit, axial mismatch and longitudinal mismatch. The two things are DCB. You can miss axially, that means 3.5 millimeter vessel, you are 3 millimeters. Or your geographical plaques, angiographically looking normal, but you have geographical plaques on your OCT on either side. So the drug-coated balloon should be longer than the plaque length. So if it is a plaque length from less than 50%, the plaque length is 20, you use 25 or 30. So there are many solutions to this, but as both of you have shown, the drug-coated balloon is a new thing. They said leave nothing behind. Actually, leave nothing behind is nothing, is a myth. Leave nothing behind is a POBA. Leave something behind is the drug-coated balloon. Leave everything behind is the drug-coated stent. Yeah.
Sir, just till study starts, whether your decisions in doing this provisional left main stenting, assuming everything is same, does it vary depending whether circ is dominant or not? I mean, the decision making, whether to go for pot, side pot, drug-coated balloon, if circ is flowing, there is some carina shift. Does the decision change whether circ is dominant or not?
It should not. It should not. If the flow is good, you know, both the European Bifurcation Club and the Asian Bifurcation Club, they say that don't touch the circumflex if you are going for a provisional. You know, you're talking about a situation where you have done a provisional stenting. Don't do anything. Don't touch it. If the flow is good, like what Dr. Hajra said, that you can do a FFR and all. But even those things are not required. You don't do anything. If the flow is good and it is less than 50%, don't do anything.
That's okay, but at the same time, if let us say it's a dominant circ and infected LAD, I think the weight of evidence and weight of reason will change in favor of circumflex.
Yeah, that's the difference. Yeah. If you have a CT of the RCA, which was dominant to start with, now you have put a stent. If the circumflex is down now with the flow, you can have some hemodynamic collapse or compromise. So immediately inflate the balloon, that's it.
So finally you have to give weight to the area supplied which is viable. And this business of circos, this business of 2 millimeter vessel, I think they are just simple guidelines. Finally, you have to apply your intelligence rather than artificial intelligence.
I think the slides come
And,
on. Many a times you
since-
see a carina shift. So that is not really so important. So you can identify that and leave it alone. But whether the plaque shift, that would be more important than you have to deal with.
Dr.
So
Prabhu,
I'll ask a question to Dr. Trihan.
Yeah.
You have put a stent,
In?
left main to LED,
Yeah.
and there is stenosis in the circumflex. Will you call it as ISR?
It is ISR.
Because there is no stent there.
It is in segment.
No, the circumflex
It is in segment within 5 millimeters of your area of work. If you get anything, it is in segment. Dr. Baran is going to show you a case, and where he's started from circ close to the ostium, got an so-called instant restenosis. Restenosis is not really in this stent, but proximally. He went proximally, and then he covered. And the next time he went from the os and covered the whole, means nailed the circumflex os. And third time the patient come with now something in the left main. So he puts a stent from LM to LCX, and there is probably nothing great in the LED os, but he puts a stent in the LED os also, because he has tested in segment problem with the stent. So anything within 5 millimeter of the stent is in
Next question
segment.
will be how hard it will be to tackle this kind of ISR, but there is no stent?
So now
or a
we-
de novo lesions in the circumflex. How do you make out whether it's de novo lesion in the circumflex or the really
So
stent?
now we just cut the short and the discussion. So in continuation of the circos, this is a 45-year female, right normal. She's a diabetic and left feeling retrogradely. So that means something bad in the left system. And this is what it is. You have a tight lesion in the prox LED. Circ lesion is hidden. Now you see the circ lesion. This is 001. We were talking about 110. This is 001. You can see it clearly. The LED lesion starting from here. This part is at least angiographically not significantly diseased. So this is 001. In fact, there is one more division, so you can call it as 0010. So handled the LED with a balloon and then made some way and then thought, put a stent. Now if you look at the LED, you can kind of go crossover from LM to LED. But if you are going LM to LED stent, then it becomes a kind of dedicated LM stenting, and then you'll have to be LM trifurcation stenting. Sometime you try to make the life relatively simple. So we had not done the IBOS, but I am sure most of the people who are here will vouch that the arrow where I am putting it is Dr. Ajit here, because he was with Ultron 2, he was talking about Ultron 3. Ajit is there. So he will concur with me that at this yellow arrow, if we had put any imaging, it would have shown things like this. Central lumen and then lot of atheroma there. And the LED would have looked here like this, larger lumen, very less atheroma. And LM would have possibly shown some atheroma, because if you see the distal LM and the osteoproximal LM, there is a difference. And the ramus would have shown it like this. This I am just trying to tell you that it would have looked like this, though we had not done any imaging in this case. So with this, we thought we just spare the LED os and put a stent just a little beyond the os. And that's what the result is. The real os is spared. We have not done any trauma to the LED os. We had a backup plan, and just in case things don't work, we can finally go with the LM to LED stenting also. And so the IVOS would have shown things like this, and after the stenting, IVOS would have shown things like this. That LEDs become better, and circ stays worse. So now, where is the os? You really do not know. I have shown you with the yellow arrow moving. If you put a stent like this, you are encroaching onto the LM. If you have your stent little to the circumflex, then you are missing things. So this is a cutting balloon. Look at the position of the cutting balloon has to be perfect. And then here you try to give a little more pressure. And finally, you end up in a result like this. So let me tell you, in case you want not to leave a stent there,
your practice of balloon angioplasty has to be extraordinary. It doesn't have to be an ordinary practice of doing balloon angioplasty. How is the result here? Anybody? If you look at the result before angioplasty and the result after angioplasty, it is more or less stent-like result. So now nothing abnormal. You just do icing on the cake and give a drug-eluting balloon, which was done in this case. And again, precise positioning, not trying to injure things here and there, and even trying to angulate the balloon. And so this is the final result. Nice result in the stent, nice result in the circumflex os. So that's how I say that it is one of the modern ways of handling the circ os. So again, we just try to, now the balloons, if the wire is in the stator branch, the balloon lies different. If the wire is in the different branch, the balloon lies different. You trying to set the atheroma in a much better way, like you tend to set the carina after 2 stents in a much better way. If you put 2 stents, 2 balloons there, same way you try to set the carina much better in the absence of a stent. And that was the final result. 4 months later, if you look at it, circ os is still reasonable, but what you have got is an in-stent restenosis, which is kind of in-segment restenosis. That indirectly tells you that if you want to handle the circ os, maybe drug-eluting balloon is better. And we handled this case with a drug-eluting balloon to the LED os, and finally this is the result. So this is about 2 years now, and the patient is perfectly fine. So I think this is just one case, and second case may not be like this, but it just tries to tell you that if you want to handle the circ os, here it was only circ os. If you want to handle the circ os, and we know the track record of stents is not very good, at least 1 in 5 stents will create a problem. And also technically it is difficult to deliver a stent there, and a lot of issues related to circumflex os. So if you are not dealing with a dominant circumflex and infarcted LED, then I think the way to go is spare circ os from a stent and try and rely on a drug-eluting balloon. And before you want to ice the cake, you have to produce an excellent result at the circ os. For that, whether you use a cutting balloon or other type of scoring balloon, I think that's your responsibility. And for delivering a drug-eluting balloon, especially if it is a distal area, then I think one very simple trick is the way you want to deliver a covered stent. You take a guard extension as deep as possible. Similarly, if you want to deliver a drug-eluting balloon distally where there is an issue like Dr. Pramod was saying, 2 minutes. So I think take a guide extension to the site where you want to deliver the drug-eluting balloon, so that that issue of the balloon staying in the intravesical compartment for 30 seconds, 40 seconds or 50 seconds, that thing is gone. If you have a guide extension there, all what is needed is you just pass in your drug-eluting balloon there and open it and deliver the drug. And the company says 30 seconds, but my practice is keep the balloon there, desi ghee ki tarah, as much as possible till the time your patient is tolerating ischemia. During that time, you should be very, very careful. Look at the QRS, look at the T wave, look at the R wave, also look at the pressures. And the moment you find your patient is kind of wavering and giving any signs of ischemia, I think that's the time to deflate. So I think one way to handle circ os is to handle it with drug-eluting balloons and make that area nice looking with cutting balloons followed by routine balloons. So thank you very much.
Let's hypothesize here. Suppose the circumflex is 3 millimeter and on angiography 90% lesions, but on IVAS and OCT there is extension of the plaque in the left main, which is not visible on an angiography. Let's presume it is 40%, 50% plaque only. Now you have tackled the circumflex with cutting balloon, a 3 millimeter drug-coated balloon. Now you have extended the drug-coated balloon in the left main, but the plaque remains there. So it is an axial mismatch of the left main, but it is a total axial fit for the circumflex, Austin circumflex. So as I was discussing, actually missing the axial treatment of the left main. So in future, this plaque may progress in the LAD, which you have shown here. It could be ISR, it could be natural progress on the plaque, which you have not treated. So my question to you, should you use one drug-coated balloon in 001 or two drug-coated balloon to treat the left main, like a 5 millimeter left main?
So
you have to use additional balloon or just finish with one?
Again, I think that will depend largely on what is the size mismatch. If your left main is very roomy, let's say left main is 6 millimeter and a 40% plaque, just forget about anything. But if your left main is like 3.5 to 4 and circumflex is 3 millimeter, that means you are trying to do something to the LM. So if you are trying to do something to the LM, I think you are possibly required to treat that area. That was only a filler.
Any questions?
I would, sorry.
Ask something.
Just more questions from panelists?
I just wanted to ask Dr. Bijay sir, okay, you nailed the ostium for the circ in this case. Let's see, I've got a case of 001. Just the circ ostium is involved. I did the cutting balloon, everything done. Still, I find that the ostium is having the problem. So if I say, like in this case, the left main, the LED ostium not involved, so you just spared the ostium, tried not to touch the ostium. But what if I have gone straight with the decay crush? In that case, I would not have a problem that the patient is coming with the circ ISR again and again. Okay, I'll not cover the left main ostium, I'll cover to the body because the left main is long enough. So what would have been that approach for this
You do
case?
not have any scientific head-to-head comparison between these two strategies. There is absolutely no doubt that if you want to do any bifurcation, especially left main bifurcation, then crushing is the best technique. And for those people who do not know how to cross a mini crush stent, will do a decay crush. Like I have never done a decay crush in my life. Never done it. Because I feel why to cross it twice? And if you are as an interventionist cannot cross the into circumflex ostium of a crush stent, then I think you must learn, because whatever has been done in decay crush, some part of the world there, it has been propagated to everybody and most of the people. Decay crush may be an okay technique if you want to do it crush somewhere distally, where sometimes it is difficult to cross into the side branch. But doing a decay crush for a left main, I think you must better learn how to cross into a mini crush stent. Finally, whether it's a mini crush stent which has been kind of kissed or is a decay crush, the final result is dependent on how good was the final kiss. And those who do not know how to cross, maybe do a decay, but otherwise I have never done it, and I will almost never say that for left main you should do a decay.
Actually, decay crush was never tried in this kind of lesion. It's a true bifurcation, it's a complex bifurcation, and severe calcification has been ruled out in decay crush trial. But this 001, the decay crush was not done, and is not required.
Just before we wind up, just last question. What about this new technique of decay coulé? What do you think of that?
See, decay culo is nothing but a reproduction of a string culo which was published in JACC about 15 years ago. The advantage of decay culo or string culo or culo, for all of them have culo, the advantage is that you perfectly cover the carina, you do not crush the stents. The disadvantage is whenever you are trying to do any kind of a culo, you have to lose a wire. That's the summary of all kinds of. See, if you do culo, string culo and decay culo, decay is your crossing helps, string is a less amount of metal, but culo is culo.
In the future, as Pramod was mentioning, so
I think we are
future will
late.
be these bioadapted stent. You had one slide, but it did not explain. That is the only stent which is superior than the conventional stent.
Right. Can we move on to the case presentation now? We are already running late for the program. So can we invite Dr. Gaurav Tripathi to present his overview of the first case?
Hello everyone, good morning, and thanks for inviting for case presentation. And we'll take this topic of isolated LCX lesion to even further, and with some more added complication, more complexity and complications in my case presentation. So the clinical details: this is a 73-year-old male, hypertensive diabetic, and ex-smoker, having chest pain since 1 day, high trop T, echo was normal with So, high trop pi levels with normal ejection fraction, creatinine of 0.9. We can see in ECG a subtle horizontal ST depression in V4 to V6 with 1 millimeter ST elevation in V1 more than AVR. So, this is angiogram. Isolated LCX lesion, seemingly isolated LCX lesion with lots of calcium or triamteric appearance extending up to the distal segment, and we can very safely say it's Medina 001. So this is where I will put a stop to myself and take opinion of Trehan sir how to deal with this case. If you wish, I can replay the previous angiograms as well. Isolated LCX, seemingly isolated LCX lesion with a lot of calcium.
So this is almost a replica of my case where it was no calcium. My case was 48-year female. This is 70 plus male, and this patient has a short history, 1 day, and drop positive, if I have not missed things. So with whatever. So at the moment the culprit is circumflex, and I'll say that angiographically we can clearly see calcium, but at the same time it is always preferable to have a taste of the calcium by intravascular imaging, whether the calcium is luminal or calcium is outside. And if the calcium is luminal, there is no doubt you have to get rid of it, and generally to get rid of the luminal calcium and to have facilitated entry of the gears, it is better to have rotational atherectomy of that area. But in case it is not a luminal calcium and the calcium is outside, then other modalities other than rotational atherectomy like IVL and even sometime laser can be applied to it. As far as what is going to happen to the LED is concerned, because I suspect that LED is looking to be not involved, but if you just look at the LED osteoproximal LED in the top right frame, and compared with the kind of a distal LED, it is almost 40% of that.
Yes.
So I think it may be wrong to call it 001. It has to be like, it could be 011. So if it is 011, then I think you have to finally have to end up in a LM bifurcation, but the crux has to be treatment of the circumflex. Like once we were talking, the circumflex ostium is an Achilles heel. It is an Achilles heel and presents with restenosis in 1/5 of the cases. One of the biggest reasons is you give it a stepmotherly treatment in the first procedure. Most of the time you do everything best for the LED os. You don't do things as good for the circ os. Even if I have done some cases or some other people have done some cases, circ os, even if some suboptimal result is there, you say it's fine. I think if you give a good treatment to the circumflex os, it is possible that the results of 1/5, 20% or 18% restenosis might be a single digit restenosis. So I think this is a classical case where you'll have to give reasonable treatment to the circ os, we'll have to modify the circ os, and finally kind of also treat the LED. Let's look at what is the intravascular imaging.
So likely we were taught in our residency LED first. Now similar to Modi ji, we have to look east policy, and we have to also take care of LCX at the same time with due diligence. So CBC were out of the table because patient don't wanted a surgery, he wanted a non-surgical solution. So DCB to osteal LCX was again out of the box because it's a huge triamteric calcification. So straight away we taken a femoral approach, 7 French EVU guide, wiring run through floppy, but IVUS couldn't cross, neither could any balloon. So over a fine cross microcatheter exchanged to rotafloppy and did a rota ablation with 1.5 millimeter burr. So now after rota ablation, look at the proximal post rota ablation predilatation also done with 312 NC balloon. Now look at the osteal LED portion. Now what? Leave it here, DCB to LCX, or what I did was an IVUS to LED. Is the osteal LED looking more significant now? It was significant to start with, but appearing seemingly. That's what I'm saying. Showing in that next slide, sir. It's an imaging of Excellent. Let me play the slide. See, so we did IVUS to LED, and now again, as IVUS definitely explains the situation. A tight lesion in osteoproximal LED with almost 180 degree to 270 degree arch of calcification. Somewhere superficial, somewhere deep. It's a deep one. So now the strategy changes. Now we have case fully committed decay crust stenting we are opting out for. So cutting balloon was done first, Wolverine 310 at 10 atmosphere pressure. Then not yielded well again, to go to IVL C2 3.5 into 12 at with 50 pulses given. And 10 kept distal LCX synergy 332, and it was tough to negotiate, so we have to take a GEC to negotiate through. And 3.5 15 alpine was taken at 14 atmospheric pressure in osteal LCX. And LCX stent later crushed with 312 NC balloon, rewired with workhorse wire, the run through. And post dilatation done with 3.58 at 16 atmospheric pressure. First is done with the same balloon, 3.58 and 312 in LED. Then a Megatron 3.528 at 12 atmospheric pressure deployed LM to LED. Now this is second case 3.512 and 312 in LED and L6 respectively, and second pot with 4.458 NC balloon. And this is final IVUS run. We can see it was a volcano catheter and machine, so it's difficult to pull through. You can see a jump and a IVUS run. So IVUS run in post stent, we have to look for apposition, and we should also take care of MSA. I think in such cases we should not or try to overkill. If MSA is achieved by the criteria, which would say it for a day, and this was the final result. So my take home message from this case is, SS anatomy of bifurcation with IVUS before any decision making. Although I was planning to, but couldn't pass any IVUS catheter in L6 to begin with. So I have to put an LED IVUS before doing rotablation. Upfront twist and technique for osteal L6 stenosis in complex cases, as suggested by Pramod Kumar sir. If there is a calcium and there is a lot of calcium in osteal L6, we should go for upfront twist and technique. Lesion preparation, as old guys have said, fail to prepare is preparation to fail. Decay crust is preferred for complex LM bifurcation, and always look for MSA in post PCI IVUS. There are guidelines for MSA. We have to take care. We should not try and overkill, because it's not the calcified wall which ruptures, it's the opposite wall. So if MSA is achieved, call it for a day, and all good for patient. Thank you, sir.
Thank you very much. While we have question and answers, I'll ask Dr. Barun Kumar to set up his laptop for the next presentation.
Sure.
I think excellently done case. Something which I would have done a little different was that having seen that we are going to also possibly address LED, I would have taken my 1.5 bar into the LED also. Also into the circumflex, if you look at it, your walk-in with your 1.5 bar was not all that good. You had some resistance, and then it went with a jump. It is always very, very important while you're trying to address the circumflex ostium that you try to change the trajectory of the guide wire. And how can you do it? There are two simple ways. One is you can do a kind of pull-push with your wire. Sometime you can change the wire, like you had a floppy wire, you could have taken a support wire. Second thing is you can change the trajectory of the guiding catheter, where again you have pull-push and torques. You can pull-push your emplange, you can torque your emplange clock and counterclockwise. What it does is, it will change the guide wire bias, and your burr will try to burr more than one area. And why I'm saying is, finally you had some difficulty in delivering a stent into the circumflex, and had the task with 1.5 burr, been a little more aggressive than this. I don't say that you take a bigger burr, 1.5 burr only, but just changing the trajectory of the burr, which you change by changing the guide wire bias, which can be changed either with the wire manipulations or with the guiding catheter manipulation. Often the task done by the same rota burr is better than what you just do with one trajectory of the wire. And the final polishing run in all these trajectories is so important that it will convince you that the things have been done very well. And I would have also taken the advantage of an open burr by pushing it into the left antedescending artery. The other thing which could have been different in this case is if you look at the LM to LED, angle is more or less right angle. And here the priority was the circumflex. And the lesion severity was circumflex, not LED. So you could have done LM to circumflex stenting, where you would have chosen a stent not 3 mm synergy but a bigger synergy. And you could have tapped into the LED because LED segment was relatively short. And the size mismatch, if you look at finally in the LA caudal, it looks that LED is still smaller. You are careful not to get into misadventure by post dilatation, but the size mismatch is looking to be a little more with LED and left main than would have been from circumflex to LED in this case.
I think if you have the mobile in your hand, and the people use ChatGPT today, just now, you put it this case, severe calcification requiring atherectomy, is there in data in the decay class? The answer will be no. There is no data of decay class requiring atherectomy, categorically mentioned. So you have done decay class fine. It doesn't meet the definition criteria of LED as Dr. Trihan is made. The LED list is not more than 10 millimeter. And roller coaster trial has shown us that 30% of these people who have severe calcification to start with, they require additional modification. You have done one non-compliant balloon. Additional tools means either IVL, ideally should be IBL, or OPN balloon to reduce not only the plaque, modify the plaque, also plaque volume reduction, as he has mentioned. The bigger size of the plaque would have reduced, and I agree fully that LED should have been done first. I mean, LED should have had one rota plus. That's my comment. Two rota, one in the LED, one in the circumflex.
Thank you, Gaurav. Thank you very much. Nice presentation.
Good morning, respected teachers, seniors and colleagues. So I am presenting a case of actually LCX ostia stenting extending to the left main. I thank Dr. Pramod sir and Dr. Samshad for inviting me here and giving me an opportunity to present the case. So the case is 65-year-old male. He is a non-diabetic for past 5 years, non-hypertensive, non-smoker. He is obese with a BMI of 27.4 kg per meter square, with LDL cholesterol of 121 and HbA1c of 7.4%. He presented with chronic stable angina class 3 for last 6 months. His ECG has some minor ST changes but no obvious abnormality, and echo showing normal LV ejection fraction. So he had a few past cardiac events. First was in 2019 August. He had an NSTMI, and when his angio shows double vessel disease with LCX proximal 90% and RCA 100% mid occluded. So LCX stenting was done with 1 day, and the plan was to do staged PTCA to RCA CTO. So after 2 weeks in August 2019 only, RCA was opened using 2 drug-eluting stents. He again had one episode of unstable angina in February 2021, approximately 1.5 years after the stenting. And this time the angiogram shows LCX ISR. It was a type 1 type of ISR, and again the stenting was done with stent almost extended up to the ostia of the LCX, 2.5 into 20 watt, which was post dilated with 2.75 into 12. So again, after almost 3 years, he again presented with chronic stable angina class 3 in October 2024. which is my index, this case presentation. The angiogram shows LCX ostia approximately 90 to 95% stenosis. Some haziness at the confluence with LAD ostia also showing some haziness, and left main lumen seems to be reduced by approximately 50%. So the case is CSG left main with DVD with ostial LCX stent ISR, patent RCA stent, syntax score is 29 with Medina 111. So what will be the plan?
How will you proceed? About the, actually, we had already discussed this case. We were in the flight, and he told me, and he showed me the case. I think I just summarize him in just one sentence. Nothing to feel very good about it. There is nothing to feel very bad about it. That's what I told him. Why there is nothing to feel very good about it? Because the last result which he showed shows excellent things, and the follow-up is only 1 year. So you can't feel very good about it. If he tells me that after the final result, now it is 5 years and that patient doing very, very good, then I think you can feel good. And there is nothing to feel bad about it, because he stented a lesion which is a little away from the ostium, and then got into a kind of a very simple restenosis. He stented that again, but this time he extended the stent till the os, which anybody will do. All of us will do the same. And third time the patient came with, as I was answering your question, if you get any restenosis within 5 mm of your area of work, that is again, you call it in-stent restenosis, or you call it a restenosis in response to wear manipulations. In segment. So again, in segment is a part of in-stent restenosis. So it's a type of, again. So finally he ended up in LM bifurcation. I think most of us will do the same thing. The only thing which it tells you is that this is an Achilles heel, circumflex os. I think this same thing would have happened to the LAD also. Means whatever has happened in circumflex, you would have started with a osteoproximal LAD lesion, you get some in-stent restenosis, then you put a stent right at the os, since looking at that the LM and circumflex are spared, and finally to get up, come back with some new lesions or an in-segment response in the LM. I think all of us would have ended up in an LM application. So I think nothing to feel good and nothing to feel bad about it. This is a usual story of stenting these segments.
So what I would just let you know that, you know, the largest DEB use in the whole world is in Japan and China. The number of procedures done by DEB, only DEB, is about 40% in Japan. Rota, IVL, bifurcation, everything is now, most of the time, if the end result is good, they will put DEBs. No stents, nothing, not at all. So in this case also, imaging is very important to see how important is that left main stenosis. Let's say that it is 40%, don't touch it, don't do anything to it. Why will you do anything to it? Maybe you can do some physiological studies, or let's say some thallium or something, to see whether that is actually producing ischemia or not. Simple left, the circumflex ostial lesion, cutting balloon, maybe a drug-coated balloon. Maybe I'll just leave it at that. So it depends a lot on the imaging. What is the result of imaging in the left main?
With OCT, we are gradually learning how to ignore things as well. Yes. Because otherwise you overdo things and you run into problem. One little question, Dr. Jahan. Like the second stenting which was done, it got up to the ostia. Suppose ostia was avoided again in the second stenting before it involved the ostial. Would it have made any difference?
I think if you look at his angiogram, and I don't know whether imaging was there or not, that tells you that leaving an os in this case will be again a cowardly approach. You are likely to get into a problem there. So at least cover that area which looks angiographically within the reach. So I think I would have done more or less the same. I would have gone till the os, and it is one of the unfortunate cases where you have in segment starting from LCX, which is proximal, going to LCX os, and then going to left main, and again all in segment area. That means, in fact, I argued with him that why did you do anything to the LAD os, because LAD os is not so much diseased.
But the counter argument is that here is an individual where you did something to the LCX and then you found that there is a response much beyond the area where you worked. And then you put a stent in the LED into the circumflex till os, again the response is too much into the left main. So this is a case who is likely to react into the LED os also. So it is better to cover. The only thing is that you could have treated the LED os with a, as I told you, DEB rather than DES. But I think we have identified a patient who's overreacted.
So do you have any data where the left main is around 20 plus millimeter long versus 10, 15 millimeter long? So, left main looks very long and very big in longitudinally, it looks very big. Circumferentially, maybe small in size. So there are data where the left main behaves completely different from the left main which is less than 15 millimeters.
This could be a different course also.
Yeah, course also.
It's a long one.
Long one, it will be intermyocardial to start with. From intermyocardial.
CT angio might have actually helped you to see the course of the left main. It's a really long left main.
But
So the other important thing is when you are trying to address the circos in a longish left main, then your instrumentation, your rubbing onto the left main is likely to be more. So you are likely to have more reaction in the left main. If there is a mild block and then you have to get into circumflex, you have to kind of push your guiding too deep. So you're kind of damaging or insulting the intima of left main more. And if you, so it's a result of, if you don't respect the soft tissue will not respect you. So I think one of the reasons for long left mains not doing so well, especially near the bifurcation, especially if you are trying to address the circumflex, to my mind is that you try to traumatize the distal left main more than what you would have done in a relatively short or a 10-12 millimeters left main.
I'll add to that left main. When the left main is long, the angle between the circ and the left main comes to around 90 degree or sometimes beyond that.
Yeah, it becomes more angulated.
Yeah, so whatever process you use, a decay crush, culotte, whatever, we try to cover the lateral carine, lateral wall of the left main. But once it is 90 degree, we are not going to cover that. It becomes useless because both the things are the same. So long left main, we are missing, we cannot use the decay cross method also. And movement of the heart is like circumferential. So even that will cause the distortion of the stent. When the heart moves like this, if you put a stent from the circ to left main, so look at the angle of the stent. It's 90 degree or sometimes more than that. And every time the heart moves, it's causing the problem to the stent. That's
Yeah. Can we see now what you've done?
Slide. So I did the imaging and it shows, I will show just now. So I access with 7 French femoral approach with 7 French EBU with IVAS guidance, and my plan was straightway 2 stent technology with decay cross technique. DEB was not one option because economically patient was not affording it and it is not under the insurance. So I wired the both artery, and as LCX was critically diseased, so IVAS will not go that. The first I dilated the LCX. Then I did the IVAS, which shows after dilatation LCX was around 2.5, 2.75, and the lumen was around 3.5. So initial ISR cause was under expanded stent, or you can say under angiographically it was looking okay. But the LCX size was 3 to 3.5 at the ostia. And the distal left main at the confluence, it was area was around 5.8 and ostial LD was also around 5.5. So after dilating the LCX, I put a stent at the LCX ostia. Then crushed with the balloon 3.5 into 12. Then recrossed the LCX and post-dilated the LCX ostial stent, and then did the first kiss. After that, I put the stent from the left main ostia to the LED, and I did the first pot. After that, again sequential post-dilatation with high pressure of both the stent in the LED and LCX. Then the second kiss was done. Then final pot was done. And this was the result, aliocaudal view and cranial view.
I think good
very
results.
good result.
Very good
result.
Very,
yes, no doubt.
So we have had a lot of discussion on the topic already. I think we are running late in time. If you have any questions, panelists, would you have to ask anything? Dr. Trehan, any other comment?
I think only thing is, if it is 5 years down the line, I think we'll say everything is good. But at the moment,
So we have
are still
follow-up of
fingers
1
crossed.
year.
It is 1 year, yeah.
Just one comment. You
1
said
year is telephonic follow-up.
So 2
See,
days
telephonically,
before-
sometime just before a patient gets a 90% ISR, 2 days before that patient is okay.
So as I was preparing the case, I talked to the patient telephonically and he was doing well, no symptoms.
you always blame your friends who has done the first angioplasty. You know, you said
No, all.
no.
all
I'm
done
just
by me only.
framing the statement. And the stent was smaller in size. Stent can get smaller in size in 30% by Akiko's data on IVAS because of recoil. Stent can get bigger with the bioadapter stent. 30% can get bigger. So always do not blame your friends. He may have limitations of imaging. May your stent has recoil from 3 to 2.75. It's not always your fault to your friend. Your friend might have done a perfect job. So stent behavior is different. Well, thank you.
If you look at the EBC data, you know, they have divided the circumflex restenosis into mechanical restenosis and biological restenosis. Almost 25% of the restenosis in the circumflex is mechanical. Under expansion, it was the biggest culprit.
One of the
or
most common
undersizing of the stent.
Right.
So in fact, they say that if you can detect that, you need not do anything. Just expand it to its full length. Don't do anything.
So, sir, second time when 2021 patient came, I should have done the IVAS, but at that time COVID was there, so it was just quick procedure and just get rid of that. So that we missed that.
I think Varun, you did very
Thank you,
well, and everybody goes through all these things sometimes. Only thing, all the discussion that I conclude, that there is nothing, a thing called isolated OS circ. Isolated circ OS disease is nothing, it's a misnomer. There is always left main disease, left main bifurcation is involved whenever you are dealing with a circ ostium. So always think of that, assess properly the left main bifurcation, the LED ostium, and then decide for the first index intervention. That is the most important thing, the index intervention. Because repeat intervention in circ ostium is a headache.
And I think it cannot be overemphasized. You have to have imaging to do left main, otherwise you'll make wrong decisions, wrong expansions, and wrong outcomes.
But at the same time, if you are using IVAS, you sometimes tend to overdo things. That kind of, you know, you have to put a red line.
Just comment, now we have about 100 patients with left main circumflex, multiple procedures, multiple types of stenting, culo, DK crush, and everything followed up with intravascular imaging at the point of. Our data is 32% restenosis and circumflex osteum. If you're 5.5 is your diameter, and we always felt that you get it more, we'll get better outcomes. The only thing I think is more than 5.5, you won't get it at 1 year, you get it at 2 years. The problem with circumflex is the movement, the hinge movement of the circ. How much ever we try to get this diameter up in the presence of a stent, I think that even large lumens, they come back. So I think it's sobering that your intravascular imaging showed big lumens at the end of the procedure with very good debulking, IVL, but patients came back. So I think it's more than just IVAS to decide what happens to circumflex.
Even interesting is if you go through all trials, we all recommend IVAS for main is a must. But in practice in Europe as well, I think it's less than 50% used in IVAS for left main as well.
So I will request everyone to stay on the stage, and next presentation will be Dr. Vijay Trehan sir, because he said that after his presentation he will be free to entertain everyone on all the sessions.
So
I was asked to speak on Are you ready to sense the unexpected? It was somewhat unexpected for me. When I reached the airport, they told me the flight is delayed. 1 hour, 2 hour, 2.5 hours. So no issues. At least it landed finally at Patna. But if the flight was supposed to crash land, then are you really ready to sense? If you sense, you back out, like Dr. Bharat did yesterday. So anyhow, with that lighter discussion, well, most of the time, if you've done something like you were going from groin and it was kind of a rough with the wire, rough with the catheter, and then you inject, you know that you created a problem. So nothing to sense, you know it. You had an aggressive guide, you injected, so you bought an aortic dissection, and you are walking through this highly tortuous, right, with a burr of whatever size. For this kind of a lesion, and the burr has a lot of guide wire bias. So you know you are in for trouble, you sense. But sometimes things are simple. This lady, top positive, nothing so remarkable in the ECG, normal left main, normal proximal LED and circumflex, a tight lesion here, most likely culprit, a moderate lesion here and a mild to moderate in the prox LED diagonal and a moderate lesion here. So one of my consultants was operating, and as per his version, after wiring the circumflex and he was just about to pre-dilate the circumflex, the patient became hypotensive. And he had given a whiff of dye just to see where the circ wire, and he found that the dye is hanging, and he suddenly pulled out the guiding catheter out of the left main. Soon the patient arrested, code blue is alerted. Now several hands are quickly available. I was also called, but very, very difficult to do CPR. Radial name came out. It was extremely difficult to even obtain a femoral access. The reason is photograph given to me by the son of the patient clicked just after her admission because he had to send it to rest of the relatives. So with great difficulty we were able to get the femoral wired into the left, no dissection of left main, nothing great or mischief done by circ wire. We can't see any obvious thrombus shot into the circulation. The patient is asystolic, and with difficulty the lead is taken there, and you have a TPA lead here and the wire distally and the guide tip here. So are you ready to sense what's gone wrong? We are already more than 10 minutes into CPR. We don't have ECMO. We are only having a chemical warfare with ADR into the coronary artery, NORAD, systemically atropine, and looking at the anticoagulant. The shoulders are trying. We don't have Lucas. It's only a very weak ROSC which has come, and no pericardial effusion. SBP is 60 to 70 on high dose inotropes and also multiple boluses of ICADR, and that's what you get. That's what you get. Sit carefully. Now wire deep into the LED, took a thrombosuction catheter even when there is no obvious evidence of thrombus there, and this could not go beyond that lesion in the mid LED, and the thrombosuction catheter did not aspirate anything also, and the massage is on. Change of hands, still shoulders are tiring. We are almost 25-30 minutes into the CPR. Any guess what to do now? After another 10-12 minutes, we are already almost 40 minutes into the CPR. Minded, this was a very heavy patient and it was very difficult to do a massage. And then came a weak ROSC, which needed multiple boluses of intracoronary ADR. And mind it, every time you inject intracoronary ADR, the guide is only intubated just to give it ICADR. Immediately the guide is pulled out. No time for the guide to sit in the left main. And then you get into a situation like this, which looks a little stable, but still you have a lot of contrast hanging in the distal circumflex. as well as in the LED. So we thought, let's take this patient on IBP at least. Now difficult access from the left also. So these are real issues. Obese patient, not too good pulse. It's about 60-70 pressures, so you're not able to get it. We crossed over from the other side, took a bar, made it a kind of target where you can hit the needle at the target, advance the bar, and took the patient on IBP and direct stenting of the circumflex on IBP. But still, the rhythm is only weak, requiring high dose intracoronary ADR, and the life is hell. Anybody wants to change the direction of management, guide us something great, something good, something new? We didn't have ECMO with us. At this point, when the rhythm is there, it is possible that rather than having IBP, one could have had a better transvalvular pump in the form of Impella, which is not available. So what should come to your mind when you get the so-called unexpected hemodynamic collapse? Well, early in the procedure, once you're just into the procedure, the commonest reason is low volume. Many times these patients are doing an overnight fasting, or sometimes the volume is okay, but you have expanded the intravascular compartment. And how do you do that? Like you have given a radial cocktail, you have given sedation, there is some vagal stimulation because of the excess, or at times anaphylaxis. All these things will expand the intravascular compartment so that there is relative hypovolemia. So once you are early into the procedure, I think these are the important issues which are responsible for this kind of an unexpected situation. While being in the case, then of course the dominant situations are ischemia and or tamponade. Of course you can also have loading issues which can lead to a hemodynamic deterioration or collapse. In the later stages, all these reasons which were there initially, they will be there, but in addition, it is possible that the person has lost a lot of blood from the GI tract or into the groin, and sometime while trying to handle the groin, and there is a hematoma which produces a vagal stimulation. So these are the issues which can produce a situation like this. So, Dr. Pramod, you were into the case except in the last 30 seconds when you were managing your bag. So out of this a kind of consolidated list of the problems which can account for a situation like this, what comes to your mind? The question is asked from Dr. Pramod, not from Dr. Hazra.
Air.
Now you picked up the mic, but only after I told you to hand it over to Dr.
Air.
So, in fact, when I entered the cath lab, I had the information given to me was that he just did nothing. In fact, that will be the usual thing. You ask your colleague, क्या हुआ? बोलता मैंने कुछ नहीं किया. भूत तो आया नहीं करने के लिए, किया था तो नहीं होगा भाई. So my first comment was that I think दो चीजें हैं. एक तो तेरा गाइड बहुत अंदर घुसा हुआ. तुमने एयर डाल दिए और गाइड अंदर घुसा हुआ है, और प्लस सी we arrested the heart for such a long time. Heart arrest कर दिया and your guide is in. You don't let anything go. You have pushed in air and you don't let anything go. That is what creates a situation from where it is very, very difficult to get out. You will lose these patients. You can do a massage for 10 minutes, 20 minutes. If this patient was on ECMO, it is possible that the patient comes out. If this patient, during the time when some rhythm was there, was on a transvalvular pump, it is possible that this patient comes out. But in the absence of these situations, like you don't have an Impella, you don't have an ECMO, to expect your IBP to do wonders, I think it is, probably it will not do wonders, it may, but more often you are going to lose the case. The first comment which I gave to my consultant was that this is, your guide was in beta, और दूसरा तूने air डाल दिए, and he called us, I think, relatively swiftly. So, after about 10 ampules of intracardiac ADR, 10 ampules, mind it, almost 10 ampules of intracardiac ADR, and a great display of mighty shoulders. So, this is what it is. If you look at the circ is flowing well, And if you look at even the distal LEDs flowing well, IVP is kept overnight, and this patient was discharged walking 2 days later, and that is what was the LV. I think the biggest satisfaction is to see the left ventricle. The left ventricle is contracting very well. And these claps should be, I think, to those tiring shoulders who supported us. And the message which I want to convey here is that air most of the time is not seen. In fact, you shoot air, the air will be seen only if it is surrounded by contrast. Air is easily not seen. If you look at here, there are telltales about air in the distal LED. You compare it with the one which we got it after some time, after about an hour. It tells you that there is something in the distal LED. We don't know whether it could be a thrombus, but it could be air also, most likely air if you go by the history. And we took the thrombosuction catheter not to suck thrombus. We just wanted to take it as deep as possible, wedge into the coronary, and then try to suck. And if you suck, you will never know whether you have sucked air or not, because it is like vacuum which you have sucked. So not getting anything means nothing. You have got nothing is not that. That means you might have still got some air which would have evacuated the distal circulation. See, what you see angiographically is this, which is 5%. If you look at the coronary tree, there is much beyond what you see with your standard angiograms. And air bubbles, once they break into so small bubbles. The viscoelastic forces of air bubbles are far, far less than that of a thrombus. Thrombus does not tend to go and fill the microcirculation. The bubbles, air bubbles, tend to get into the microcirculation, and from where they can be washed out also. The washing out is only if they reach into that 95% of circulation which is not seen. And this is how the air goes in. If you see it, I think this slide I prepared just to show you that many times the moment you want to rush your balloon inside, and that is what I talked to my consultant yesterday also. He told me only wire डाली थी. मैंने कहा तू बेटा balloon भी डाला था. कहता हाँ सर balloon लेके तो गया था, मैं डाला नहीं मैंने. So while he was taking the balloon in, he had this, and when he flushed with saline, the bubbles went in, and that's what created a hemodynamic collapse. So I think the message from here is that most of the time things, you know that it is going to happen, and you have seen it, like I showed you first 3 or 4 cases. But the moment I started this case, Hadra was first to pick up that there is air, and it is only 10-15 seconds later, Dr. Pramod was also very sure that this is air. And see, these two heads were nodding very carefully. And so that is what experience says. But these heads were little down when I paused after 40 minutes of massage, that what to do now, because then you start thinking something else. For them also, the message is, even a 40 minutes massage, continue. If you continue, I think your patient can make out. And 10 ampules of ADR is the count given to me by the staff nurse, that 10 have been shot into the coronary artery. That tells you that a stunned myocardium may need far higher dose of ADR than a routine myocardium. So I think I'll end up my case by just simply telling you that if you start sniffing, which the seasoned interventionists do frequently, they sniffed it very well. If you start sniffing it well, you will be able to sense the unexpected. So thank you very much.
I had a similar experience. I was with my colleague, and we were starting the procedure, and the patient on table started doing like this. We thought it's aortic embolism. And finally, patient came back. We did MRI. There was no embolism. So what we did, we learned that day that when you prepare these assemblies for PTCA, Y connector, never connect them to the guide, because that is the time you are not sure whether your Oxford valve is working or not. It is backflowing or not. So prepare your assembly disconnected with guide catheter. We suffered on the other territory. Patient came back because it was a minor flow of air.
I think this TCT 2025, Dr. Trehan was sitting there, and I was recording his conversation with the world leaders, and he was mentioning about this air embolism, because somebody said it is air embolism. It is actually not air embolism. And I was watching from India. I have sent you the video.
That, yeah.
Anyway, so this air embolism very common, especially it will be devastating if your angio was normal. Like if you have a normal coronary artery, he had a cardiac arrest, how do you explain to the relatives? I had once. So my question is, do you give, how much of adrenaline you give? 50, 25, 75? Is it different from the intravenous? How much you give?
No, this is, I told you 10 ampules were shot into the...
No, intercoronary you have to give only 50 to 25 to 75 microgram of adrenaline. If you give more adrenaline in coronary,
this case,
it will cause a vasoconstriction.
In this case, I have given, so again, that's what I summarized, that a patient who's developed so much of stunning, there, if there is somebody is awake, you do it like this, he knows. If you're dozing, he will not know it, you will have to touch him. He's sleeping, you will have to hit him. Once your myocardium has gone to a deep sleep, almost 6-7 minutes of asystole, this will require tremendously high discipline. This is what I told you, that 10 ampules were shot into the intracoronary
Usual
circulation.
recommended dose is 50 microgram, is the best vasodilator.
And
no, you have to,
same thing.
If the beta blockers behave differently with higher dose of adrenaline.
No, those are with the awake person. Those are with the awake heart. Okay. Those are situations when you have taken up a patient just like this and there is no stunning of the myocardium. Here is a stunning of the myocardium. Okay. And 10 ampules were shot into the coronary artery.
Actually, you have pushed the aspiration catheter is much bulkier. The other way, simple way of...
You can take a simple microcatheter, get into different circulations.
Or perforate the balloon.
No, actually here...
Perforate the balloon which you have caused. Yeah. So perforate the balloon and try to aspirate. That might also work. Yeah.
So I think this is a condition which may happen with anybody. It has happened with us also. So one thing which is very important is the primary operator has to keep the charge and keep doing the maneuvers instantly. So sniffing is obviously one thing which if you sense it early, obviously the reversal
Actually this case wouldn't have gone to this situation because she was very obese and the radial line was lost.
Oh.
So it was, in fact, if you look at it, even to get the left femoral, it was very, very difficult. Our bar was just getting subintimal, and so we had to go crossover, make a target and hit it.
So first thing is that primary operator continues to do the endeavors. CPR is done by other hands. And first thing before, see, epi is not ready, adrenaline is not ready, you will call the sister, it's going to take some time. You start auto-perfusing something.
So that was the time,
whatever you have.
So that is what we used to do some time ago when we were being taught. Nowadays we are on the teaching side. And I say this is an absolutely stupid thing because let me just tell you, again I'll tell you, a lot of people will say, 100% hyperbaric oxygen. Absolute stupidity. Absolute stupidity.
No.
Same thing is auto-perfusion. See, you cannot do auto-perfusion once you have embolization in the distal circulation.
So until the time epi is getting ready, normally dilution, we say normally 1:1000 dilution. But here, I think I agree with that. We are not, because we are losing a patient in some time. So whatever you get, 1:10, 1:100 dilutions, you start giving as a bolus into the coronaries. Only that can produce.
See, what you push from outside will almost never perfuse the capillaries. Almost never.
Obviously, it is going
what you have to do is you have to alter the capillaries. For that, it's chemicals and support of the systemic circulation. We used to do this, and we used to do it, talk it, listen to it, do it, and then talk about it. Now I have stopped listening it, and sometimes even like you said it, unfortunately be a little bitter and say that auto-perfusion has no role.
No, until the
auto-perfusion has no role.
Idea is that second, what will you do?
Auto-perfusion has no role. Cardiac massage has a role because auto-perfusion and perfusion the coronary artery. You need to support the circulation. To support the circulation, either have ECMO or have extended cardiac massage.
Vijay, what Rajneesh is trying to tell you that an intracoronary adrenaline may not be ready. So till then, you do whatever you're doing.
Then train all of your labs to have IC.
Oh yes, yeah. I agree. For example, I remember, why do you want to give hyperbaric oxygen?
Yeah.
You're not actually treating the cause. You're actually trying to support the brain. That's what you're doing. So it's part of your overall management. The same thing, like when Dr. Hajra said that it will be too much if you give that much of intracoronary.
Hyperbaric oxygen.
I don't care how much I'm
Hyperbaric oxygen does not prevent brain, number one.
No,
the only mechanism
you are actually trying to oversaturate the bloodstream so that some amount of oxygen reaches everywhere. That is
No. That is not. See, I have reviewed this topic.
I think
you give 100% oxygen because like your
hyperbaric is not available in most of the countries, so we give 100%.
So,
we give 100%.
Let me just tell you two things. See, actually, this thing is being talked about everywhere. You give 100% oxygen and you give hyperbaric. 100% oxygen means you are inhaling 80% nitrogen. Once you give 100% oxygen, that means you are having zero nitrogen in your airways. If you have zero nitrogen in your airways, then in the pulmonary arteries, if you have a dissolved nitrogen, because wherever you have air embolism, it's oxygen gets kinds of absorbed, it's only a nitrogen which is circulating. So you have nitrogen in the pulmonary arteries and pulmonary capillaries. That nitrogen will get back into the airways, into the alveoli, because in the alveoli now you have no nitrogen, the only 100% oxygen. Right. By hyperbaric, a bubble which is like 1 millimeter or 1 milliliter in the volume is decreased, compressed to about 1%. They become so small, and if the bubbles of nitrogen they compress, they get compressed in the hyperbaric chamber, they become so small so they can be easily exiting out of the pulmonary artery into the alveoli. So you kind of get rid of dissolved nitrogen from the systemic veins, not from the coronary arteries. In fact, even talking about hyperbaric oxygen or giving 100% oxygen is waste of time. What is important is maintain systemic circulation, good cardiac massage, and if you have an access to a kind of ECMO, quickly take this patient on ECMO. And then if you continue giving intracoronary high doses of epinephrine, which is shown in this case, I think your circulation is going to relent and let those microbubbles pass, and as the microbubble pass, as the circulation is resumed, your heart will come back. Okay. The next day's echo shows you almost everything.
Can we conclude this session now? We have very good, very nice discussion, very heated discussions, but I think we have learned a lot from the masters. Thank you very much, Dr. Trehan. Thank you very much, Dr. Mulasari. We had a lot to learn, and thanks for your participation, my panelists and Dr. Trishant Pathi.
Thank you.
We'll conclude this session. We have to move on. We are already running an hour and a half behind schedule.
Thank you, sir. We are moving to the next session on STEMI and cardiogenic shock. So I would like to invite moderator Dr. Ankit Gupta, chairpersons Professor Sharat Chandra sir, Dr. Arvind Kumar sir, Dr. Manish Kumar Jha sir, and panelists as Dr. Sumit Kumar Verma was Dr. Javed Anwar and Dr. Nishant Kumar Abhishek. Meanwhile, we have an announcement. We have a running simulation lab and hands-on session at level 1 in the same building. So anybody who is interested for hands-on and simulation lab, we are having simulation lab for tower, rotablation, leadless pacemakers, vascular access closure devices, everything we are having over there. So it is a very interesting place to be there. Thank you. Mics over to Dr. Ankit. And can we have Dr. Shumit Shankar on stage as a panel member?
Good afternoon, everyone. It is a privilege to get participated in the most commonest, deadliest cause of the death in STEMI leading to cardiogenic shock. Now, without wasting our time, I would like to call upon the Dr. Shesh to talk upon the high thrombus burden cases. Please, Dr. Shesh.
Thank you. Good afternoon. To kick-start this session, I'll be presenting a few high thrombus burden cases which we have done recently at our center. Scroll. So the first case is a 62-year-old male who presented late after inferior LMI with all sorts of complications. CAG revealed the thrombotic occlusion of the right coronary artery from the mid. After the pre-dilatation, the flow was good, so we decided to deploy the stent. 330 stent was deployed at 14 atmosphere. However, after the stent, there was a slow flow, for which thrombosuction and intracoronary vasodilators were initially given. A repeat thrombosuction was done, and with distal administration of intracoronary vasodilators with the thrombustor device. Finally, the flow had improved in this RCA. This is the final shot of that case. In the second case, almost the same subset in favor of MI, late presentation with CHP, RV dysfunction, cardiogenic shock. CAG, we did CAG which revealed high thrombus burden, 7F radial axis and was obtained, and with help of 7F thrombosuction we decided to do the thrombosuction. The RCA was already collateralized from the left. We can see mid total occlusion of the RCA. Directly we proceeded with thrombosuction, but the flow didn't improve at that point of time. Second run of thrombosuction was done along with intracoronary administration of the vasodilators. After that, pre-dilatation was done. So after the pre-dilatation also we did a few runs of thrombosuction because flow didn't improve after the pre-dilatation and multiple repeat thrombosuctions as well. So ultimately we had to resort to penumbra device in order to improve the flow in the distal artery. After the use of the penumbra, the flow improved, and we decided to stent the lesion. After the stenting also, there was a residual thrombus in the stent. So we had to use the penumbra device again in order to aspirate that chunk of the thrombus which was still remaining, and finally we got this view. Third case also, this is also RCA. However, this was not a very late presentation. Patient was having ectatic vessel or ectatic RCA. Initial thrombosuction was done, but the flow didn't improve. Followed by pre-dilatation and a repeat thrombosuction. Penumbra device was used at that point of time, and it led to initial slight improvement in the flow, but still we can see the distal thrombus burden was there. After the ballooning, we again did one more run of penumbra, and final shot was like this. These are all very high thrombus burden cases which we have done recently using the devices. Now over to our expert speakers for further elaboration on these cases. Thank you.
Thank you, Dr. Shes. I have one question from you, Dr. Shesh. We have there is a guideline which we have class 3 indication for the thrombosuction, and still we are doing the penumbra, and we have a latest technology of the penumbra where we are doing the high burden of thrombosuction there. Is there any new guideline which has been introduced for this?
Slide is my slide. All right.
For penumbra devices also.
I think Dr. Hazara will going to tell us. Yeah, tip and tricks to manage the high thrombus burden case-based approach. Thank you.
So what are the strategies? You have thrombosuction catheter, many catheters, but best one is the penumbra. You have laser, almost universal in my lab. Laser sometimes is free of cost in India, not for European countries, because I will not say it is Oxford laser many times. You can give intracoronary TPA, but 2025 TCT, STRIPE trial says it is harmful. In fact, last week I had a case, intracoronary TPA caused VT exactly like STRIPE complications. Some Japanese and Singapore have presented some cases in TCT with stent retriever. Many of us during our student days has recommended you forget stenting on that particular day, deferred stenting, and come back with intracoronary, your tirofiban, Riopro later on. DEB only, if you have a diffuse thrombus, small vessel, you can use DEB and just come out. But the problem is if you have late thrombus, your drug may not reach to the intima. Sometimes if you have a large thrombus and doing a thrombosuction, patient crashes, you have to use the MCS. And you have DPD for your graft thrombus. You have a large venous graft, lot of mugs, and perhaps you need a DPD in the grafts to prevent embolizations in the native artery. What are the drugs which can help? Cangrelor data is routine, almost affordable patient in our lab. Still the GP2B3A receptor antagonist intracoronary is effective. PCSK9, there is some data from Samir Mehta to reduce the thrombus burden. You do not know what time he has infarcted, maybe some delay. And recent data on RUC3, this is the antiplatelet given subcutaneously and do it at home. The ambulance driver, if give this antiplatelet, strong antiplatelet by subcutaneous injection, one jab, perhaps the no flow, slow flow and thrombus burden by the time he reaches the hospital will be less. And in the past, we have a mesh stent from Israel. It is usually seen in the large ectatic coronary artery, led presentations like many Indian STEMI, and moderate stenosis, especially the cannabis addicts in India, the power bull drinks, abuse, and menopause. Apla syndrome in female, young female MI, young MI, and the venous graft. So if you see this in left, be ready, you are going to see in the right. So this is the right, and not the problem of stenting here, because large artery, usually these big stents are not available during our student days, maybe 5-10 years back. Now stents can be dilated up to 6.75. And the idea of thrombosuction got a class 3 recommendation just after one trial. How sad. You have many trials like Proctor trial has said the venous graft versus native, if you do the venous graft is superior, easy to do. One trial is not going to change the recommendations. You have to do 2-3 more trials. But one trial, test trial, has changed completely the scenario of aspiration. And in 90% of us, when you see large thrombus, you still do the thrombosuction. So I do not know what is there on the trial, how many patients had this kind of stroke. It's very small. And stroke occurred up to 30 days. It's unfathomable. Now, what is the difference between classical thrombosuctions and the CAT-RX technology? CAT-RX technology maintains this continuous aspiration pressure till the end. The same thing cannot be achieved with your syringe. So that's why the distal embolism and stroke is not seen, and there is a Cheetah trial which supports that perhaps it reduces the mesh and the distal embolizations. The same CAT-RX can be used for distal delivery of the drug. Adrenaline 50 microgram, if you give too much of adrenaline in coronary artery, it will act differently, it will behave differently, vasoconstriction. So 50 microgram, nitroglycerin, nicorandil, etc. can establish some flow, and the normal flow of the coronary is the best treatment for thrombus. So restoration of flow, either vasodilatations or by aspiration or by stent sometimes work. Same CAT-RX can be used for many other purposes, and recently this CAT-RX, the lumen is so big, it can be used to treat PVL, TAVR PVL through the coronary wear. So it has got many aspects of use. You should preserve this CAT-RX. All labs should have this penumbra device. And if you have this kind of thrombus distally, you can try aspiration, you can try Cheetah, you can try this new device, retriever, which is very costly. And this retriever removes the thrombus and you get good flow, and you can continue your cangrelor, heparin, GP2B3 receptors, and once they come back with good flow, and he came back with almost normal looking arteries and no thrombus, get away with the stenting, or you can paint this artery with the drug coated balloon if you have 50% or plaque erosion, plaque hemorrhage there. The latest kit in my town is a laser, and there is a recent trial, last past trial. It is not a positive trial. So here is a patient, 89 years, had complete heart block from anterior STEMI, large LED, and wired, glazed, 80-80, only saline. So if you are doing with thrombus, laced with 80-80 saline, few runs, it can cause severe vasospasm. So nitroglycerin, nicorandil is, now if you have 2-3 wires, then still it is possible. You should have at least 6 French catheter to pass the laser. It cannot go through 5 French. You can have many wires in the side branches till the laser works. You start proximally at the head of the thrombus, go distally, and once you are seeing this kind of flow with the stenting, you are very happy. So RCA, you see this kind of lesions, and this kind of lesion can come as a barrier or a deferred stenting strategy, but laser worked here to some extent, not to great extent. I'll just take one. Intracoronary TPA, good flow. So the take-home message from this trial, STRIPE trial, that intracoronary TPA is harmful, but still sometimes this is practiced in large ectatic artery. So ladies and gentlemen, all thrombus, all MI, all complex coronary arteries are not same. They may look similar on an ECG, but on angiogram they look completely different. Sometimes it comes as a surprise, and you should have all these strategies available in your lab. Be prepared to fight the worst case of large thrombus with laser, aspiration, the pharmacotherapy, and be patient, because these devices take some time to get a TME3 flow. Sometimes waiting can help you to understand the philosophy or the flow of the coronary arteries, and you can stay away from the stenting if you have a TME3 flow, no residual stenosis, or you can do the stenting. Thank you very much.
Thank you so much, sir, for enlightening us and the tip and tricks for fighting against the thrombus. Please take the chair on the dais. Without taking much time, I'm calling the Professor Sharat Chandra, sir, to present on the ACS with the left main cutoff. We can have the question after the session because we are running late.
No.
There was a question of NOACs. It was we presented it at the AHA late breaking last year. It's published in American Journal of Cardiology. NOAC plus single antiplatelet is superior than dual antiplatelet therapy. It's a small study, randomized study, but showed the death was no different, but re-MI was 6 times lower with rivaroxaban, 15 milligram plus clopidogrel versus dual antiplatelet therapy in ectatic coronary artery.
प्रमोद का दिया हुआ this thing is matching and it's very effective to counter the cold. About the NOAC, I said no, somebody said yes. So there are many ways of treating each and every lesion, like air embolism, thrombus. So you have an opinion.
Thank you.
Sometimes it works, sometimes it do not work. And if you have a TME3 flow, perhaps you don't need to give. But if you have a compromised flow, ectatic artery, you can still use NOAC. But you have to use one, I would say one strong antiplatelet, either ticagrelor or a prasugrel. There is new data from Tuxedo 2 by Dr. Upinder Kaul. In diabetics, perhaps prasugrel is superior than your ticagrelor. So there are different ways of, over to you.
Thank you, sir. So the topic given to me is ACS with left main cutoff. Should we panic or take the challenge? So if you see the incidence of totally occluded LMC is less than 1%, and most of the cases are CTO rather than acute occlusion. And if you see the data of acute total occlusion, the incidence is somewhere around 0.2%. The LM-SOX syndrome was first described by Quigley in 1993. So coming to some data, so if you see this registry, the Atolma registry published in 2020, it is an uncommon angiographic finding usually leads to a catastrophic presentation. And this entity is susceptible to cardiogenic shock, malignant ventricular arrhythmia, and sudden cardiac death. And if you see the predictors of mortality in acute total occlusion of left main, one is collateral circulation. Though the value of collateral circulation is controversial, but the absence of collateral was significantly higher in patients with cardiogenic shock at presentation and was related to 1-year MACE. And another important thing is right dominance. In true Atolma, it has been suggested that only patients with right dominance will survive to receive a diagnosis and invasive treatment, and Atolma and left dominance is incompatible with life. And final thing is the final 3 flow. We have to achieve this final 3 flow because restoration of 3 flow is crucial. And if you see this registry 2023, so if you see the data, no patient had left dominance, and at present presentation 73% were in cardiogenic shock, cardiac arrest occurred in 27%, and 97% patient underwent successful revascularization. Still, the mortality is very high, it is 58%. And after multivariate analysis, only cardiogenic shock and angiographic success were independent predictor of in-hospital mortality, and presence of well-developed collateral circulation had a significantly lower prevalence of cardiogenic shock at presentation. So this third registry 2018 published in Advances in Intervention Cardiology. Here you can see again about 40% of unproductive left main occlusion cases present following successful on-site CPR. Shock was present in 85% cases. Left main was opened in 90% cases by PCI, and circulatory support was given somewhere around 80% cases. Still, the in-hospital mortality is around 56%, and the data showed that no need for CPR leads to a very poor procedure outcomes and strongly correlates with left main with hospital mortality. So here's the patient, 52-year male, anti-LMI, non-thrombolized, presented to us 24 hours of chest pain. That's the angiogram. Here you can see this left main is 100% occluded, and it is well collateralized by the right circular. Right is dominant and significant disease, but went of class grade 3 collaterals to the LAD and LCX. So here we decided to go for the PCI, wired LAD, circumflex was wired, but even after multiple thrombosuctions, we were not able to achieve the flow in left main in LAD and circumflex. At that point, we planned to go for cataract system, but that was not available. So we told our technician to arrange for that. But after multiple thrombosuctions, maybe after 30 minutes, we were able to achieve some flow, and that was a spot lesion. And finally, we dilated with a balloon and stented with a single stent, left main to LAD crossover stent, and that's the final TME3 flow in the LAD and circumflex. As a routine, we did IVAS also. It showed well opposed stent in LM and LAD. And in a stage procedure, RCA was stented 2 weeks later on. So that was the result of RCA stenting after 2 weeks. So another important case, good case, 48 male, non-diabetic, non-hypertensive, acute anti-LMI. He had recurrent VT, multiple shocks given. He was in shock, ST elevation, you can see the ECG ST elevation in AVR, AVL. Ejection fraction was 35%, and we were rushed to the cath lab, and again right dominant circulation, and left main was 100% occluded. So that's the angiogram here. So we took the femoral approach, and we initially wired the circumflex, but not able to wire the LADs. Then we took hard wire. Finally, we achieved to wire the. We succeeded in wiring and dilating the LAD, and so stented. LAD was stented, but there was significant disease in the circumflex. So we did a culottes stenting, and this is the final result after the culottes stenting of that lesion. So again, case with NSTMI, global LV, hypokinetic, ejection fraction 32%. It is almost flush ostial occlusion of the left main. Here you can see the angiogram, almost flush occlusion. So we took the right angiogram, again grade 3 collaterals to both LAD and circumflex. So again we took the wire. Initially we wired the circumflex but not able to wire the LAD. So we took hard wire, and then after some difficulty we were able to manage negotiating the LAD. LAD was wired, finally shifted to workhorse wire and dilated the lesion. And finally, again, we did the left main to LAD stenting. Again, that is the result. And final kissing was done to the ostial circumflex because there was some lesion in the circumflex. So we did the kissing of the circumflex, that left main kissing. So that's the final result again. So coming to the last case, he's a young 48 male, anti-LMI MI of 8-year duration, developed VT during hospital stay, DC shock given, ECG showed ST elevation in V2, V5, 1 AVL. Ejection fraction was 30%, and it is showed apicolateral and apicoseptal hypokinesia. So here is the angiogram. Thrombus has completely occluded the left main. We initially thought of some dissection, maybe dissection, but patient was in shock, so we tried to wire the LAD and circumflex. So wire initially went to some different artery, it was diagonal, and then we took another wire, and that's the angiogram. You can see that that dissection, that staining was increasing as we wiring the artery. So if you see the last diagram, you see the wire is in the diagonal, and you can see that some flow was, we were able to achieve some flow in the LAD. So at that time, the diagnosis is clear. We are dealing here with a case of left main aneurysm presenting as the MI. So it was 100% left main occlusion because of a large aneurysm. So here again, then we were able to wire the diagonal, we wired ramus, but we were not able to wire the circumflex. So circumflex, so here we took the he took the right angiogram, and it was circumflex was 100% occluded. So it was, we were dealing in the case of atherosclerotic left main aneurysm, which had circumflex was 100% occluded, and there is a large aneurysm. So here if you see this aneurysm data, so PCI is advisable once a patient is in ACS, unstable patient, single vessel disease, and a small vessel disease. Otherwise, patient is stable, large aneurysm, such patient should go for CABG. So here we decided for the PCI because patient was in shock. We can use the LV support device like IBP, Impella, ECMO, and here is a debate again using of DAS versus covered stent. We tried, our plan was to use the covered stent, but that covered stent was not available in the lab because of that last night case. In this perforation, we used almost 3 stents, 3 covered stents, so that was not available at that time. So we decided to go with a normal stent. So Promus 3.520 was deployed from left main to LAD. We were able to achieve some flow in both LAD and diagonal. So that is the flow. So we post-dilated again, we did the IVUS, and IVUS showed that there is large aneurysm around the stent, and it is full of thrombus also. So, but even after this stenting, patient is developing recurrent slow flow. We did the multiple thrombosuction runs, DILZAM, GP2A given, but we were not able to achieve the good flow. So at that time, somehow we arranged that covered stent, and we took 3.826 millimeter graft muscle stent, and it was deployed from ostial circumflex to up to the LAD diagonal bifurcation. Here we sacrificed the ramus because it was a small vessel, and circumflex was 100% occluded. So it was filling retrogradely by the RCS. So we deployed a covered stent from left main to LAD diagonal bifurcation. So we post-dilated it, and we achieved TIMI2 flow in LAD and diagonal. We did the IVUS, which is showing that covered stent, and it is obliterated the aneurysmal segment. So nothing was visible because of the double layer, nothing was visible beyond the stent. So we did the follow-up angiogram after 3 months. It showed TIMI3 flow in both arteries, and there was complete obliteration of the aneurysm after 3 months. So we published this case report in Village Journal, left main coronary artery aneurysm occlusion presenting as MI with cardiogenic shock and patient shaped at seeking the LAD at the cost of other vessels. So what are the recommendation of doing unprotected left main occlusion PCI? So procedure should be fast. First and foremost important thing is the speed. Unless there is critical downstream lesion, don't touch that ad hoc lesion. It can be staged later on, and IVUS should be used if it is available. And one another important thing is dual operator. First operator should focus on achieving the flow, and other operator should do the should start circulatory devices. And circulatory augmentation is must. If dual operators are unavailable, then circulatory support initiation should commence after the occluded left vein has been successfully opened. And further care and follow-up is needed because all such patients need intensive care and dedicated heart failure therapy after PCI. So to conclude, in hospital, mortality of such cases is always high, especially during the first day of admission, and without prompt reperfusion therapy and circulatory support, survival of such patient is virtually non-existent. Cardiogenic shock and angiographic success criteria plays a major role in predicting the outcome of these patients. Since the final TME3 flow was the only predictor of in-hospital mortality, every effort should be made to achieve this goal. Thank you.
Thank you, sir, for this beautiful talk on the left main cutoff, especially the last one, which is left main aneurysm. Now, I want to invite Dr. Dilip, sir, to present on the bridging therapy, which MCS to choose.
I think the last case was really amazing. The left main and out of the box thinking. So, you have to know how to perforate the covered stent if you're putting across the circumflex artery. So you have to keep a fiduciary wear in the circumflex because you can't see anything after putting a graft stent. And then perhaps you have to use the angle microcatheter with confine jet or Astato 14-like wear. But you could escape without doing that. But I mean, your circumflex obviously got closed, knocked up. But it's already occluded.
That's already occluded before at the time of the presentation.
So it was feeling retrogradely. It was feeling.
So we decided to cut off it.
Okay, then this is okay. Then it's okay.
Yeah. Good afternoon, everyone, and thanks, Dr. Pramod and Dr. Samshad for inviting me. This is about MCS, and we are going to have more good news about MCS in probably January mid, when our own Make in India MPLI will be available, and it will be unveiled in WAPI, I think, in 14 to 16 January. So these are my disclosures. So let's quickly go to some cases. So this is a case of elderly patient with critical left main circumflex LAD, and this was a surgically turned down patient. Patient was a relative of one of our critical care doctor. And then I had to do this procedure in 2014, I think, if I correctly remember. And then I had to use IABP in that situation that time. And finally, the patient went home with a good result. It was a culotte strategy was done. This was a patient who came at 18 hours of interval MI to our center. And this was the ECG. And this was the echo, and the RC was flowing, LAD. This was the result which we got even after giving all the cocktails and waiting for around 20 minutes. Patient was doing next day, quite well. So we thought we are through. This was in mid-COVID. But the day after, the patient developed severe pulmonary edema, ventilated, IBP was put on. The patient's augmented BP was only in 70s. pH was 7.21. We thought, let's see the angiogram. And this was the arrhythmia which the patient was having. The patient was having an atrial fibrillation. And we did the angiogram, and you can see the flow of the vessel. The LAD was flowing well, the diagonal was flowing well, but the patient's lactate was climbing up. And the pH became 7.13, lactate went to 7.3, and the patient was going downhill. So there was no way patient had a flowing artery after 3 days of myocardial infarction. On IABP, the lactates are rising, pH is deteriorating. Then we had only one option. We took the patient on ECMO, and then the IABP and ECMO combined was kept for 9 days. And this was the echo of the patient after, before the discharge. The ECG was well formed, arrhythmia was not there, and the patient made it. It was 9 days of. And this was the ECMO basically, saved the patient because the lactate was going up and everything was wrong at that time. This was another patient who had a bailout stenting done by me after bypass surgery. They came with acute coronary syndrome with a 25% EF,
And again, this time the patient was refused surgery with syntax of 25, and we had to put an impella in this case, and we had to tackle the left main and the RCA, which was a chronic total occlusion. This was the first case of CTO done in India on impella support, which I think I did in 2021. So these are some situations where we had to have a MCS, otherwise taking these patients out is difficult. This was again last case where the patient had a MI, and some other center the patient was called, our team, and we had done a ECMO. Our ECMO team did ECMO in the other center and brought the patient. We did the IBP here, and then we did the angiogram, and you can see the LED occluded. RC also had some osteal disease, and then we treated this patient on ECMO, IBP. We did a diagonal stent, and LED was treated with drug-coated balloon. So we didn't want to compromise the diagonal as it was in cardiogenic shock. We didn't want to close it and going for a bifurcation strategy. This patient had refractory VT-VF. Finally, the VT-VF settled down, but after 5 days, patient developed sepsis and lost the patient. But these situations demand a mechanical circulatory support system, and if we institute the MCS early, the chances of recovery of these patients can be very high. So MCS can be required in cardiogenic shock patients, protected PCI, malignant arrhythmias, or as a bridge to a cardiac transplant. So these systems are available with us at this moment. Hopefully by February we'll have our own impella, which will be ranging, the cost will be ranging around 10 to 15 lakhs, and we'll be using more and more of these devices. The present impella which is there, the only device which whose cost got hiked, the first case which I did was 21 lakhs, second case I did was 26 lakhs, and now they said it's 29 lakhs. So hopefully we'll be getting more and more impellas when the Merrill impella come in. So the IABP gives us a little support, 0.5 liter per minute to 1 liter per minute, mostly used in protected PCI. Cardiogenic shock, I think data is not at all. IABP shock 2 trial has refuted the benefits, and it has gone to class 3 indication. Impella is an excellent device, and it gives us 3 to 5 liters of flow, and there is a ease of going transaxillary in these patients with impella, and there we can also support the RV. So we need to see the what's the cardiac power output and what is the PAPI index, and then we decide which support is needed, LV or RV. And then there is a ECMO. ECMO is a very handy device available in many centers, and this can be used, and it has been used in many centers as a protected PCI measure. So MCS in protected PCI, a lot of centers are using ECMO when the LV function is good, because it increases the afterload. This slide I have put because this has given us or enabled us to think more and more of MCS. These are 2 endovascular devices used by me last month, and the one groin was having 22 French access, one was an 18 French access, and all these accesses were closed by 5 perclosure devices, 4 prostyles and 1 angioseal. And this is how we can safely go inside with an even ECMO. A cardiologist can do an ECMO with a proclosure, 2 prostyles, and then safely come out. And this has enabled us to take on more cases on MCS. We don't have much of evidence with in cardiogenic shock, but finally we have a danger shock trial which has come in, but it invites a lot of discussions. There are a lot of critical analysis of this trial, but we have finally one trial with impella in cardiogenic shock which gives us benefit in an RCT, and even if we have some contradictions, critical analysis, but we have got one positive trial. Registry data is very favorable with impella, and we can see here how the cardiogenic shock survival has improved from 60%, 50% to 77% now. And in PROTECT series of, in protected PCI, we have robust data from PROTECT series, PROTECT 2 and PROTECT 3. PROTECT 4 is ongoing, and we get a huge benefit in kidney protection and overall mortality when we use judiciously a protected PCI, an impella. This was the clinical expert consensus document, which is being cited numerous times in different publications on cardiogenic shock. This was, I was also part of this meeting and discussion when it evolved, and here we can stratify patients on whom we should be thinking of taking MCS, MCS, or rather Impella, while going for a protected PCI. This is a scoring system. And if we use these devices properly in time, say in cardiogenic shock stage A, B of SKY, if you use MCS, mortality can be better. So finally, rounding up, these are the indications or choices of MCS which according to me should be there. Acute infarctions, it has to be acute infarction, cardiogenic shock, it has to Impella. Otherwise, ECMO with IABP can support. Best is ECMO with Impella if we have. Protected PCI, we have evidence with Impella. From logistic point of view, ECMO is a good support for us. If we think of very high risk patients, IABP has less of, or I think we don't have much evidence. But patient with malignant arrhythmias, refractory VTVF, where someone who is going for a ablation in this refractory VTVF patients, ECMO is #1 choice of MCS there. It allows you to do your job without any catheter in the LV. You can take your catheters, you can ablate wherever the arrhythmia is coming from, endocardium, from inside, from epicardium, you can go in and do it. So these are choice of MCS according to me in cardiogenic shocks. Thank you so much for the patient hearing.
Thank you so much, sir, for enlightening us emerging technology of bridging therapy and advancement in it. So please take the seat. We can running late, so we can discuss this after this session. So now again we have some cases of Impella assisted complex PCI. So I'm going to invite the Dr. Dhananjay Kumar, who will going to tell us some case-based new emerging technology Impella, and Dr. Ravi Vishnu Prasad. Is not here? Okay. All depend upon the Dr. Dhananjay.
Good afternoon, everyone. So this was a case, 70-year female presented with 4 hours chest pain and shortness of breath. She was hypertensive dyslipidemic but non-diabetic. At presentation, her pulse rate was 118 per minute. Systolic blood pressure was 70 mmHg. Respiratory rate between 24 to 28. And SpO2 was ranging between 88 to 90% on full oxygen. She presented in midnight and her ECG was suggestive of anterior wall MI, echo RWM in LAD territory with ejection fraction of 30% with mild grade of MR. So immediately we took her for angiography. You can see there is some plaque at the LAD ostium. The LCX is critically stenosed. The RCA is critically stenosed in mid for a diffuse length of lesion. And there is no appreciable plaque in the left main. So under the support of IABP, we didn't have availability of in-house Impella. So we started with this, with IABP, we did this primary PCI, and there was good flow in the LAD after primary PCI. The patient remained in shock. So the chest pain subsided, breathlessness persisted, even on the patient remained on the NIV support. SBP remained around 100 mmHg on IABP plus high dose of inotropes. And ST segment started settling, the echo remained the same, the eGFR was preserved, the liver functions was mildly deranged. Even after 3 to 4 days, any attempt of winning from the IABP, the BP was again falling. We would have to increase the inotropic support, and the same cycle was repeating again and again. So we decided, we talked with the CTVS surgeon. They were not ready to do anything. So we decided to do complete revascularization with Impella, but I would like to some comment from the chairpersons.
Yes, sir. Hazrat, sir, please.
I think, shock is a difficult subset. Though people have said the IABP do not work, perhaps it works. In IABP shock trial, if you have a 5 years follow-up now presented by Greg Stone, those who have survived and has gone angioplasty, their long-term mortality is much lower than your placebo arm. Now, if you have the MCS facility available in your lab, you have a one set of mind state, like Medanta, Dr. Praveen Chanda or Rajni sitting here. If you have Impel available, an affordable patient, we will take out Impel and do the case.
Sir.
But if you do not have Impella, then definitely IBP should be tried in all patients, large stent. And the outcome is guarded. Whatever you do, the shock patient outcome is guarded. You can put a stent there. You can do a drug-coated balloon. Whatever you may do, he may come back, may not come back. That should be explained to the patient.
So, I am completing my section. So, I did this complete revascularization with the support of Impella CP. I started with the RCA. The RCA was calcified, but it yielded with the cutting balloon, and we can appreciate the calcium. It is almost all around, but I was able to fracture it with the cutting balloon, and this was the final outcome of RCA. Then we did the plastic to LCX. Same, the calcium was there, but it yielded with the balloon anchoring support to the LAD and cutting balloon. Yes, and now I did IVUS to LAD, and the previously stented which I did during the primary angioplasty. The segment was looking like it is normal, but you can see there more than 50% plaque in the proximal segment of the stent, and 20 to 30% of plaque at the left main ostium. So we as well as 70% of plaque in the left LAD ostium. So we decided to go from the left main ostium to LAD up to the proximal segment of the previous stent, and yeah. So this was the final outcome. The patient, it is now, it has been more than 1 year, and patient is doing very good. We removed the impella after 14 hours, and patient did well. For the sake of discussion, for the high risk PCI, I am putting one second case. It was a 36-year male patient, post ACS, ongoing angina with shortness of breath, a smoker with no other comorbidities, mildly dyslipidemic on the evaluation during the hospitalization. ECG was left main equivalent, RWMA in LAD, the EF was 32%, in heart failure, off and on supraventricular tachycardia, SBP up to 100 without inotropes. Saturation was
quickly go
on
to the
NIV.
case because the time is up.
Yes, sir. And the ECG, CAG was done outside, and he was referred for emergency CABG, but CTVS did not. So this was I have the only, during the intervention, this was the left system. You can appreciate the left main is critically stenosed. The LAD is totally cut off from the proximal part. The LCX has some lesion in the osteoproximal segment, as well as the OM has some lesion. And this was his RCA. RCA, it is dominant, but there is significant lesion in the mid part. So, and in the young patient, the CTBS surgeon was not doing anything. We did his complete revascularization with the help of Impella, and it has been now more than 6 months at least, and he is doing good. So all these things Dilip sir has already discussed. So thank you so much. Thank you so much for my side.
Thank you very much. We'll go to the second case. We'll have more discussion later on. Okay.
Yeah, I would like to call upon the Dr. Shemlol Umesh, who is going to tell us initiating the 24/7 STEMI program. I hope it will come in our country also.
Yes.
I think that's what I was going to do. So my friend Umesh from all the way from Mauritius thorough gentleman, very friendly, very interested in knowing the things, teaching the things. And let us hear from him what he does in his country, the country of Mauritius. Over to you, Umesh Agarwal.
Thank you, sir, and good afternoon, everybody. Thanks to the organizing team, Dr. Pramod Kumar, Alam, and the whole team for giving me this opportunity to be here. So I'll be presenting 24/7 primary PCI, how I initiated it in Mauritius, and what is the impact of it in the public sector, because I am a doctor who works in the hospital and we work in the private sector at the same time. So I will talk today of implementation of 24/7 primary PCI in the public hospital, which is on a free basis because all our hospitals, all the treatment right from admission till discharge is on a free basis. So how was our initial experience and what we gained from it? So if we go by any guidelines, be it AHA, ACC, ESC, or any local guidelines, they all say only one thing, that in STEMI, which looks like that on an ECG as compared to a normal ECG, earlier the culprit vessel is opened, better is the immediate, short-term, and long-term outcomes. In MI, minutes means muscle, and we should strive hard and try everything to open the artery as fast as possible. We all know there are two ways to open the blocked coronary artery, either by thrombolysis, which is the medical management, or going to the interventional, where we do our PCI, angiography, and angioplasty. So in all of our hospitals, thrombolysis was still used in most of our 5 centers. Coronary angiography was never done before discharge, and the patient was put on a waiting list for coronary angiography. Then a decision was made whether to do PTCA, go for CABG, or just be on medical treatment. So if we go by this slide, it is a very busy slide, but we are going to concentrate only on the primary procedure. So angiography with follow-on primary PCI is offered to patients presenting in 12 hours of symptoms, and PCI can be delivered in 120 minutes. That means 2 hours. So, or in patients who are presenting more than 12 hours of symptoms and continuing myocardial ischemia or in cardiogenic shock. So if we choose to give primary PCI, a drug-eluting stent is preferred over a bare metal stent. And if the patient is in cardiogenic shock, we do only the culprit vessel. And if the patient is stable after primary, we can go for the elective lesions if we have. So going by the NICE guidelines 2020, upon first medical contact of a STEMI patient, ECG and diagnosis should be done in 10 minutes. In non-invasive centers, in 10 minutes thrombolysis should be started. And in PCI-capable centers, angioplasty should be done within the first 2 hours, and the wire crossing should be done within 90 minutes. So if a cath lab is available, primary PCI is a preferred treatment because the artery is open under vision, so the chances of failure are very less. There is lesser risk of bleeding than with tenecteplase, and immediate relief of symptoms is received as soon as the artery is opened. So before 1st September 2020, our cath lab used to be open from 9 to 16 hours. Only cold cases were done. Streptokinase and later tenecteplase were used to thrombolyze the patient. The patients were stabilized and angiography was deferred and the patient was put on a waiting list. Then a decision is made for the type of treatment. The cath lab used to close after 4 p.m. on weekdays, and on Saturdays at noon, and on Sundays and public holidays it was altogether closed. And in cases of failed thrombolysis, patients were transferred to PCI centers, which were 2 in the country. So that depended whether the cath lab was available, place, and of course on the mood of the doctor who was on call. Some patients passed away on the way before reaching the hospital or after doing coronary angiography. Minute means muscle in STEMI, and precious time was lost just transporting the patient from one hospital to the other. So this is a center where I work. Actually, it is situated in the capital of Mauritius, Port Louis. And I was sort of lucky to be surrounded by a dedicated, young, and dynamic team, but they were all not competed. We didn't have any idea of doing primary angioplasty. But they were all ready to take the challenge to start the primary PCI on a 24/7 basis. So it was, I had 2 consultants, 3 specialists and myself. So we 6 cardiologists, we decided we are going to start our 24/7 primary basis. So since 9 years, no primary was done. Streptokinase and later tenecteplase was used. And on 1st September 2020, when I took charge of our cath lab, I became the head of department. So primary PCI was started at least from 9 to 16 hours because we have to get special permission from the ministry to open our cath lab after working hours. And it took us 9 months at least. And on 21st June 2021, we got a 24/7 primary PCI pilot project to be conducted in my hospital by the Ministry of Health and Wellness. So this was my first day as boss, and then I got a patient of 40 years old, uncontrolled DM, smoker, and then he started having epigastric discomfort since last night, and then he started getting central chest pain since an hour. He had a malaise, he lost consciousness, he was unable to speak, of course, and then when he regained consciousness, he was brought to the hospital by his colleagues. And this is what his ECG looked like, so we can clearly see it's an anterior wall MI. And we decided, so we were at that point where whether to thrombolize again or to go to the cath lab. And we decided to go to the lab. And this is what his right coronary artery is. And we can see the LAD is closed. And as soon as passing the wire, it opened and we did a direct stenting. And this is a result. So we can see there is a very easy flow. And it took us around 15 minutes only to do the case. And this is what his echocardiography looks like. I think the slides are not running. I think I got some problem with the slides.
I think you can conclude. Last slide. Perhaps it was the last slide.
So just to tell you that the procedure was successful. The slides are not running. The procedure was very successful, and then the patient was discharged 2 days after. That means on the 3rd day, instead of keeping the patient for 3, 4, 6 days or a week. And the patient is still alive. He's leading a normal life with an echocardiography, which is perfect. And during this case, we participated in numerous competitions, and then we got awards also, the Golden Award in the Public Service Commission of Mauritius. And since 2020 till now, we have done around 650 cases of primary PCI in our center, in our only center, in my hospital, and we have 5 hospitals like that. So roughly around, we do around 30 cases of primary PCI a month. And it has been a very good success story. And the most important thing is, like, when we thrombolize a patient, anyway, we have to do an angiography and angioplasty afterwards. So if we take it takes us the cost of an thrombolysis, the risk that we take, and if the patient is not, the artery is not open, he can go in failure and he will end up with 6, 7, 8, 10 medications. When we do primary PCI with a newer stents, with shorter DAPT, the patient is going to have a normal EF, and then he will be at least at most on 2 or 3 medications for lifelong. So primary PCI, it brings a lot of change in the patient's life, in his family life, personal, professional, and to the country and to the system as a whole. We should take the initiative, especially the young generation of cardiologists, to do primary PCI, because this is the only way we can have a normal EF, and the person who has done an MI can live as a normal person in his daily, day-to-day family, personal, and professional life. And the whole system and the country gains for it. Thank you.
Thank you, Dr. Shamlal. I want to congratulate for initiating this 24/7 STEMI program in your center, and it truly reflects your commitment and the dedication towards the patient care. Now I want to conclude this session so that we can, as we are running short.
Yeah. So, you know, the reason we met Dr. Umesh in Delhi last year this year only. And we were very keen to have him here. You know, for the simple reason that one person actually has changed the whole scenario in Mauritius, and we would like that to be repeated all over the country. I mean, in Bihar also, we are still facing a big problem. I'm sure West Bengal is facing the big problem. So we want every center to have somebody like him to take the initiative, take the challenge, and start the primary PCI program. And as far as I'm concerned, primary PCI, if you are not doing as an interventional cardiologist, I think it's a criminal act. This is a procedure which must be done everywhere, everywhere. If you have a cath lab, you must do it.
One question. Hello.
I just wanted to add up to whatever you said. I always told my boss who was here that this is criminal. We have a cath lab, patient is coming with an MI, and we are thrombolizing the patient. We are sending him home and calling him on a waiting list. This is, as you rightly said, is criminal. And the day when I got the chance of changing it, I changed it. And I can tell everybody present here that I had no experience in doing primary PCI. But we had to take that challenge, and it paid off for everybody, for us, for the community, for the patients, and for the health system as a whole. And it should be encouraged everywhere.
Yeah. Last question from Sumit. One question with Hajra, sir. What should be the mindset of young operators working in the peripheral part of country for primary angioplasty? Suppose we have situation in proximal LAD, 100% cutoff with proximal thrombus, and another is between 90 to 99% lesion with distal slow flow. What should be the mindset of the operator?
So 90% other artery?
No, same in LAD. One is 100% cutoff, and another is 90 to 99% and distal slow flow. So that whenever we wire the lesion, immediately it gets stuck and patient get compromised. So what should be the mindset prerequisite? Can we do?
Thrombosuction, definitely I'll do it since it is proximal. Thrombosuction by penumbra, strong if it is available, laser if it is available. And sometimes if you do not have any of these, you can just do a plain balloon angioplasty, see the flow. If the flow is compromised, wait for some time, give vasodilator, treat both 90% distal, first distal, then proximal. If patient is very elderly, you can use DEB also sometimes in primary. So if you really want to avoid stent, you can use a drug-coated balloon. Thank you.
Thank you, sir.
Thank you, sir. So we are moving to the next session, so nightmare and challenges. So we are dividing nightmare challenges in two parts. Two presentations we are having as of now, then we will be having inauguration, and the rest of the presentations of nightmare we are keeping it in second half to keep the second half also more interesting. So I am going to invite Dr. Anshu Agrawal as a chairperson, Dr. Amit Kumar Jha as a chairperson, Dr. Vijay Kumar Trehan as chairperson. Our moderator will be Dr. Rajiv Krishna sir, and as a panelist I am going to call Dr. Dhananjay Kumar from Haryana, ex-KGMU alumni, Dr. Sumit Shankar, Dr. Adil Ahmad Khan, and Dr. Manas Thakur. Dr. Anshu Agrawal, I think he is not available, and Dr. Vijay Kumar Trehan sir had his flight. So I will call Dr. Aditya Bhaskar boss to chair the session, and Dr. Rajan Narayan sir to chair the session on night medicine session. Dr. Sumit, can we have you here? And Doctor, I would like to ask Dr. Jyoti to join us. So over to Dr. Dipankar, boss. He is from Guwahati and he is giving his presentation on stuck rotabur.
Good afternoon, everyone. Thank you, organizers, for inviting me and giving me an opportunity to present a case here. So I have named the case as failed attempt at one, stuck at another. So it became a double whammy for us in the cath lab. So my case is a 73-year-old female who weighed only 48 kg, non-hypertensive, had COPD, non-diabetic. She was complaining of chest pain since the last 1 week, and she presented with features of LVF, and her troponin was positive. So echo revealed that her ejection fraction was 40 to 45%, and creatinine was 1.82. So we diagnosed her as a case of ACS and STEMI, and then took her for angiogram. And we did angiography using the right radial route, where a 5 French Tiger catheter was hooked. And this is the angiogram. You can see that this is a long left main. Distally, there is heavily calcification. And LCX is 100% stenosed. And LAD from austere to distal, austere to mid, we had a severe calcified lesion, and around 90% stenosis was the maximum. In aleocranial view, you can see that the distal LAD was okay. The proximal, the mid part was heavily calcified. In aleocaudal view, if we can see nicely, we can see that the proximal part after the initial OM, the LCX is 100% stenosed, and it looked like this is the culprit vessel. So the right RCA was also diseased. So our plan was now whether to send the patient for CABG or whether should we attempt PCI. Now, because the weight of the patient was very less, creatinine was high, and she was having features of LVF, the surgeon said that it is better to go ahead with angioplasty. So our initial plan was that we should try doing the LCX first. So we'll take a microcatheter, park it distally in the LMCA, and then try to cross the LCX. But the moment when we hooked it with a EBU 7 French catheter through the right femoral artery route, the moment we take the microcatheter distally and try to wire the LCX, the patient would have severe hypotension and would become very restless. We tried for quite some time, pulling back and forth the microcatheter, but eventually we thought of just leaving the LCX and just go ahead with the LAD. Although LCX was the culprit vessel, but here securing the LAD seemed much safer. So over a microcatheter, because there was heavy calcium, so LAD cannot be done like that. We had to modify the calcium chunk. So over a microcatheter, we exchange our workhorse wire with a lot of floppy wire, and then we tried doing the burring with 1.5 mm bar at 1,50,000 speed. So we tried to do with packing movement, but after a few runs, we were unable to cross the mid part, and our bar got stuck. So once the system stalled and the bar got stuck, and then we tried pulling it, but it was not coming. So we tried for some time, and then eventually what we did is that we cut the shaft of the rota ablation, and then we take a guide extension catheter till as much deep as we could, and then we had to use our force to pull back the system. We also tried in the meantime to take another puncture and to wire from the side of the bar, but that could not be done. So what we did is that we applied force with the guide extension inside, and somehow we were able to retrieve the bar, the stuck bar. After retrieving the bar, luckily when we did the angiogram, we saw that there was no damage done. The LAD was still flowing, but the calcium was still there. So now the thing was whether should we continue more, or we should try, or we should quit. So we just thought of, let's take a 312 balloon and just see whether it crosses or not. To our surprise, the plaque may have been modified with the rota bar. So 3O balloon crossed, and then we were able to do the pre-dilatation. So from the mid part of the LAD to the proximal part, we did pre-dilatation with 3O12 balloon. So after that, we took a Wolverine cutting balloon over a guide extension catheter, and then we inflated it up to 10 to 12 atmospheric pressure. After the using cutting balloon, this is our angiogram. So thereafter, over a guide extension catheter, we took a stent 3.532 from the mid LAD, and this is the angiogram after our implantation of first drug-eluting stent. Thereafter, we went for LMCA to LAD with 4 into 37 mm dash, and after confirming the position in multiple views, we deployed this stent. So during deployment, we can see that it looks that there was a good expansion, and this is the angiogram after deployment. Post-dilatation was done with 412 NC and a 510 NC balloon at 16 to 18 atmospheric pressure. And then we did with 5 into 12. This is our final angiogram. You can see that there is TME34 in the LED. The L6 is already not there. And this is the caudal view. Now, we did not have any imaging to see whether the balloon was expanded or not. We had some cost constraint with this patient. So, for a case of such stuck bar, what we can do is that we can use a second guiding catheter and try to wire it through the side of the bar. Otherwise, we can cut off the sheath and remove the outer cover of the rotablator, and then try to pass a guide extension catheter and try to pull as much as possible. Sometimes we need to deeply intubate the guide also, and then try to pull. Thank you.
Thank you, Dipankar. I congratulate for doing such a complex case. What I think the reason behind the success in this case is, I think the distal left main was the culprit lesion, and before the rota got stuck, it has done some work because your 3 NC passed smoothly. So it has saved a little bit, although it got stuck. Later that the cutting balloon and all did the job. So I think it's a wonderful case, and my question is, what is the another approach? Suppose if we could not retrieve the rota, then what we could have done in a different way?
The final is CT surgeon only, but another thing is that we could pass the wire to the side and then slowly dilate it and then make a space for the bar and then try to pull it out.
We can try to pass the wire beside the bar, try to inflate a small balloon, and then we can put it. Thank you. Any comments from panelist moderator? Any question from the audience? Thank you, Dr.
So next presentation we will be going with Dr. Aditya Bhaskar. So I will request Dr. Dipankar to stay on stage and chair this session.
Yeah. Thank you. So good afternoon, everyone. My case is post-MI aneurysmal VSR that was managed percutaneously. So my case is 63-year-old hypertensive male presented to outside hospital with complaints of chest pain and dyspnea since 2 days. Evaluation outside revealed inferior wall STEMI, which was complicated by a cardiogenic shock, pulmonary edema and AKI. After initial stabilization, CAG was done outside, which revealed single vessel disease in form of proximal RCA was 100% occluded. 2D echo done outside revealed vessel VSR with left to right shunt. Patient was referred to us for definitive treatment. So on arrival, patient blood pressure was around 70/50. Patient was tachypneic, having raised JBP, bilateral creps and pansystolic murmur. After some stabilization, we took him for 2D echo. So in 2D echo, in apical 4-chamber view, we can appreciate that there is an aneurysmal VSR. There is a separate entry, then a big aneurysm, and then an exit. There is also associated some mild mitral regurgitation, mild tricuspid regurgitation. If we see the basal short axis view, you can appreciate that this is a very complicated VSR with a, it will come next. So this is a complicated VSR with an entry, with an aneurysm and exit. So to summarize, we have a post-inferior wall MI with, we have to deal this VSR with an entry, aneurysm and exit. So how to deal it? So patient was initially managed with inotropic supports, diuretics, antibiotics. Creatinine was 3.0, although having some good amount of output around 50 mL per hour. So after stabilization, patient was actually admitted under CTVS. So the heart team decided to go ahead with percutaneous closure and surgery only if device fails, which was very likely due to the complexity of the anatomy. So we planned for device closure. The challenges were shock, pulmonary edema, AKI. This is a type 3 VSR, and anatomy was not at all suitable for device closure and occluded RCA. So we started with 6 French femoral arterial sheath and 7 French right jugular venous sheath. So we tried to take LV angiogram, but the defect was so large that my pigtail somehow entered into the right ventricular cavity. So finally we crossed the LV to RV without any difficulty, and we tried to park our wire in the right pulmonary artery. After parking our wire in right pulmonary artery, we exchanged it to the employer extra stiff wire. Then from the right internal jugular vein, we took an in-snare and we took it to the right pulmonary artery, and we tried to snare it. After a few unsuccessful attempts, we finally was able to snare it through the right internal jugular vein. So somehow we formed this classical AV loop. So we have formed the AV loop. Now we have to deliver the device. So we first took 14 French delivery sheath, which from right internal jugular vein, RA, RV and via VSR, we took the sheath into the left ventricle. We opted for 32 mm ASD device, the LifeTech Sera device. Actually, we have not able to done the angiogram properly due to some problem in the power injector. So we took this 30 mm based on the echo. So we took the device to the left ventricle, and once the LA disc is deployed, patient having multiple runs of ventricular tachycardia. Somehow it settled, and finally we revealed the LA and RA disc, and we took an LV angiogram via pigtail catheter. You can appreciate that this device is sitting in the interventricular septum, but there is some residual leak. We planned to upsize the device to prevent that residual leak, but because there were two factors, means whenever we are taking any device to the LV, there were runs of ventricular tachycardia, and just upon keeping the device in interventricular septum, there was immediate improvement in hemodynamics. Initial BP was around 80-90. Just putting the device, the blood pressure rose to 120/80. So considering these one positive factor and one negative factor, we tried to deploy it here, and we deployed. Finally, fortunately, the device stuck in place. On table, there was immediate improvement in hemodynamics parameters once device was placed, even without releasing. So we ignored the residual leak and deployed the device. Patient was shifted out on minimal dose of inotropes. We were very happy, but unfortunately, in next morning there was hematuria, and it was expected because of the residual leak. So we gave blood transfusion, and the AKI started worsening. The creatinine rose to 6. But somehow, this is the post-op 2D co-screening. So we can see that device is fitting properly, and there is some residual leak. There is some change in orientation, I don't know how, but the device was sitting properly. So conservative management was adopted. There was fortunately gradual improvement in hematuria, hemoglobin level and renal function. Patient clinically stable and mobilized before discharge. So this was the follow-up echo after the 1 month. Device is sitting properly. There was some residual leak. So post-device closure hemolysis, etiology is high velocity jet through the residual shunt or around device edges, leading to RVC trauma and leading to hemolysis. The clinical features is hemoglobin drop, hematuria. The management is supportive care. Sometimes the residual shunt may be treated by another device. Reintervention is required if hemolysis is persist, and even if the hemolysis persists, then we can opt for the surgical removal of device and closure by surgery. So take home message is percutaneous closure of VSR in high risk case is an acceptable and feasible option with CTVS backup. Sometime accepting the fair result reasonable, we accepted the residual leak because our hemodynamics parameters was improved. Known complication bound to happen, and we are lucky enough to manage this conservatively. Thank you.
Any questions, discussions, moderator? Any comments?
Hello.
nicely managed case, very good. What are the chances of having device embolization if we are doing post-MI BHD closure?
Actually, we after deploying, just keeping the device, we pulled many a times, and by
More
tug
than
test.
normal cases where there is non-infrared BHD, then it is more in this case, or it's almost equal in both?
No, the post VSR device closure always risky because the edges are friable. They are not very tough. Just 5-4 days before, we could not put a device in apical VSR because edges was not supporting. So there is high chance of immobilization, device mobilization. But we had CTVS surgeon in the cath lab also, that in case of any like mobilization and all, he can take directly to the cath lab.
Sir, what about revascularization?
Yeah, revascularization role is dicey. Sometimes they say that revascularization will lengthen the procedure, will increase the dye load because they think that the territory is always already infected. But there is one theory that this revascularization sometime may improve the semi-viable type of myocardium and may increase the device success rate. But it is not very clear cut that we should always revascularize or not. But sometimes the dying myocardium may improve and may give device or edges more stability. So this is a doubtful thing to comment about.
Thank you, everyone. Thanks, Dr. Das, and thanks, Dr. Bhaskar, for the fantastic cases. So I think we come to the end of the session.
Yeah, we come to the end of the partial part of this session. The partial part we will cover in the second half to keep the second half more interesting. And thank you, everyone, for joining us. Next we will move on to our next session. In between we will be having felicitation and the downwards at the chairs also. So we are moving to the Dr. Prabhat Kumar Memorial Lecture for Cardiac Surgery. Our moderator, I will request Dr. Ajit Pradhan sir to come over the stage. I will request chairpersons Dr. Sunil Kumar sir, Dr. Sanjeev Kumar sir, Dr. Sheel Avnish sir, Dr. Anuj Kumar sir. I will like to call our panelists, Dr. Amir Kazmi sir, Dr. Kunal Krishna sir, and Dr. Mayank Arya on the stage. And for delivering this lecture, we will be having none other than Dr. Naresh Trihan sir and Dr. Ajit Pradhan sir. He will introduce Naresh Trihan sir. Over to you, sir.
Thank you, Samjan. Good afternoon, Adab. It's a profound honor for me to introduce the first Dr. Prabhat Kumar Memorial Lecture. And truly, it's the most fitting tribute that this inaugural lecture is being delivered by none other than India's most celebrated and renowned cardiac surgeon, Dr. Naresh Trihan. डॉक्टर प्रभात को गुजरे लगभग 4 साल हो गए, लेकिन आज भी यकीन नहीं होता कि वो हमारे बीच नहीं है। एक मुद्दत से तेरी याद भी आई नहीं हमें, और हम भूल गए हो तुझे ऐसा भी नहीं। प्रभात सिर्फ एक दोस्त नहीं, एक नायक था, एक नेक दिल सच्चा इंसान। इतने कम उम्र में उसका चिकित्सा जगत में योगदान रहा, वो बेमिसाल है। बिहार को उसकी बहुत ज़रूरत थी और बिहार उसके जाने से गरीब सा हो गया। एक बेहतरीन चिकित्सक, बिहार का नामचीन हृदय रोग विशेषज्ञ था वो। जरा से भी अहंकार नहीं था उसमें। किसी भी वक्त कोई मरीज आ जाए, प्रभात वॉज ऑलवेज देयर फॉर हिम। पेशेंट फर्स्ट, यही उसका धर्म था, और इसी चीज़ ने तो उसकी जान भी ले ली जब ड्यूरिंग दोज painful days of corona when he was looking after these patients, और उसी में लगा रहा। दिल के मरीज उसका मुस्कुराता हुआ चेहरा देखकर ही अपना दिल उसे दे देते थे और सुरक्षित महसूस करते थे। He was very soft spoken. I never saw him angry or irritated. उसका यूं चला जाना आज भी दिल को रुला देता है। रहने को सदा दहर में आता नहीं कोई। I need 2 minutes to speak about you, sir. आप बैठ जाए। रहने को सदा दहर में आता नहीं कोई, जाना तो हम सभी को है एक दिन, मौत उसी की है करे जिसका दुनिया अफसोस, वरना ये तो दुनिया में सभी आए हैं जाने के लिए। Dr. Prabhat Kumar will forever live in our hearts and in every life that his healing hearts once touched. और हम डॉक्टर प्रभात की यादों और उसकी महान विरासत के साए में एक ऐसे शख्स को सुनने जा रहे हैं जिनने कार्डियक केयर को नई बुलंदी, नई ऊंचाइयों पर पहुंचाया, जिन पर देश ही नहीं दुनिया को नाज है। लेडीज़ एंड जेंटलमैन, आइए तहे दिल से स्वागत करें, खैर मकदम करें पद्म भूषण डॉक्टर नरेश तिहान का, जो भारत के माए-नाज और मशहूर मारूफ और अजीम हार्ट सर्जन हैं। डॉक्टर त्रिहान कोई परिचय के मोहताज नहीं है। He has been a true trendsetter, a pioneer who not only transformed cardiac care in India, but made the world acknowledge that India's cardiac surgery is second to none. To introduce Dr. Naresh Tihan is an honor in itself. ये मौका मेरे लिए बेहद हसीन है, जिसकी खूबसूरती को लफ्ज़ों में पूरी तरह बयान नहीं की जा सकती है। हाँ, इतना जरूर कह सकता हूँ, गुलों में रंग फ़ज़ाओं में इत्र बिखरा है, गुलों में रंग फ़ज़ाओं में इत्र बिखरा है, हमारी बज़्म में एक महताब उतर आया है। मैं उनकी शख्सियत को बयान करने के लिए काफ़ी अल्फाज तलाश कर रहा था। From inimitable to peerless to unparalleled, सब शब्द कुछ छोटा सा पड़ जा रहा था। एक कहते हैं ना, तमसील व इस्तियारा और तस्बीह सब दुरुस्त, तमसील व इस्तियारा और तस्बीह सब दुरुस्त, उसका मिसाल क्या जो अदीमुल मिसाल है। इसका मतलब हुआ कि उसकी क्या मिसाल दी जाए जिसकी कोई मिसाल ही नहीं है। The language of metaphors falls short and the imagination finds no parallel. आपने मुल्क में जदीद हार्ट सर्जरी के एक नए दौर का आगाज़ किया। बीटिंग हार्ट सर्जरी, मिनिमली इन्वेजिव कार्डियक प्रोसीजर्स और रोबोटिक कार्डियक सर्जरी को भारत में मुकाम दिलाने में आपकी खिदमात संग-ए-मील की हैसियत रखती है। अफोर्डेबल एक्सीलेंस का जो नज़रिया आपने दिया, उसने इलाज को मॉडर्न टेक्नोलॉजी, इंसानियत और हमदर्दी से जोड़ दिया। मेरी पहली मुलाकात आपसे 27-28 साल पहले हुई थी, जब मैं बिहार आया था अनडिवाइडेड बिहार का पहला हार्ट सर्जरी सेंटर कायम करने के लिए जीवक हार्ट हॉस्पिटल। एस्कॉट्स के लॉबी में सर के साथ घूम रहा था, जा रहा था, एक दरवाज़ा का एक छोटा सा उसमें कुछ खराबी थी। इन्होंने देखा, कहा कि उस बंदे को बुलाया, कहा कि आओ, जो इसको देखभाल करता है। कहा कि कौन है वो? कहा कि कल ही मैंने उसे कहा था इसको ठीक करने के लिए, अभी तक क्यों नहीं हुआ है। उसी वक्त मुझे एहसास हुआ कि अज़मत का राज जो है ना, बड़े कामों में नहीं, बल्कि छोटे बातों में स्टैंडर्ड और परफेक्शन को यकीनी बनाने में है। और इसी खूबी ने डॉक्टर त्रिहान को डॉक्टर त्रिहान बनाया है। आप न सिर्फ एक बुलंद पाए सर्जन हैं, बल्कि एक दर्शगाह है, एक इंस्टीट्यूशन है, जिसने सैकड़ों कार्डियक सर्जन्स को तराशा, हॉस्पिटल्स कायम किया और अपने शागिर्दों को बेपनाह इज्जत और बुलंद मकाम दिलाया। आज के दौर में ऐसे मोहसिन और उस्ताद, ऐसे गुरु कम है। मैं दिल की गहराइयों से डॉक्टर त्रिहान साहब का इस्तकबाल करता हूँ और दुआ करता हूँ कि खुदा आपको लंबी उम्र, अच्छी सेहत और तवानाई अता करे, ताकि इंसानियत आपकी खिदमत से यूं ही फैज़याब होती रहे। खुदा करे कि सलामत रहे दस्ते सिफ़ा। दस्ते सिफ़ा कहते हैं हीलिंग हैंड्स को। शेर हुजूर मैंने आपके शान में लिखा है, इसलिए आपकी तवज्जो चाहूँगा। खुदा करे कि सलामत रहे ये दस्ते सिफ़ा, इनके दम से इस दुनिया का दिल शागुफ्ता रहे। इन्हीं शब्दों के साथ मैं दावत देता हूँ डॉक्टर नरेश तिहान को अपनी इनॉग्रल स्पीच देने की, जिसका हम सब बहुत बेसब्री से इंतज़ार कर रहे हैं। बहुत बहुत शुक्रिया।
So keeping up the language adab, thank you. अच्छा, तो आप तो शायर बहुत ज़बरदस्त निकले, क्या बात। So good afternoon. इतना ही कहना था कि बुलंद, तो आप मिसयूज़ कर रहे थे वर्ड। आप ये बोल सकते थे कि ये बहुत शरीफ आदमी है, इसकी बात सुन लो, और दूसरा ये लेबरर है, सबसे बड़ा चपड़ासी। सो बुलंद की बातें छोड़ दे। अच्छा, सो thank you for coming, and I have the honor to talk about Dr. Prabhat Kumar, which is a lot has been said, but You know, there are legends of Bihar, and the two of them who I knew very well was Dr. A.K. Thakur and Dr. Prabhat Kumar, because they actually shone the light in Bihar when there was no light. There was this whole, conviction that they had that they wanted to do something for the people. So in very adverse circumstances, when it was even difficult to feel safe in Bihar, these people devoted their lives to actually enhance medicine at a level where till today we remember what he did and his attitude towards the patients, the honesty with which he is legendary for. And even whoever I've met always said, Prabhat Kumar ji was the most ethical doctor in the area. And the fact that he accomplished in spite of all the odds is something worth remembering for all of us and taking a lesson from it also, because today there are too many distractions which may actually detract us from that same point of our dedication to work, our ethics, the integrity of medicine, all these things that we talked about. I think if we collectively can uphold it, that would be the best tribute to Prabhat. And ma'am, it's unfortunate that we lost him, and to a very mysterious disease that came our way, which nobody actually knew what was the real impact of it. But you're fortunate to have had him for the years and the fact that you can have the memories of a great man. So our tribute to you also. Today, I was just asking that in our cardiac conclave, the experts are all sitting here, so I can't add much except, our friends are doing extremely good job at Medanta with Dr. Prabhat Kumar and his pediatric team. It's an amazing realization for me also that this quality of work is being done and can be done in Bihar. I'll tell you why. Just today somebody reminded me of this idea that how did you think of Bihar? So I was lecturing at Harvard once, and an American professor in his American accent jumped up and said, I can see you'll go back and you'll do this and you'll do that, but what about the Bimaru states? Now, I had already been in the US for over 20 years. I didn't know what Bimaru states, what it was. So I said, could you please tell me what Bimaru states are? So he rattled off all the names. So the first thing we did was, of course, establish Haryana, but the next step was Lucknow. Lucknow for two reasons. It was UP. UP was part of Bimaru. And also I studied in Lucknow, so it was familiar territory for me. So we said, let's take the step. And we got so criticized by our financial partners that what are you doing in tier 2 cities? This is only a loss making, have you lost it? You won't believe. I just had the belief that we will do, it is needed, and that's what the next step was, Patna. When the opportunity came, I was in one meeting, I signed the documents. I said, this is a PPP with the government. Nobody wanted to do it. They said for two things. One, whoever goes to Patna, and the second was do a partnership with the government. That's insane. But thank God to all of you, actually. Thanks to all of you who have actually made it happen. And it's the people. My main principle was we go where we are needed, rather than go to a chase lucrative markets only. So that's why I think this has been a very good experience for us. Then we went to Ranchi and to Indore. So that all the underserved areas, we have had a very good experience and gratifying experience more than anything else. So I think following in the example of Prabhat, if he could shine the light so many years ago, and son of the soil here, Pramod, I must say that there is something in the water of Bihar that makes you be this way. This is fantastic. So Sandeep, let's take some water back with us. एक बाल्टी ले चलते हैं दिल्ली में सबको पिलाते हैं. It's something which is wherever. See, I'll give you two examples. I studied at King George's Medical College. While we were in college, I never thought we'll become something in life because of the environmentally we were like that. Okay. One would never believe that people from Bihar, from the old Bihar, wherever they have gone, they've reached the top of the world in their profession, no matter what, like also from King George's. So the two most unlikely areas from where I thought people would be running like the most successful institutions are from here. So with that, I don't want to stand. There's lunch. I'm sure everybody is thinking of that right now. And so Prabhat, we shouldn't delay it any further. Let's do whatever honors we have to do and let's break for lunch. But thank you for your indulgence and good luck. And I wanted to suggest that AI today is going to be a major component of our life as we move forward. I'm told there was a short lecture by somebody on AI, and there is a room for it. We need to, it's a tool which we need to master. It's like what they say, conquer the tiger, but we need to and not feel scared or by any way or means shirk it, because the world will pass us by if we don't. So we are already using a lot, trying to develop the algorithms, and we'll be very happy to share with all of you in the coming months. Thank you so much.
Thank you, sir. Thank you, sir. I will like to ask Trehan sir to felicitate Shubhra Singh ma'am, Prabhat sir's wife, who is here with us. And I would like to request Pramod sir to felicitate Dr. Naresh Trehan sir. We will request Dr. Trehan sir to, if possible, to stay for next 5-10 minutes, because next presentation we will be having Dr. Mayank Arya on robotics cardiac surgery. Yeah. Dr. Arvind Goyal and his team, Dr. Mayank Arya is a cardiac surgeon, is his team, and he will be presenting a case of robotic CABG to us. Okay. So after this presentation, we will be having the inauguration session. Some technical glitch is there. So we are moving forwards for inauguration. For inauguration, I am going to invite Dr. Naresh Tehan sir himself, Dr. Pramod sir, Dr. Ajit Pradhan sir, if he is here, Dr. UC Samal sir, Dr. James Nolan sir, Dr. Rajan Narayan sir, Dr. Shamlal Umesh sir, Dr. Ravi Shankar sir, Dr. Praveen Chandra sir, Dr. Virendra Prasad Sinha sir, Dr. Arvind sir, if he is here, Dr. Arvind Kumar sir, if he is here, Dr. Ajay Kumar Sinha sir, Dr. Rajneesh Kapoor sir, Dr. S. Chatterjee sir, Dr. B.B. Bharti sir, Dr. Rajiv Agrawal sir, Dr. Sanjeev Kumar sir, Dr. Arvind Goyal sir, kindly join us on dais. I also request Dr. V. Surya Prakash Rao sir, he is also with us. Dr. Ajit Mulasari sir, kindly join us for the inauguration session. So, thank you everyone. We are moving to our next part of the session. Lunch we are postponing for almost 25 to 30 minutes, and it is a running lunch. If somebody wants, he can join over there in the first floor. We are moving on to the structural intervention session. So I call Dr. B.B. Bharati sir to moderate this session. Our chairpersons, Dr. U.C. Samal sir, Dr. Vipin Kumar, he is not available, Dr. Sumit Sajol sir. We will be continuing this cardiac surgery session just after presentation of structural intervention. We will be having one presentation of robotic, because some flights have been preponed. Dr. Neeraj Kumar sir, as a chairperson.
इसी में करा दो ना, इसी में
डॉक्टर प्रवीर सिन्हा सर,
ये छोड़ दो, ये भी छोड़ दो, ये है ऐसे कम, तो ये खत्म कर दो.
डॉक्टर अमित कुमार, if he is here.
कैल्शियम वाला बंद कर दो. कौन है स्पीकर देखिए?
डॉक्टर दिलीप
है, खाली एक उसका लेक्चर करा दो, बाकी छोड़ दो.
डॉक्टर अशोक,
अच्छा ठीक.
So I hand over the session to B.B. Bharati sir to conduct further proceedings.
Actually, we are now to start the most exciting session, the structural disease session. We know that initially the most of the cases done by the surgeon, but last few years we are doing the many of the surgery case by balloon, by catheters, and this is the main advancement in the recent time in the cardiology. And today we have a Dr. Praveen Chandra. This is a name, internationally reputed doctor, and is the director of the Medanta, Delhi. And today he will speak about the post-surgical AVR failure, how to treat evolution of the valve in valve. That is one of the recent development, even the failure of valve post-surgically, which is a prosthetic valve, and how will treat not by the surgery, by another valve. Dr. Praveen Chandra sir.
Thank you, Dr. Bharti, and I think this is a wonderful program which has been organized here, and I am glad that I am attending this program and participating. So today I am going to take you through the new era of coronaries which has progressed, we saw in the morning, and the structural heart intervention, which means the valves of the heart. And I am just trying to tell you that almost every valve we are treating today, and the most important one where we started was the aortic valve. And in aortic valve, the native valve we treat, but today I am going to discuss about valve in valve, which means where a surgery has been done earlier and now the patient is having symptoms because of the failed bioprosthetic valve. And as you see here, we have evolved also in TAVR, which is transcatheter aortic valve replacement, with so many valves. So we have to make our selection also, and we have to choose which patient to treat when. So in India, it has now progressed. Many centers, more than 200 centers have done TAVR today, and I think more than 5,000 cases have been done. And 10% of our cases are actually TAVR in a failed bioprosthetic valve. So that is the current situation. And of course, that means that it is not a new procedure we have been doing, and we did in Medanta also a couple of them, and many other centers are also doing it. So our experience now with TAVR has grown to about 1,000 valves. So we have done almost all kind of situations like, obese patients. This is an example where a patient undergoes TAVR. So who undergoes TAVR today? Any patient who is a surgical turn down. surgeons said no, that is where we started. But now we are doing patients where surgery has already been done, but now the valve is failing. After 10 to 12 years, average 10 to 12 years of bioprosthetic valve, these patients start developing symptoms and their valves start degenerating. And the degeneration can occur in any types of these valves. There are many types of bioprosthetic valves. Some degenerate early, some degenerate late, but the treatment remains the same, that we have to either do a surgery in these patients, a redo surgery if possible, or we do a transcatheter valve-in-valve treatment. And the degeneration happens because of various factors like calcification, leaflet torn, pannus overgrowth, endocarditis, previous endocarditis, and patient prosthesis mismatch, where a small valve has been put which is degenerating very fast. So that is the current scope of the whole situation. And in these patients, how do we diagnose them? Diagnosis happens by first echocardiography. So the first signals come to us when the patient attends the echo lab, and there we get a call that this patient has a high gradient, which means or the valve has started leaking. Then we start thinking of these things. Then we do a 3D echo many times to see whether it is a valvular leak or a paravalvular leak. And then once all that is decided, and whether it is a thrombus formation on the valve or it is a true degeneration, that has to be differentiated. And then based on that, if the gradients are high, there is high leaflet calcification, or we see that it cannot be treated medically, then these patients undergo this. This is the routine indication for re-intervention in these patients: heart failure, LV dysfunction, high gradients on echo, and symptomatic severe stenosis or regurgitation in post-valve surgery patients. So we typically discuss three options. One, a redo surgery, always we discuss. The second is a valve-in-valve procedure, and the third is anticoagulation also sometimes helps. So medicine also has some role, because some patients will have a thrombus which will get dissolved with some good anticoagulation or thrombolysis, and these patients can be carried forward for some more time on medical therapy. So today, why we are choosing valve-in-valve? Because it is minimally invasive, it is done with a very low risk in high risk patients, and the recovery is very, very fast. So that is how we decide then in that particular case. So this is a patient who had a very small valve to start with. So coronary obstruction can happen, which we measure by nickel valves or something. Based on this, we do these cases. And open mitral commissurotomy, then had a triple vessel valve replacement. Certainly, the key takeaway is that it is mandatory to do a CTF and very, very fast. So with this, I think I will stop here very fast. So with this, I think I will stop here, because we have tower, and tower. So that's all. Thank you.
Which valve you will?
Which valve? This patient had a first valve done at for about 20, patient talk, and that's all. And this is which is known as renal denervation therapy. So this is that with every year, as you can see, these are the nerve plexus. We give signals. So these are the signals which come controlled, or the patient is not able to tolerate the medications. Once we do these procedures, artery stenosis really came down after this. That over a period of time, the kidneys will go down. It doesn't have.
Do you have any experience with Paradise?
Basically, our case selection right now to take so many medicines. So please try to reduce my medicine. Logical, reasonable solution to that. Because the thing is, we have to give contrast also while doing the procedure. So in about 30% patients, you will see that the BP is controlled, equilibrium to figure out which drug will be effective in this case. Because we have done presumably all the real wire. The second is that the kidney functions, sometimes the GFR, if it is like between 30 to 60, then there can be an increase.
In that case,
In that case,
what happened to quality score in those cases? Those have been. What happened to quality score in those cases? Those have been undergone the procedure.
Son is of mitral valve more than 10 years, most of the case, more than 10 years, most of the case.
Time congratulating Pramod and Shamshad on putting up this. Okay, thank you. On putting up this. Okay, thank you. So, as now analysis of the CT, especially there is no question, but still there are many patients requires a very deep digging, which patient we can actually try TMVR in mitral annular calcification. Personally, I have used a good number of TMVRs. I have done almost more than 70 and with a 100% procedural success rate. These are the steps of TMVR. So workup is necessary. We should know what previous bioprosthetic valve size was there, what kind of valve was there which has now been degenerated, and then a detailed CT analysis. This is very, very important because we are not only looking at the valve size, we are looking at the LVOT. So once we replace this valve, some part of the new valve will be encroaching upon the LVOT. So we need to look at whether it may not lead to a obstruction of LVOT that can be catastrophic in these patients. So which I'll tell you once I reach there. And then a patient preparation, room setting, transseptal catheterization, transseptal puncture is very important. Then obviously once transseptal puncture is done, we are into the LA with the edgeless sheath, cross the valve with a wire, place a safari rounded wire into the LV, and then the mitral valve crossing, and then THV preparation is done. So before taking the valve across the septum, now this is a bulky device, we need to have a septal dilatation. So we need to dilate the septum with the balloon and then crossing the septum, and then positioning of this valve across the failed bioprosthetic previous surgical valve is also important. So I'll show some of the cases where I think it will be further clear to all of you. The challenges, as I mentioned, we have to look at the LVOT obstruction. So what is the neo-LVOT area, which is very, very important. So this is one important thing which is associated with this procedure. If we if we do not do this well, and this is a narrow neo-LVOT, and do this procedure, I think this can be catastrophic. So if there is a neo-LVOT, we need to modify the LVOT by doing a lampoon procedure. I'll show you one case also with that. And besides that, obviously, if we are not meticulous, there can be an embolization because of the less anchoring of the valve. Tamponade can happen, vascular complications can happen, perivalvular leaks can happen, and CVA, coronary compression is not the case here, but other things can happen related to this procedure. T is very important, paramount, associate adjunct thing required with this procedure. Transesophageal echo, it can't be done without that. And then transseptal puncture, precise transseptal puncture is again very, very important because we need to have a very good trajectory while we are advancing this new valve across that septum and then getting into the mitral annulus. So these things are very important while we plan each and every step of this procedure. And then obviously the valve deployment. So rather than going into this detail, I'll show you some of the cases and some of the challenging cases which we actually faced while doing these TMVRs. So this is case number 1, a 60-year-old male patient where in 2013 the mitral valve replacement was done because of rheumatic heart disease, and now that valve has degenerated. So this is a 3-Mancio picture. As I'm mentioning, this is very important to study the CT in detail. Now main issue is here, we have to look at while we position this new valve here, what would be the neo-LVOT. We should know the exact size of the previous valve, and this is how the diagrams are made while calculating the neo-LVOT, while positioning the valve. So what valve we are choosing, this is a 29 my valve, and the pictures are created while position a 29 valve, and this is a neo-LVOT. Now, this space is very important, and now, you know, having done so many TMVRs, we can actually tell what is the neo LVOT seeing this only rather than calculating this. So, it has to be more than 200 after placing the valve. If it is less than 200 or even less than 170, then I think it becomes very, we have to be very, very cautious while planning this procedure and require a lampoon procedure prior to doing this. So, these are the steps. So, as I mentioned, it is a T-guided procedure under general anesthesia, and a septal puncture is being done under a T guidance. Precise puncture is required. We are into the LA, and then we get the edgeless sheath into the LA, and then cross over to from the mitral valve into the LV with the safari wire. After having done that, this is a balloon dilatation of the septum. This is also required. Usually we do it with the 14 balloon size, and then after we have done that, this is how we take the new valve across this trajectory, RA, septal dilatation, puncture, and then LA, and then into the valve. This is a perimount valve. So one thing very important is that on fluoroscopy, we should have this perimount in a single lane. So this is very important. We should pick and choose a projection where a valve, previous surgical valves come in a single line, so that once we are deploying this valve, we should exactly know how much we are into the LA and how much we are into the LV, and then under a rapid pacing, we deploy this valve. So this was a very simple case. Now this was another unique case, which was a young guy, but had undergone a cardiac surgery twice in the past. So now, third time, I mean, after having 2 cardiac surgeries, now his valve has further degenerated. Now what happened, look at this, 93 he got a post-mitral valve repair and a redo mitral valve repair and tricuspid, it's not repair, it's a replacement. Tricuspid valve ring annuloplasty was also done in 2014. And he's a known case of sarcoidosis, and now again degenerated, but in no manner he was surgically deemed fit. He was surgically totally unfit patient for any third cardiac surgery. So he was in florid cardiac failure, case of sarcoid, twice failed valves, and you know, he was in a really bad position, and his mitral had degenerated, and also the tricuspid ring had failed, and it was leading to severe TR. So this case I planned to actually do both the things in one go, both the percutaneous mitral as well as tricuspid valve replacement. So this is an analysis which I mentioned is very important. The challenge here was valve in a ring is not an easy ball game. It's a very critical, very tough, very complex. So first I planned the mitral. So septal dilatation done, safari wire into the LV, and if you can decipher, there is a very small thin line. It was an epic valve at the mitral position. So it was, it can be visualized as a very faint line, but then having known that, we knew where to place it. So after this, I deployed this valve within that degenerated surgical bioprosthetic valve, and this is this being done. And after having achieved a good result at the mitral position, I shifted the access from the femoral to the jugular, and then this is a ring. Now this is an oval ring, and it's an incomplete ring. It's not easy, because if it is an oval ring and an incomplete but very rigid ring, now rings can be rigid, rings can be little flexible also. So once we place a valve within this, we may have some space which is left out. It cannot have an absolute apposition. So this is a tricuspid valve being deployed in a ring, and it was a massive florid TR. So both the valves done in a single go. Look, there is some space here which I am talking about. So that led to some leftover TR, but then we could actually decrease the TR by 2 grades, and mitral was treated, so patient came out well. Now this is another patient what I am talking. Once we analyze, now look at this neo-LVOT. This is a very small neo-LVOT. Look, so this is almost 100 or 120, 126. Okay, I'll finish in 2 minutes more. So once we face this type of neo-LVOT, we cannot simply go ahead and replace the valve as a direct step. We have to modify the previous leaflet of the surgical valve, because it will obstruct the LVOT and it can lead to catastrophe. So this case I planned with the lampoon as a prior step. So this is the lampoon steps. We go into the LA, LV and then take the wire back and snare it into the aorta. So create a loop. So once this loop is created, this wire is replaced by a special wire called a stato wire. Now this is a stato wire and then a flying V is made. So I am just showing you how lampoon is done. So this is the lampoon. So once a flying V is done, we insulate the wire on the aortic side, aortic valve has to be insulated, and then this is already insulated, and then this is an exposed portion of that stato wire, and then we electrify the wire. So what actually we are doing with that, we are lacerating the previous leaflet. Now it is the leaflet which is going to create an obstruction on the LVOT once we do the TMVR. So then after having done that, we have to pull both the sides. We have to create a loop with the exposed portion of a stato wire and then pull it back. So we are creating a force on the leaflet and electrifying the wire. So this lacerates, and that will lacerate the curtain like leaflet, and once it is done, there will not be any obstruction in the LVOT, and then we can actually complete the procedure by placing this valve in the previously degenerated valve. So this is how lampoon is done, and it is absolutely an indication if the neo LVOT is very narrow. So then after this we could accomplish this without any problem, and this is the pictures, this is the echo, and this is the previous valve, and one 3D video was showing a laceration. So short of time, this is a post valve deployment, and this is one more challenge which we face at times. If the atrial septum is too thick, so then at times we may not have a precise perfect puncture, and then what we are going to face with this this shows, I'm just showing you this. So now at times the puncture is not very precise because or the septum is too thick. So this happens. So we have done all the steps, we have dilated, we are taking a balloon to dilate a septum. Now look at the second video. Once we are trying to advance this balloon, that everything is trying to come back. So then this is important. If balloon is not going, everything is coming back, we cannot think of advancing a valve. So what do we do here? Now it's an unfavorable puncture, unfavorable septum. So what we do, we take a snare on the LV side. So with that snare, we are actually gripping the safari wire and trying to pull it down. So while we do that, then we could actually have the balloon across the septum, dilate it further, but still it's not going to be easy. Look, literally what we are doing, we are pulling, rather than pushing the valve, we are pulling the valve with the snare to get it down into the mitral annulus. So this is the help of snare assisted TMVR, and once we are in position, we deploy this valve, and then everything is fine. So in this patient, typically what happened while giving this push and pull, we lacerated the atrial septum. So there was a wide AST which we had to close with the AST device, and then everything was okay. So TMVR done with the snare assisted mechanism. So this is how complex and things and challenges can be conquered while we plan a TMVR. So it's a very good, reasonable, good option for a failed bioprosthetic valve at a mitral position, and obviously heart team discussion comes into play before really deciding about it. A meticulous CT analysis is the key. So neo LVOT, we have to figure out if it is narrow, we have to always consider a lampoon first, and always keep in mind finally the durability of these valves too. So these are tissue valves, and out of 76, 2-3 patients of mine over last 5 years, they are showing raised gradients. So whenever the gradients are rising, we can always think of adding an anticoagulation, warfarin into that, but still, we should keep in mind that these valves are bound to degenerate at some point of time too. Thank you very much.
Thank you, then. Any question?
Do you keep a mechanical circulatory support standby for all these procedures?
So obviously we do it in hybrid OT. Everything is ready there. Even surgeons are there, and it's under GA. So not an issue, but we haven't required it in any of our cases. it all depends, you know, how do you plan it, whether, see, we have refuted some of the cases based on a narrow LVOT or if the anatomy is too bad, but if you plan it well, there are less chances that you will lead on with the hemodynamic instability.
Sir, and do you intervene early depending upon the symptoms, or it is just if at all the echo shows that the valve is degenerating, so do you prefer to keep them on the medication first and then only if at all it fails?
All these patients are with degenerated surgical prosthesis with mitral position symptomatic. They are presented in heart failure, stabilized, and gradients are high, or they are regurgitating, the leakage is profuse, so or PA pressures are very high, so all symptomatic patients.
First, it has to be a medical management.
Absolutely.
If at all the medical management fails, then you...
Obviously, these patients have to be followed up meticulously. If the gradients are going higher and higher, despite everything, PA pressures are rising, RV dysfunctions are appearing, then obviously one can plan with the least symptoms also. But usually, most of these patients presented with heart failure symptoms stabilized and then planned it.
So, any experience with the betterment for new LVOT modification?
I think we are absolutely nick of time. So even my flight and Dr. Mullah Sari, let him be here and present, because our tachycardia, our heart rate is also rising.
Thank you. Next is Dr. Mullah Sari Ajit sir. He is a Padma Shri awardee and he is the director of Madras Mission Hospital, Chennai. Actually, he had done many innovative procedures in stuck valve. We know the stuck valve is a major, very high mortality due to pulmonary edema and hypotension leading to multi-organ failure. So the procedure should be less invasive, less mortality is the most important aspect when you are managing the stuck valve, because thrombolysis and valve replacement is very high risk in this group of patients. Dr. Mulesari sir.
Thank you. So this is something unique that we have done, and I thought I would present it here so as to tell people how this works. It's not moving the slides. So the first thing I want to say is that, as the chairperson has said, that most of India faces rheumatic heart disease. The repair is an option but does not last long, and you end up with a mechanical valve. And the problem is that because mechanical valves are durable, they are used first, but the mechanical valve anticoagulation with vitamin K is good, but patients sometimes don't take it. You keep the INRs between 2.5 to 3.5 according to the position and the type. There are dedicated valve clinics, but sometimes patients, because it's a lifelong anticoagulation, they stop. And valve thrombosis is high, and in the mitral and tricuspid position as compared to the aortic can vary from 0.1 to 5%. Now, when a patient presents with a stuck valve, and the guidelines recommend either increase of heparin infusion to get the thrombosis off, or thrombolysis, and the usual way is an ultra slow infusion of 48 to 72 hours of good thrombolytic agents like TPAs or tenecteplase. And transcatheter manipulation of immobilizable leaflets was spoken about a few years ago, and we did some of these in desperation because there were patients with 3 surgeries, stuck valves, high INR, pulmonedema, on ventilator, surgeon doesn't want to go in, lysis can't be done with an INR of 8 and 9, and we thought that this is a possibility. Now let me see the background. The background is this treatment, which is ultra slow thrombolysis, which is an option to surgery. But let's look at the cohort. The cohort is 276 patients, of which about 6 were unsuitable for surgery, and another group was unsuitable for thrombolysis, and it came down to 214 from 276, and the final study was only 150. So 2/3 of the patient ultimately, of what was shortlisted, ultimately landed up with this treatment. The success of thrombolysis was demonstrated by a Doppler documentation of improvement in valve dynamics, reduction in major diameter or the area of thrombus by 75%, and symptomatic treatment. And full success was 3 out of 3, and partial was 2 out of 3. There was no fluoroscopy, there was no CT and closing angles measured. And in this study, which was in the JACC, showed that ultra-infusion of thrombolysis was superior to a standard redo surgery in these group of patients. Now, what is the problem? The problem lies here. Here's a mechanical valve. That's the thrombus in the lateral orifice, annulus. It can also be on the hinge. Now, what we are trying to attempt is a stuck valve like this. You can see that this leaflet is stuck, not moving. One valve is here. One leaflet is here. This is a bileaflet valve. It can happen. And there's either a thrombus here, which is not allowing it to open, or it's on the lateral orifice side, or it could be on the hinge and not allow it. Now, we took the first patient in out of desperation because there was a European Heart Journal study which showed that a stuck valve could be mobilized by tapping these leaflets and opening it. So we took the first patient up with a simple understanding maybe that a tapping of this leaflet could be useful. And the solution for a stuck mechanical valve or a metallic valve was this. You cross it in the center with a wire and balloon, put a balloon and get that leaflet moving again, and the clot flies off and the leaflet comes open, and obviously we have to catch the clot from growing into the brain or some other place, which could create a stroke. Now, the research question was, when we do this balloon, will the leaflet dislodge or avulse from the hinge? Will the leaflet or annulus fracture when you're ballooning the whole thing? Will it deform and malfunction after that, which will have a problem later? And maybe the bond is too hard, like a strong pannus, where we can't release it. And obviously, you need to have coronary, cerebral, and systemic embolism issues, which has to be protected. This part we can sort, the last one. That is, we can put filters for cerebral protection. We can use coronary embolism by protecting the coronary circulation. And we can get these clots out if they embolize with transcatheter embolectomy. But the first four, how do you study it? And so you can have it two ways, an animal study or a bench model. And there's a complete lack of information of what balloon will you put in the center of which valve, what balloon will you put in the lateral valve, what are these sizes, and everything else. So to address this research, one of my fellows took up this project as his PhD topic, and I put him on to testing how we could do this. So the first thing was, can we test a bench test on a new brand of valves and see where it breaks or where it fractures at what pressure? The problem is it's not a mimic of a wear and tear valve at core body temperature over several years. A new valve is different from an old valve in the body. The animal study, implanting the valve and waiting for a stuck valve to happen for several years is not feasible. So we did a closer in vivo scenario where we bench studied explanted surgical mechanical valves during a redo surgery in humans. So we removed those valves which the surgeons were doing and took it into the cath lab on a day when, like Sunday, when there's not much cases going on. So this is a vernier calipers. This is an explanted bileaflet ATSAP valve. You measure this distance. You measure this distance, you measure the leaflet thickness, and the central orifice will be this distance minus twice the thickness of these leaflets, which is 5.7. So we can measure the central, and similarly we can measure the lateral orifice. So one way is measure these numbers so that we know which balloon to do what. The second way is in the valve, in the cath lab, we created an in vivo model, where we open this balloon up in the center with a 1:2 balloon dilatation and see what happens. You can see the fluoroscopy of the balloon going in, a 5 mm coronary balloon in the center and a 10 mm in the lateral. And interestingly, as you see this balloon going up in the center, this is a very large balloon, 10 to 20, with 5 mm is this distance. What happens, as you can see at the end of the video, is that the leaflet will just break and one leaflet will fly off. So we can know that at what pressure the leaflet will give away and at what balloon size is the maximum you can do. Similarly, we can check it in the lateral leaflet. So in the lateral again you have, but the interesting thing in the lateral is as you go up with a 20 mm balloon at a high 16 atmospheres, which is basically a 9 mm size, it breaks into fragments. So we learned that there are certain pressures and certain sizes, what happens to the central leaflet and what happens to the lateral when the balloon goes up, telling us what would happen when you balloon dilate these valves. So we did the first 20 patients on surgical explanted valves to see what happens to these valves
when you do it. After which we started doing these procedures more regularly, and this is a technique which is very similar to a TMVR. We do a transeptal, we get in, we put the wire, but we protect both the brain with 2 filters. We were using Sentinel, but Sentinel is not available from Boston Scientific anymore. And then we take a baseline vertebral, upper limb and lower limb pulse pressures so that you know if any embolization happens, what to happen. And this is a cartoon mimic. So we get this balloon right in the center, we protect both the brains, and then we keep a coronary guiding catheter in the left to protect the coronary system. And then we realize quickly that after the first few cases, if the patient was stable, a CT is very useful because the CT tells you a few things. What are the diameters? You can measure it. We can also differentiate between the HSU unit, whether it is pannus or thrombus. A thrombus is low HSU unit and a pannus is high HSU unit. A large pannus is not going to open with a balloon dilatation, it has to go for surgery. But a small HSU unit. So we measure these numbers on the CT before the procedure. If the patients are stable, if they are not, we can't. We require the balloon size. We target the central orifice with a working wire and a balloon, 5 to 15 here, peripheral balloon, and the lateral, if it is required, with a larger balloon. It completely releases the leaflet. It's important, and our endpoint was not just gradient, it was full opening of the leaflets. And this was clearly because we know now, and I'll tell you the follow-up on these patients, that if you don't release the leaflet completely, which happens very often with thrombolysis, they will come back with again recurrence in 1 year and stroke. So we need to get that opened up nicely for the patient. So this is the echo pre and post gradients, and 30% of them will embolize. So you cannot do this procedure without cerebral protection. These are the sort of stuff that you get into the sentinels or into the spiders. So you can't be bravado and do a procedure without protecting the brain. You will get into trouble. Now we've got an app now for all the types of valves, what we can currently have in the market. And we know which balloons go into what. And we have named this procedure as percutaneous transcatheter release of the stuck valve. It's called as the Petros procedure. And this first report of that on the mitral position, we published the first 6 in structural heart. And these are the pictures of that. I'm not going to the first aortic position, 6 we published in the JSCAI journal. And we showed how to protect it and how the thrombus looks like, organized thrombus looks like on these. And finally, last year we published in Circulation of the first 24 patients, which we attempted with a 1-year outcome of these patients. And clearly we had 2 groups, a primary and a rescue Petros. Primary were patients who were refused for surgery and not fit for lysis. They were really surgical rejection. Lysis is not still being used. And the rescue is you thrombolize the patient and they don't do well after 72 hours and they still have problems. So I'm not going to do this. Basically, the technical success was about 92%. We had 2 deaths, one release related to vertebral embolism, and one was a sudden cardiac death at 8 months, possibly of a restuck. But what is interesting was the recurrence of stuck valve happened even in the stuck release with 16%, and we had to re-intervene either with a redo procedure or lysis. The mean gradients are very, very low. And clearly, the outcome is extremely important. This is a Kaplan-Meier curve which we published. So what it showed the study that this is a possibility for surgical rejection, lysed failure patients. And this is a letter to the editor from Gunnar's group, which was the group which did the first ultra-infusion lysis, that how can it be given to everybody? Well, we are not going to give it to everybody. We are going to give it to only those people who are not safe for lysis or failed with lysis or surgical rejects. And I am happy to say that we have now completed 128 patients of lysis versus stuck valve. And we've just submitted to Circulation for publication. This is the first consecutive 5-year outcome, 5-year patients of 128 were lysis versus stuck valve. Thank you very much.
So do you have any patients whom you cleared by CT and there was a mismatch in pannus and your balloon failed, and then is there a possibility you do half the procedure, could not complete, and they get better candidate for surgery?
Yeah. So if you look at the failure rate was 2, and that was in the mitral position. Those were because of large pannus and not a thrombus. And this in the initial days, we didn't know how to differentiate a pannus, and there's no data. So today, if I say 130 HSUs and low, I'm not sure it's thrombus. More than 200 could be pannus. But more than that is the amount of pannus. If the pannus is very large, it's unlikely to open up. We've got not great results on the aortic position. Our failure is 30% in the aortic position because that is more likely to be pannus, and they should go for surgery. But again, the clinical history, recent admissions, all that make a big difference whether to decide whether it's pannus or thrombus. Sorry?
Electrocautery for pannus, can we?
Yeah, well, there are other things which we are looking at. It could be electrocautery, it could be a cutting balloon. But some people have suggested IVL. We are not yet so dramatic yet, but I just want to be sure what we're doing is correct. So this 128 patients will tell us, as shown as I can't present the slides because it's up for publication, but I'll just tell you in short, the immediate outcomes are the same with ultra-infusion lysis but at 1 year, there's a p-value of 0.002 for recurrent stroke and recurrent admissions for rethrombosis after lysis. So lysis is good. It's like thrombolysis for MI. It can be done everywhere. But primary PCI is better if you can do that acutely. And I think that once the protection devices and our procedure gets more finer, I think it may be a standard of care. It's already, the JAC put one step first. It's come into a small guideline that if it's failure for lysis or not suitable for surgery, mechanical leaflet release can be done.
What is your What is your anticoagulation profile, sir?
We keep the INR, we've got a very good valve clinic, so if they follow up all our patients, we keep the mitral position between 3 to 3.5 and the aortic position between 2 to 2.5.
Then during procedure, how much heparin you are giving? During procedure?
Well, we keep the ACT high, we keep it around 300 so that we don't have problems of sticking up at that point of time, but we keep the INRs reasonably high. But the problem is patients go all over and after a few years they become lethargic with the INR and problems start.
Sir, do you have any experience with the pregnant women?
Not yet. I've not done a pregnant woman stuck valve yet.
Sir, absolutely marvelous. And looking at these innovations as a surgeon, I must say that times are difficult for us.
No, sir, we've got a very good surgical unit which handles equal number of difficult cases. Well, that's another problem because in young patients they will come back and then you have that issue to sort out, I think. Okay, thank you.
Thank you, sir. Thank you. The slide change in the program. The next speaker is Dr. Edwin Francis. He will speak on sinus venosus ASD device closure. Dr. Francis.
Good afternoon, everyone. Thank you, the Medanta team, Dr. Ashish, for calling me for this great meeting. And the next around 10-15 minutes, I'll quickly go through a slightly newer intervention being done, the sinus venosus ASD closure. Basically, it was probably the idea came up in maybe around 15 years back in 2009. And then more progress, only a case reports in the first few years, and more regular procedures were happening since 2015, and the more increased numbers and more centers are trying in the last few years. So these are the first few publications came in 2009, and then from the Middle East there was an article in 2000. They did it in 2012, but published later, but was presented in AHA in 2014. And from India, the first report came in 2014. So the question is, how do you select these patients? How do you proceed with them? What are the criteria to go about? And basically, it's a usual mechanism of evaluation: echo, CT scan, and the gold standard is balloon occlusion in the cardiac cath lab. MR, CT, and MR and 3D printing and virtual reality may help you in the cases, but the gold standard is cardiac catheterization. In the basic echocardiogram, you can all know that it's a sinus nose ASD in the 90 degrees. So TE is usually I do a baseline TE test to confirm the diagnosis, to see the pulmonary venous drainage, confirm there is no additional defects, other veins are draining normally, and to exclude other abnormalities. So once this is done, basically, initially we were using, may go directly to the cath lab and do a balloon occlusion, but now more and more requirement, a CT screening is mostly done. CT definitely is one of the best methods to analyze a patient for the suitability for a transcatheter closure, and the 3D reconstruction also helps you to analyze it better. And more importantly is you need to identify small additional veins going in, and also helps to make measurements to choose your stent or device. So this is a CT scan. You can see the sagittal picture, and you can see what you imagine is you have an SVC, a covered stent in the SVC, and there should be space for the left upper pulmonary vein to drain posterior to the stent into the left atrium without obstruction. That is our aim. So these CT pictures will help us to just mostly analyze them, but as I said, catheterization is the gold standard to prove that it is suitable or not. So balloon occlusion is the standard. What is done is, in the different operators have different methods. Usually put a balloon and occlude the lower SVC and make sure on TE that the ASD is occluded. Meanwhile, there is unobstructed pulmonary venous drainage into the left atrium. Or another way is, initially when I started doing it in 2016-17, I also used to do an additional right pulmonary artery injection and see the lever phase to rule out any additional veins are there. Many a times there will be an additional veins entering the high SVC which may be ignored. Many a times it can get occluded if you inadvertently occlude them. And in borderline cases, obviously the PA pressure and pulmonary vascular resistance need to be analyzed. This is one of the first major publication came in from the SHAG group in the Europe, from London. It's 2020. There are around 25 cases here. I did my first case in 2016. This is one of the typical case scenarios. This is an angiogram which the catheter I use usually a 6 or 5 French guide in the right upper pulmonary vein and inject. And you can see the catheter here is moved in. You can see the pulmonary vein draining to the SVC RA junction, and the predominantly RA and PS filling. So this is an LAO view in which you can see the same venous injection into a upper vein which is draining into predominantly RA. So what we do is we balloon occlude. Here I've used a 24 mm sizing balloon. We may go into the details of semi-compliant or non-compliant balloons to be used. The most often used are, the most easily available are a 24 mm KSD sizing balloon, and you can see a simultaneous injection from the right upper pulmonary vein shows a complete occlusion. There is complete drainage of the right upper vein into LA posterior to the pulmonary vein, to the SVC without obstruction. So in these cases, they are suitable for a transcatheter closure. Here is another example in which there's a Tyshak 6 cm balloon used. You see a slightly residual flows, then you have to inflate at higher pressures or a bigger balloon to occlude the complete closure of the sinus nose ASD. So I give you another example in which is not suitable. Here, injection is made in the right upper pulmonary artery, and then you can see the venous stasis. The moment the balloon is deflated, you can see the contrast being drained immediately into the SVC-RA junction. So these are the patients which are not suitable for a transcatheter closure. I give you another example in which my first injection here, a balloon, sizing balloon, you can see almost nearly unobstructed flows here. If you have not done a CT prior, or if you are not very good in examining clearly, you can do the next angiogram. You can see there's another vein which was missed completely. I go up and make sure there's an additional vein or not, then that is completely occluded, and better you cannot do this. So a case selection is the most important point in deciding whether a patient could be suited for a transcatheter closure. So here is one of the first few cases we've done in which routinely initially used in the first 10 cases, a custom-made CP stent pre-mounted on a bib balloon was utilized. You can see there is a pulmonary venous flow is away from the prop towards the RA. It is a blue color. And once you inflate, it should come. So it's a bib balloon, inner balloon is being inflated, and followed which the outer balloon is also inflated, which shows a complete deployment of the stent, which completely occludes the sinus nose ASD. So this was the recent publication came into circulation 2025 in only 3 centers in India, I think. Shivakumar has the largest series in India, and I have the second largest series in India with the sinus nose ASD closure. We have multiple types of stents available. The covered CP stents is the one which was routinely used earlier in the Western world. Now it is pretty expensive, so more often nowadays we are Sapphire covered stent is used by the STLT company. You have B-graft, Medtronic extension, self-expanding extension tubes, LifeTech specific custom-made devices. A Joe stent which was tried but hardly used now. An Optimum stent is available, covered stent is available in the Europe. I'll give you a few examples with the things can go wrong and things can go right way. There's again a same patient in which you can see a complete occlusion here. And then we put in here is a Sapphire stent used. Nowadays, recently for the last 5 years, I've been predominantly using Sapphire stents. A balloon is implanted on a 6 centimeter bib balloon, and the stent is deployed, and you can see an unobstructed flow in the final injection with unobstructed flows of SVC. Usually I go by a transesophageal echocardiogram. There's 2 ways of looking at the pulmonary vein. Either you can puncture, if you have PFO, you can go through it and keep a catheter there, or you can puncture the atrial septum and keep a catheter in the pulmonary vein. Here, if I have a good flow, you can see here's a blue flow that shows it is flowing towards the RA. When a balloon expanded, you can becomes red. And this is after the procedure, you can see a complete unobstructed pulmonary vein into the left atrium. So if you do a TE, you may not need always a pulmonary venous protection. In borderline cases, I will puncture and do a protection. But here's a clean case. Here's another case in which I have used endurant aortic extension tubes. The good thing is it has spokes here, retention, this thing, so it can hold on to it. So it will be slightly more easier in doing it rather than a balloon expandable stents. But there are side effects too to it. If you have case 3, there's an older lady, 63-year-old, moderate TR, moderate MR, moderate pH was there, and then the CTR is like quite high, and no surgeon was willing to take up the patient. So in this case, it was a bit borderline. So I punctured the atrial septum, make sure I had punctured into the left atrium, and then entered into the pulmonary vein and kept a catheter there, and then injecting into it through a sheath with a balloon occlusion, which shows almost all veins draining unobstructed into the left atrium. Here's a LifeTech custom-made device. Only thing around 6-7 implants have been made, 5 which I have done, which are reasonably good results. But you need to have specific suited for the specific anatomy. Here the stent is being deployed with the pulmonary vein catheter kept here, make sure that it's unobstructed, and then you release the barbs. Unlike in aortic stent grafts, we release the retention barbs after the release. I partly release the device, and then release the retention barbs so that it holds on to that same position and then completely deploys the device. You can see the well-released device with no residual flows. Here's another case in which I got into trouble. Here is another 20-year-old lady in which measurements are made with a marker pigtail, and then I go ahead and deploy a Sapphire 60 mm stent on a 22 into 6 centimeter balloon. So deployment is done, but then you can see the level of the upper end I kept at the lower end of the innominate vein, at the upper end of this pulmonary venous catheter. But post-deployment, it started migrating the moment I started deflating it. So I can re-inflate and hold it. But once you release a stent, there's no way you're going to catch it there. So I have no other way. I try to take a Corda balloon, hold it from the RA, and then deploy another uncovered stent on the top of it just to hold it so that it doesn't migrate further. So in this process, I had to re-inflate it more in higher diameters. So there was a stasis in the pulmonary vein. So I take a 10 mm Mustang balloon and inflate it at the pulmonary vein. So it distorts the stent a bit, and it causes unobstructed pulmonary venous flows. And one more last angiogram, which shows unobstructed innominate venous flows are also shown. So it's a another case in which there was an additional second MASD. So I deploy the stent and dilate the lower part and then go on to deploy the second MASD also. So both can be done in the same sitting. So this way this can be done, but then complications do happen as any procedure. One of the most scared complication could be a stent embolization. In the series in the world, that circulation paper, there are around 360 cases done in the world. They had around 2 to 3% embolization rate. That is based on the improper planning and not having the right hardware. If you lose a distended inflated stent, only option is to go for a surgical removal. And then there's a thromboembolism, inadvertent occlusion of pulmonary veins, and perforation of hemothorax. In this, last two slides, in this paper, there's Dr. Shivakumar has published in which he had around 5% to 10% thrombi here, but initially he was not giving oral anticoagulation. My protocol is to give oral anticoagulation for 3 months and dual antiplatelets for the next 9 months, so almost nearly 1 year. After that, I stopped everything. Here there's a rare complication in which a stent graft was used, in which Dr. Muthukumar from again Chennai got into trouble with the hemothorax. The barbs were protruding out and was damaging the aorta. He had to go for an emergency surgery when the patient collapsed the next day. So these are things. This is a one CT picture given to my radiologist, another sender, in which they got into trouble with pulmonary. You can see the pulmonary vein obstruction caused by this, and then heard that they are taken back to the theater and then removed the stent. So you need to be careful in doing it. To conclude, in selected cases, a sinus nose ASD can be tackled in the cath lab. Still, there is no consensus which type of device to be used, but more often, a balloon extendable stents are more often used, but custom-made stent grafts may be useful, more easier, and maybe the future. Thank you.
Bailout strategy for stent embolism. What is the bailout strategy for stent embolism? Bailout strategy. Bailing out, how you'll bail if stent got...
Bailing out for a stent is deployed and lost it, I think, is only surgery. In this case, I was like, the moment I'm deflating, I could pick up this case. As of now, I've done around 35 plus cases. I haven't had an embolization, but predominantly the problem is the non-availability of the right hardware. The stent lengths are around 6 to 7 centimeter stents are available, but we don't have long 22 or 25 mm long 6 or 7 centimeter balloons are less available in the market. So this mismatch results in people trying to do something with inadequate hardware, and then there is no holding in the low RA. It has to hold in the SVC. So at least 40% of the stent has to remain in the SVC. If you try to compromise and bring it down, then it may not hold it there, so it will come down. Once you have lost the stent, the only choice is to take those surgery. There's no other way out. In those cases, by deflation, I thought it was a movement, so I stopped immediately, reinflated, and then tried to hold it. But it's quite difficult. I don't think it'd be easy to do that, unless you have done 20, 30 cases. Any further questions?
Thank you, sir. Actually, initially it was only surgical indication when we are reading that during the DM. Now it can be closed by the stent. It's a very new innovative procedure, and day by day. Recently, I have one patient. He went 40-year-old. He went to outside and done this sinus venosus by this stent. I am very happy.
I had a doctor, medical PG, who had done a procedure, and then later on she got, in 2019 or 20, she got admitted in another hospital for some other reason. Then she said that, in the history said that this was done. Then the doctor said, no, this is not possible. But yeah, things are changing, so probably I'm taking away a few more cases from the surgeon, probably.
Thank you.
Thank you.
The Dr. Ravindra is not present. The next speaker is Dr. Arvind Kumar. He will speak on the severe symptomatic MR, high surgical risk, new tool mitra clip.
So I will invite Dr. Arvind to be on the stage. So basically it is a 3-speaker session. It is a combined approach of intervention coronary cardiologist, then a non-invasive lab which is well equipped with a 3D TE, and finally the structural interventionist. प्रोजेक्ट करना है. So, management of severe MR in high risk subset. So, we had a 75 years female who had known case of COPD with presented with acute decompensated heart failure. In fetal MI, it was a day 3rd presentation. She was initially stabilized and coronary angiogram was done. She was on NIV support. Coronary angiogram was done when her NIV support was curtailed off, and which revealed double vessel disease. So, this was her coronary angiogram. Circumflex was 100% occluded after giving 2 major OMs, and her right coronary, there was a proximal 90 to 95% stenosis with slow flow in the distal vessel. So, basically it was a dominant RCA, non-dominant circumflex. So, what we presumed that the vessel after origin of OM2, it will not be that much great. So, medical management was planned for distal circumflex in view of no significant collaterals, and PTCA to right coronary artery was planned. Family was counseled that in view of severe mitral regurgitation, she might require a mitral valve replacement or repair, because on echocardiogram, mechanical rupture was not quite visible. So, we did a PTCA to RCA. Gradually, she was stabilized, but after discharge, after 5 days interval after stabilization, she was again readmitted after 2 days with severe mitral regurgitation, acute decompensated heart failure. Although she was not hypotensive, she was maintaining her blood pressure, but due to severe MR, she was again decompensated and readmitted. So, we reassessed sir, that what is the exact etiology. So, I will request Dr. Shraddha to put some focus on the T images, 3D T images and MR assessment.
Hello. So while Dr. Shraddha is opening her slides, the patient had an MI, 2 arteries were diseased, RCA and LCX. Patient had severe MR, ideally should have gone for surgery, but was not sent for surgery because she had other comorbidities like severe COPD. So it was decided that maybe we'll manage with plasty and see how she fares. And she came back again with symptoms. Interesting case, because ideally she should go for surgery, but now she can't. Let us see what are the images.
So moving on to the case. So what we know so far, that frail 75-year-old lady had a infeval MI, PTCA was done at that time, surgery was not possible, comorbidities, multiple comorbidities, and after that she has been deteriorating with 2 subsequent admissions with heart failure. Echo showed ejection fraction of 40 to 45%, severe MR, moderate pH. BNPs were declining it with each admission despite she was on GDMT. She had dyspnea at minimal effort, and a happy-go-lucky lady who had now a very poor quality of life. Options were already discussed while the first admission as well. Her surgical risk was very, very high, and the attendants as well as the heart team did not decide that she could undergo a surgical mitral valve repair or replacement. If you go by the guidelines, we know now these are the recent ESC guidelines which say that PCI followed by TEER after re-evaluation of MR may be considered in symptomatic patients with chronic severe ventricular secondary MR and non-complex CAD, which probably at this point our patient fits into. So now we are looking for suitability of TEER. What the checklist, we quantified MR severity, determined if the MR is, what is the etiology and everything. I'll go one by one. So of course the MR was severe, it was eccentric, there was significant flow convergence, large PISA, and all the qualitative, quantitative measures were there which determined that the MR is severe. If we go into pathophysiology, it was definitely ischemic secondary MR. There was no mechanical defect there. Due to LV remodeling after MI, because of probably the LCX disease, there was a functional MR due to the geometric distortion. There was a tethering of the leaflet causing this mitral regurgitation. The pulmonary vein flow showed systolic reversal. Mean gradient across mitral valve was 2 mmHg, just so that ruling out any significant mitral stenosis. And if we come to the suitability, PML length was more than 10 mm, coaptation depth was less than 10 mm, not very, the coaptation depth was not so high. Coaptation length was borderline 2 mm, there was no severe leaflet calcification. We now know that these numbers are not very rigid. We don't have to be rigid about that. And there's a concept of coaptation reserve, which just we have to assess whether how much of the leaflet tissue is there, which can be clipped and to go into the new coaptation zone, to create a new coaptation zone, which I'm sure Dr. Arvind sir will be elaborating on. So this was the 3D in-face view of mitral valve. We can see that the PML is severely tethered, it's not moving at all, and there is a large coaptation gap there, and there's a significant MR. So TEAR was planned. If we go by guideline-based indications, she had severe symptomatic secondary MR despite GDMT. LVF was not so bad. The left ventricular was not so big, so that is a very that was very good in favor of the patient, that the dimensions were less than 70 mm. Pulmonary arterial systolic pressure was less than 70. She had more or less suitable valve anatomy, and the MR was disproportionate, what we call as coap type MR. That if the LV is small and the MR is more severe, that is disproportionate, these patients are likely to have more benefit. Intraprocedural MR, we can see before the clip deployment, and
we can talk about a bit later. The assessment of patient is twofold. The first part is diagnostic assessment, where you have beautifully shown the images that the MR is severe, the ERO is high, the volumes are high, regurgitant volumes are high. What I need as an interventionist is how is the septum and how large is the LE. How is the septum and how large is the LE. These two things are very important for me, because I have to go with a device which has to be coaxial to the mitral valve annulus. And if you look at the mitral valve annulus in our body, it is something like this.
Yes.
And we have to enter coaxial to this line. This is the commissural line. These fingers are the posterior leaflet, and the anterior leaflet is somewhere here. I am not depicting it. So I have to be coaxial to this. The first thing is whether the septum will allow me to be coaxial or not.
Yes.
Second thing is whether I will have enough left atrium, to get the trajectory towards the mitral valve. So I need actually two things which are not shown in the
so this talk was basically sort of 3 minutes for suitability and indications, and that part has to be covered by you. So I have images. If I can open, I'll open. So the septum was quite adequate in length,
so
and
septum
there
was large enough.
adequate in length. It was not thick, and there was place for the this to bend.
Okay.
So we did that, and so this is just the end result. I am not supposed to go in the intra-procedural. Okay. That part have to be taken by you. So the suitability and patient selection, this is how we selected this patient for TEAR. And after deployment of clip, there was some residual MR, but still she is doing quite well. The mean gradient was 4 mmHg, so there was no, we didn't decide to go for another clip. There was no systolic reversal in pulmonary vein. And after almost 2 years now, she has some residual MR, but she has a new life, no hospital admission in last 2 years. And this was the first mitral clip operation done in Bihar, most probably.
Great. Actually, you can go back to a slide where you have shown the 3D pictures. Before this, the diagnostic 3D pictures, before the procedure.
Sure.
Yeah. This is a very good picture, because when you look at the 3D picture, if it plays, we feel as if there is no leaflet there. On the 3D picture, it seems that there is no leaflet there, but on the 2D picture, from the same part where we are looking at, there is actually a leaflet. So it is tethered so much that on 3D, in this view, we cannot see it. So if you have to see that, we turn the picture a bit like this, then you will be able to see some of the leaflets. So whereas on the 2D pictures, you can see that there is a severe MR and there is a PML there. So PML is still there. It has just rotated anti-clockwise posteriorly. That's a very important thing to understand, that in these cases, the MR is coming mostly from the medial commissure. Yes. And it is actually a commissure MR towards the center. So the clip has to be 12/6 only. So we talk about the orientation of the clips, which we will be talking about in the separate part here. Let us remember this, then we will talk about it.
So basically this patient underwent a clip. So after assessment, because the patient's body weight was very low, height was low, initially most of the time the required clip is almost 2. 1.5, 1.6 is the average what the people who do it, they say. But in this patient we went with only 1 clip because we were feared that after 2 clips that will turn into mitral stenosis. So that's why we deployed only 1 clip, and we planned that the rest of the residual MR we will do it with medical management, because that patient was already having atrial fibrillation. We cardioverted it, and finally she is doing well. Once she was admitted for acute exacerbation of COPD, mild to moderate MR, but it again converted into mild MR after medical optimization.
So by the time the slides are opening, we have decided that we will go with the clip in this case. In acute MR, there are certain caveats that we have to remember. First, the LA may be small. In this case, luckily the LA was large. So if the LA is small, we may not have room to navigate inside the left atrium. So many operators, they go from the left side. They do the transeptal puncture from the left side rather than the right side. It is an important thing to remember in acute situations, because when we puncture from the right side, the trajectory of the transeptal puncture is, so if this is my body, the trajectory is like this from the right side. Whereas from the left side, the trajectory is bit up. So you get 0.5 to 1 centimeter more height when you come from the left side. There is a difficulty in taking transeptal puncture from the left side because the needle system, the whole broken barrow system may not track properly. For that, if you use the SL0, SL1 set, it usually tracks. There have been articles talking about to take a transeptal puncture from the left, you turn the patient 45 degree from this part and take a puncture. But here we are taking a puncture with the use of a TE. So mostly this is not done. At least this is not I have done. I have seen punctures being taken from left side without shifting the patient's upper body.
So this is the procedure. We did a septal puncture. What we say that STD posterior and superiorly directed, so that we reach the mitral valve very efficiently. We have to grasp that. Most of the time, the mitral regurgitation post mitral and myocardial infarction, it is usually in favor of myocardial infarction. So posterior mitral leaflet is most of the times involved. So that's why we have to take that access towards the posteriorly and superiorly. And then we deployed 1 mitral clip. What I said that we were ready to accept mild to moderate MR that we will manage on medical management. We were not going to accept a severe mitral stenosis after 2 mitral clips.
So basically in these images, there are a few steps enunciated. First step is taking a transeptal puncture. We use TE guidance for transeptal puncture. It is a standard way of taking transeptal puncture. The first step is look at the SVC, IVC, bicaval view. Come down at the level that you like to. I take infero-posterior punctures. People take superior-posterior punctures. It has to be posterior. That's most important. Infero-posterior will land you here. Superior-posterior will land you here. That's the only difference. If you come from here, this is the annular plane. You have to give plus so that you come to the annular line. If you are infero-posterior, you are in the annular line. You don't have to give plus. So you don't have to add another button, another knob. That's the only difference. Once you are there, the second step is putting the clip delivery system over a sheath that is called straddling, which has not been shown, but it is a part of the procedure because the whole system is a part of 3 systems together. A sheath, clip delivery system with the clip inside. So all 3 have to be made a single system, which is made by a process called straddling, where if you can see, there are 3 lines which are seen on fluoro. They have to be co-aligned like a threshold, you can say, or a sandwich or a straddling. Once that is done, the whole catheter behaves like a single catheter and all the knobs will move the whole catheter together. Once we do that, we flex the catheter towards the mitral wall and see for the coaxiality, the trajectory is good or not, and go inside the LV. While coming up, we open the clip and we grasp the leaflets. Once we grasp the leaflets, we close it. Once we have closed it, we see whether the MR has been decreased or not. We assess everything. Let us see whether we have done it here or not. Maybe there are some images.
So this is the final images. The
echo images maybe?
Clip has been deployed, okay. And these are the final images. There has been significant reduction in the regurgitant volume, what we can see. So we were expecting mild to moderate, but after just deployment, it was less than mild. This was achieved. and it's almost 2 years, 4 months that this patient came to follow up 5 days earlier. What I have said that, to this patient, that just before the winters, just come to get the medicines optimized. She is on apixaban. She is using overnight BiPAP for her COPD, and she is doing well. 47 years old lady. One very strict warning we have been given to her, that any increase even for 500 gram in your body weight, you should come immediately. Thank you.
I think this is good. This is excellent. The result is really good.
Yeah, I would like to congratulate the team for the very good results. As he said, they were planning for reduction of the MR from grade 4 to 2+ because it was an acute situation. If you can please go to the pictures Dr. Shraddha was showing. There, Arvind sir, we could see that the jet was going not in the central part, it was little bit more medial.
So this is called pseudoprolapse.
Yes.
It's called pseudoprolapse.
So if we have to plan this case again now in today's scenario with the new types of clips and the multiple clips, what would be our strategy to have the 2 clips, or would you be comfortable with a single one?
Single clip. It's a single clip situation. 2 clips. I use 2 clips based on the width of the jet. So what is the amount of leaflets being involved? If you could see this, the amount of leaflets being involved were not more than 14 mm or more than 11 mm.
Our area was also 3.4 centimeters square. It was
Okay,
not
okay,
even
okay,
more than
okay.
4, yes.
So, the jet was little bit towards medial side. So maybe, I mean, it was not a typical central jet where we put the...
So that is because of pseudoprolapse. So what happened is that the PML is not coming at the right place. The AML is coming. So you are actually thinking that AML is prolapsing, and as a result it is giving an eccentric jet, but actually PML is not coming.
Yes.
So PML is
It
remaining
a
inside the
secondary
alveoli.
MR as well. So we don't want to completely, I mean, like come back to the trace level as well.
Definitely.
So keeping it 1+ or 2+ is obviously helps.
Yeah, this was a good result actually. On that day it was good. Maybe on follow-up you are seeing, you decrease the gain or what, I don't know. This was a good result.
No.
So what we said, that we were ready to accept mild to moderate. On follow-up,
In SMR it is
once we
obviously
got mild to moderate, but that was due to LRT, acute exacerbation of COPD. Her heart failure precipitated. But after that, when we got control of atrial fibrillation, her COPD on overnight BiPAP, she has never gone beyond mild.
She never has grade 2/4. It is always
No
grade
admission
2/4.
for last 2 years.
Yes.
Perfect results. Congratulations for the
How do you assess for
primary
SLD? How do you assess for SLD is single leaflet
for
detachment?
SLD, that is a good question actually if you are doing a clip. So when we clip, there are certain parts of the clip procedure where we see that it goes well before completely being certain that we are coming out. So the first part is, the clip is like this, the leaflets are, falling on the clip, these are the clip arms, and there will be grasper arms or gripper arms. We drop the grippers. While we have dropped the grippers, the echo guy is actually showing us that the leaflet is between the grippers and the clip. So if the leaflet is between the gripper and the clips, the grippers will be bouncing. So this is the leaflet, and there is this gripper. So this gripper will be bouncing like this. This is seen very well on the image. Once that is done, we close it. And once we have closed that, on closing the MR will decrease. That is one part. Second part is that we see on 3D that there is a good tissue bridge, which was seen in this case. So you could see that there is a good tissue bridge. What happens is that if we are not able to see the gripper arms falling properly, we may miss it. That is the most important part of it, and that gripper bounce is very important to assess. Once that is done, it should usually work. It works. Other than that, sometimes we are not able to see anything, and still people want to clip. I have seen SLDs more than 6 times. Huh? Yeah, so that is SLD is a kind of embolization only. So it leaves one leaflet because we saw one.
Generally, at least it will hold one leaflet.
Yeah,
so
yeah.
it will not completely embolize, but one of the leaflets will be in the gripper.
So if you can see this here, the grippers are actually bouncing. If you can keep on looking at it, the grippers are actually bouncing.
This shows the bouncing. After grasping, this is the image.
Thank you for nice presentation. Any next speaker?
No, sir, this session is closed. Dr. Parminder is not available due to some family commitments.
Thank you. Now session closed.
So we are closing this session. We move on to the next session, that is CTO intervention, and we have with us Dr. V. Surya Prakash Rao. He is the authority of CTO in India. He is one of the four faculties of Indo-Japanese CTO Club, which is basically collaboration of India and Japan CTO operators. For this session, I will be calling upon the chairpersons, Dr. Jitendra Kumar Mishra, Dr. Rohit Kumar, Dr. Neeraj Kumar, Dr. Gaurav Tripathi, Dr. Dhananjay Kumar, and panelists Dr. Dipankar Vats, Dr. Madhu Gupta, Dr. Ashish Ranjan. I request Dr. Vineet Kumar to join us for this session. Dr. Ankit Gupta, if he can join us for this session. Dr. Dhananjay is here, Dr. Dhananjay Kumar from Ranchi. He is a very fine CTO operator in Ranchi. I will like to ask him to join us. And over to Surya Prakash sir. He will deliver imaging guided lecture, imaging guided CTO PCI. How do we do it?
Thank you for the organizers of this Medanta Conclave 25 Patna. And I visited almost all cities in India as a proctor last, I think, 15 years, except Patna. So I'm very happy that I'm here today. So CTO PCI, I think it's now standardized in most of the centers in India also. The success rates have increased more than 90% in established centers. And the trends have changed from simple anti-grade wiring to retrograde to re-entry systems, then the IVAS guided. So the IVAS guided CTO PCI making big impacts in the outcomes with more safety and better outcomes. So this is very important. In the IVAS catheters, there are many IVAS catheters available, and particularly in India we got established catheters like Philips and Boston, and many other companies are coming. But in so you need the IVAS is important in first thing is pre-stenting for a successful wiring, and second is placement of the stenting and how we do post-stenting evaluation.
You have to project this.
And is it okay? And evaluation of the late responses after stenting and the follow-up. These are all three indications of the IVAS in CTO PCI. And so there are catheters from Philips and Boston. In India, this Navi Focus and anti-hole catheters which are very low profile, and those catheters are not available. But what are available is the Philips catheter has got a 20 megahertz and 40 megahertz. Can I move the slides, please? Can I? Yes. So in this, you have seen the IVAS navigated wiring first thing, and second thing is this stumpless CTOs. This is the area where IVAS is used predominantly. The stumpless CTOs, ambiguous cap, most difficult. That means the JCTO score increases. As the JCTO score increases more than 1, 2, 3, 4 like that, usually we used to go for retrograde procedures. My retrograde number is to be very high. Then once the IVAS has come, in the many ways of doing robust antigrade techniques, so the retrograde has numbers stable at my operations around more than 1500. I have done only 88% of the retrograde, and mostly antigrade we are able to do. Repositioning of the guide wire once you are subintimal. It's very common you enter subintimal and you have to enter the repositioning. And as I told, can somebody help me in the slides? So So this is over. I have to go to. Yes. So these are the catheters what I told you. We don't have a Navi focus which is 9 millimeter tip to transducer. This is very important. When you place a catheter in the side branch, shortest tip to transducer distance is important. This is not available with us. And what available with us is the Philips one which is 2.5 millimeter and the Opticross 60 which is a Boston which is around 20 millimeter tip to transducer. That is important. The more bulky the catheter is very difficult to navigate into the side branch. So there are algorithms like APCTO, the Asia Pacific algorithm, and the global chronic total. Fortunately, I am also contributed to this algorithm. In this, I was made a big role, and the parallel wire remains same. That's very important. Many think parallel wire technique is older one, but still in both algorithms parallel wire is there. But I was made a big issue. This, when you find an ambiguous cap, and I am not going entirely into this big algorithm and all. Simple thing, remember, the ambiguous cap is there. There is a side branch. That's a classical indication. You can have a IVAS guided puncture rather than going to a retrograde procedure, which we used to do very often. And this is a simple thing. When you place the IVAS catheter and the wire which is in the subintima, how to track into the true lumina. This is called wire-based re-entry. You can do a IVAS-based re-entry. So there are usually, we need 7 French system minimum for the IVAS guided puncture. When you want to do a real IVAS guided live puncture, you need 8 French because we need to put a microcatheter and you need to have IVAS in the system. So this is very important. But there are systems have advanced now with the Navi focus catheter which is available in Japan and anti-hole IVAS catheter. We can place on one wire both the microcatheter and the IVAS. So this system is very useful to have proximal puncture. So this is very important. If you see the double lumen microcatheter and the IVAS on the same septal branch, the tips of the IVAS guided entries, the branch, the closer the branch to the C2O lesion is better, and confirmation of the wild position by the IVAS. These two are important. So I will show some cases which I have done in some centers as a demo or in live demo cases in my forums. This is a RCA C2O. If you see a RCA C2O ambiguous cap, if you have either a conus or a big sinus branch, what you can do is keep the IVAS catheter in the side branch and slowly pull back into the main artery, and you can see a shadow. How to recognize the shadow is that if you see a circular or elliptical shadow with calcification, this is the way you should recognize the thing. There you can have your second wire manipulation to the CTO PCA. In this you can see at the 12 o'clock in the RCA, you can see the this thing. So this is a LED bifurcation CTO. You see, I tried the retrograde technique also here. Somehow I could pass septal collateral with the Corsair catheter and all, but still there is a difficulty in doing the case retrograde also. So we tried this as an antegrade IVAS catheter manipulation from the diagonal to LED. Then the retrograde wire and the catheter acted as a for me as a landmark for puncturing from the antegrade. This is very bifurcation CTO. So you can see here at the 12 o'clock, the LED position, there is a second wire we could penetrate. Finally, this is a good result. There, of course, when you do retrograde procedures, this type of stannings are not uncommon, but not alarming, these things. This is another case done in my lab only recently. This one is a big diagonal and LED CTO, mid CTO, and ipsilateral. Remember, there is no contralateral collateral. These cases are difficult. If you don't find a retrograde collateral from the right coronary in LED CTO, it's very difficult. So there is only ipsilateral from the diagonal coming LED. If you observe long segment, these are very difficult cases. So IVAS really helped me in this case. So when I placed the catheter in the Boston, because if the side branch length is more, I can place the tip to transducer 20 millimeter Boston in this, and Boston gives really good resolution images what I have observed, whatever available in India now. And you can see at the 3 o'clock position a cap of the LED, which is a calcium and elliptical. Loss of media is another good sign. How when you are entering into the CTO segment, the pictures from the diagonal to LED, that's where we identify. You can see here nicely, and this real-time puncture done in that, and we could succeed. This type of resolution images are very important when you do IVUS. They are also important when you keep the IVUS catheter in the side branch. If there is a big bridging collateral or anything, if you block it, sometimes patient can have symptoms. You have to be very careful, and bulky catheters, don't try to negotiate to the side branches. So this is the final result in this case with some pinching of the diagonal, which TIMI3 flow, so we did not do anything for it. So another thing is retrograde procedures, not only antegrade, retrograde. This case has been there's a tight lesion RCA, distal total occlusion, difficult near bifurcation, long segment C2O. These are the cases for retrograde cases. So primary retrograde. So what we have done is we could negotiate the microcatheter and wires up to the distal C2O segment, but here there is a difficulty to do reverse cart. So I have to do many maneuvers in this. What is important is in this type long segments we use knuckle. We create a knuckle with some wires like a filter XT or cyan black or a gladius wire, and this knuckle we have to watch in the IVUS before taking it to the antegrade guiding side. So here we have done this, like I have used an anchor balloon on the antegrade side system and a retrograde knuckle which is tracked. And when tracking, I have to keep a IVUS catheter in the antegrade wire and see what is the wire position. So this wire position is very key. You see there are 4 wire positions in retrograde cases. Both wires in the subintima is easy to cross and for a success for a reverse card. One in the intima, one in the subintima are always not that easy. So the most difficult case is the antegrade wire in the subintima and retrograde wire in the intima is a difficult situation. Most easy is both are in the subintima easy. So you should find before externalizing the wire, you should know the IVUS things. So this is all other case of stumpless CTO. You can easily see that the nicely found at the 9 o'clock, 8 to 9 o'clock position with the IVUS guided puncture. So this way we do it. This is another case, ipsilateral collateral, no contralateral collateral, long segments LED CTO, and this is technique what we call ping pong technique. So I use a double catheter, 7 French, and the septal collateral which is feeding the distal LED segment is crossed with the SUO wire and the Corwell catheter, and we make a loop like this. And the wire's position, when you are entering the left main, we should always check with IVUS. Here the IVUS is very important decision making. Once you are in both wires in the same lumen, then only we should externalize into the other guiding, which is called a ping pong technique. So this IVUS guided ADR, you see once you are in the subintima, how to enter into the true lumen. So this is also we make the IVUS made re-entries. I have done case, any CTO operator will be doing some of the cases subintimal intentionally. It's called last technique. If you cross only limited segment, it's called limited subintimal tracking. If you do star technique, it's a long distance subintimal tracking. So I got follow up of many patients. People are scared that it will cause thrombosis or restenosis. Actually, in many cases, the chance of restenosis are also very less. This case has 11 years follow up. I have done intentional subintimal stenting. There is no other way. That time there is no retrograde collateral. So after 11 years, the follow up of this IVUS is available, and is what you are seeing. The stent is in the subintimal, and the true lumen you can see side. So this patient is doing well. This is a classical example of how the CTO follow up with the IVUS. And I was also can show you diffuse spasm without any atherosclerosis. That is also important. You find a lot of times myocardial spasm or diffuse disease. And sizing of the stent, as you know, like any PCI, end result optimization of the stent. And hematomas, very important. You notice a lot of hematomas when you're doing the wire cross or balloon dilatations, manipulations. We find hematomas. Either we take with a microcatheter, these hematomas we can aspirate, or you can cut with a cutting balloon. You can always make them, and otherwise you have to stent it carefully. So you can always find the edge dissections also. IVAS helps you like any other imaging technique. So the IVAS in CTO PCA helps to understand morphology of the CTO plaque and calcium. It accurately identifies the true lumen at the proximal cap, which is essential for the successful guide entry. And IVAS dissection and re-entry techniques confirming the guide position in true lumen is for safety and effectiveness. Post PCA IVAS optimal stent sizing and expansion. And very important recently is the tip detection method. Because of lack of time, I could not show you. We used to do all wire entry. We can do because once you do many cases, you can do a wire entry, typical Gaia wires, which are very useful, or you can make a curve on the tip of the tough wires also. Carefully you can enter wire entry. But when you are not doing many cases, you should do it very carefully with IVAS. This is what Dr. Okamura from Japan has initiated this. This is a tip detection method. We put the very low profile anti-wall catheter on the false lumen wire, then pull back the wire slowly. At some point where there is no calcium, we make with a wire called conquest CT wire. So we enter the true lumen. This is called tip detection method. Thank you.
Thank you. Thank you so much, sir. It is always a privilege for us to hear from Rao, sir. Just a single question, sir. Whenever we do retrograde from the septal to septal, it is definitely a challenge for us to again put the microcatheter down and then take up. It is many a times it becomes difficult to cross the lesion with that angle. So do you have any special tips and tricks for crossing the lesion with such type of angles?
No, here what you have to see is you have to take the right angle, that cranial views and caudal views. Both views you have to check. Very important. And other thing is, use catheters which are very low profile, atraumatic microcatheters like Carvel catheter is very good. And the SUO03 wire is a very atraumatic wire, which is also should be used. And more important thing is selective injections. Once you are any doubt, any resistance, any VPC is coming, don't try to force the catheter or wire. Just aspirate. If it is coming smoothly, then only inject. So these are some techniques without damaging the septal.
Thank you so much, sir. I would like to invite here on the dais, and here is your session, another session. Vineet Bose will present the case, and sir, please.
सेव तो करवा दिए थे। इसमें हाथ बोल के रुक जाना है ना वहाँ पे।
शुरू में
Will do, कोई नहीं।
There is no other option. They are very attractive, and they invite you to do the procedure, but a perforation of the epicardial to manage is very difficult.
And simultaneously, sir, if you have the hardware for the epicardial, then only you should proceed. The Caraval, the SUO, these are the hardware you should have before attempting the.
Very warm good evening to everyone, and thank you Samsad and team Medanta for inviting me. This is the story of a 77-year-old gentleman having history of old infraval MI. Now he came with effort angina, function class 2. Echocardiography, ejection fraction was mild LV systolic dysfunctions, RWMA was in RCA territory. And stress test was positive. That angiography was done that saw that RCA, CTO and LAD have the significant calcified lesion. This is the bilateral injection. And this is the LAD. Samsad told, based on that we want sir's opinion. So how to proceed, sir? Then he told me to saw how I have done that one. So.
Here you have RCA CTO.
Yes, sir. Yes, sir.
So this is a must dual injection what you have given. You should give in both cranial and caudal views, and it's a RCA proximal small stump is there, and use it as side pole catheter ampullage for the RCA.
Sorry, sir.
Used ampullage.
Ampullage is there, sir. It's ampullage, yes.
So you are asking me what is the approach to this patient?
Yeah, he told like that, so I told you.
Okay, okay. I think once you have seen a good retrograde collateral, and initial strategies always antegrade in this type of cases. The initial wire what I take, I never take a CTO wire in the beginning. What I do is I take a routine wire with the microcatheter track to the proximal cap. Why? Because if you lose the tip of the CTO wire, that is a success story there. You have to unnecessarily use another wire. So for cost effectiveness, I use a simple wire, then take to the proximal cap, and after that I will take the suitable wire. Like here it looks like a mid-RCA long segment CTO with a retrograde collateral coming from the septals from the LAD. You have any CT of this patient? Any CT?
No, sir. CT scan we have not
no
done
CT.
for that.
But the history suggests of very chronic occlusion only.
Yes, sir. Because there was the old history of myocardial infarctions.
Very
almost more than 1.5 years back.
Yes.
Calcium was seen very significantly on the fluoroscopy.
Yes. So you can always try. This is a concept called soft tissue tracking in any tough CTO also. 10% of the case can have a soft tissue tracking. So something like a fielder series of wires, fielder XT, R or EA can be tried in the beginning to make a, if you find little difficult, immediately escalate the wire. Don't go on poking with that wire. A Gaia series is a good wire. Where either you take a Gaia simple or a Gaia next, which is next is 2 is like 4 grams. Is okay. If you take a Gaia 1, again 2, not much difference. Gaia 1 is 1.5, Gaia 2 is 3 grams. So I usually use directly Gaia 2, not wasting the wires. So with a microcatheter of suitable, any microcatheter is good enough, you know, unless you find a lot of calcium, where we recently are using the turnpike catheters, which are good when you find a calcium. Otherwise, Corsair group, any group is good enough. And mainly important is you have to see in two views. For the RCA, not only in the LA view, RAO view is very important.
Yes.
When you find difficult, escalation of the wire should be done fast. Don't try to poke too many times with the same wire. And in these two wires, with Gaia series of wires, you have a one-to-one manipulation. That's a big advantage. in a LAV view. I use a lateral view also. Most of the European operators, they don't suggest lateral because the radiation is more. But the success rate is more in RCA in lateral view, what I have seen many times. So I use the three views. I call it as a 3D wiring. The mathematics 3D wiring, I don't believe. I believe in going to three views. You tip direction change with the wire in three views, you can easily puncture the distal cap. If you find difficulty in puncturing the distal cap here, stop there. If you wire in the subintima, there are two techniques. Either you go use a parallel wire, simple one, or you put a IVOS on the wire, see where is the wire in the subintima, then you can make a wire re-entry with the IVOS guided. Or if you have a Stingray ADR device, that's also because there are no good branches in RCA, that is always, it is away from the bifurcation. So the second cap, distal cap, you can use that also. Suppose you're lasting 30 minutes after trying this wiring anti-grade, don't prolong the this case beyond that time usually. You go for a retrograde procedure, because that's why you have to prepare not only a diagnostic catheter on the left side, in a real CTO of long length, I put two 7 French catheters bifemoral. That is more easier. You can change to the retrograde system. Yes. I think this is the approach.
Yeah, thank you. Thank you for enlightening. This patient have already attempted for that RCA CTO angioplasty in other hospital, and they have advised for the CABG, but he was not willing for the same, so he came for that, and we can see here it was almost blunt tip calcification was there, attempted earlier, so JCTO is coming 3. Microcatheter was placed with filter FC wire, as sir have told. Initial name want to see how much hard it is, and we did not want to injure the initial proximal part. So, but that filter FC wire was not going, so we have changed it to Gaia 2 wire. It was attempted several times, but we can see here in this one it's going in some other place, not in actually true lumens, as we can see in the retrograde injections. But after multiple failed attempt, we can able to negotiate with the Gaia 2, and luckily that microcatheter was advanced, and we can taken the microcatheter injections, and we can visualize the distal part, and after that we have removed that Gaia 2 filter FC wire was exchanged with the Gaia 2, and microcatheter was removed, and after that things was relatively easy. We have serially dilated with the semi-compliant balloon, initially with the smaller and then followed by the bigger balloon. Dissection was noted, and after that we have stented with drug-eluting stent, and after stenting flow was good, so we have dilated with a non-compliant balloon with higher pressure, and that final flow was okay. And there was a LED was very highly calcified, so we have wired and used that for initially we have dilated with the semi-compliant balloon, and after that we have used that IVL, and after IVL that calcium was broken, and we have stented, and after stenting that we can able to get the good lumen, and we have dilated with the non-compliant balloon, and that this is the final LED result, whatever we got there. Thank you.
Thank you so much, Vinit Boss. It was a great case, and so much of learning from this. Basically, you were doing a CTO case with the distal end at bifurcation. You attempted anterograde. There is some dissection extending into the PLV, and thankfully everything was fantastic.
Yeah.
Thank you so much.
No, as sir was told initially, that one, two thing definitely we need to remember. Directly hard wire should not be used. Just for microcatheter, up to reach there, up to the CTO cap, we need some simple wire so that endothelium before that should not be damaged during that manipulation. That is a very, very good things. Otherwise, sometimes we are usually damaging the wire or endothelium just before starting the CTO. That I have seen. That is very, very bad things. That can be easily avoided.
Yeah.
Yeah, so this is the usual practice. Suppose we have to go to till mid LED, and there is a left main to LED, there is a curve, and then the LED also, although it's straighter, so this curved portion has to be negotiated with a normal wire, not with a CTO wire. Otherwise, you have to give bend to the CTO wire, and that entire thing is
Wire
lost, and
will
that
damage.
can injure the vessel also. Yeah, yes, sir.
Now we have another stalwart, Dr. Dilip Kumar, and he is going to present us orbital atherectomy. Is it a replacement for rotablation?
इसको निकाल देना. Thank you. So I will be a little brief. We are running little late, so calcium is a problem which we all have been feeling and experiencing, and now we are seeing more and more with the imaging modalities. So we can underestimate calcium, like you see here. We feel that there is nothing much of calcium, but when we do OCT, we get to see that there is a 360-degree calcium there, and then we plan and do the things accordingly. And the nature of calcium, kind of calcium which we get, superficial, deep, eccentric, concentric, nodule, decides the fate of the stent expansion. And it's a proven fact that if we have more calcium, the stent expansion is a problem, and that can lead to the final outcome to the patient. So we have different scoring systems based on which we decide our atherectomy device. And these are basically, I think, known to everyone. The place where calcium is, we have to decide our calcium modification tool, something which is very, if the calcium is deep, rota is not going to modify this. IVL is going to work. If there is a superficial, then rota and orbital both are going to work. But if it's concentric or eccentric, that also comes, and nodule, then orbital and IVL becomes better. So we have a lot of options, but still our age-old rota has a special situation, special place in atherectomy. So this patient, what will you do? Severely calcified, diffuse disease, and then rotablation was the answer. And we passed 1.25, then 1.5, then finally stented, and then we got away with a good result, decent result rather. But many times rota fails. So we need something which can be better and which can overcome the problems which where rota gives us the kind of inability to perform or the complications which it leads to. Like this situation where there is a eccentric calcium with a calcium nodule, and while doing rota, you can appreciate rota got stuck. So this is one of the most horrible situations. When you are stuck in these situations, you feel that you are so helpless, and asking for surgeon's help, to praying to God, everything goes hand in hand with your side wiring and hoping that your guide extension goes in, relieves it, or maybe a balloon modifies the plaque and then you take out the rota. It's a very, very difficult situation. But majority of the times the manual traction works for these patients, but it's a very difficult situation. Many times when you use rota, you can still use, you still have to use many more modification tools. Like in this situation, there was a OPN, there was a cutting balloon, and then even then the expansion was not very optimal. So we need to have a device which is easy to take in. The preparation should be easy. The chances of stuck is should be lesser, and then device should be going some more limitations of rota should be countered with the device. Orbital atherectomy is well placed there. This is a system which acts by electricity, not by gas. They don't need a powered gas to be there to check how much pressure you are generating, whether you are reading 150,000, 130,000. This electrical system, you switch it on, place everything is on table, and then you can push and play with the knobs and do the procedure. There is a dedicated hyperslide lubricant, so there is no alternate here. So it is a extremely useful solution which makes the movement of the orbital, the crown very smooth on the wire. And then these are the Viper wire advanced, flex tip wire is now available, which is 1 gram tip load, and which has the tip which is 014, but in which the transition is it goes to 008, and then the shaft is 012. And this is the orbital atherectomy device where there is an advanced knob of the crown, and then we have both the systems. We just switch it on, press a little longer, you go to the glide assist mode, and then you have to shift to the movement of speed of 80,000 to 120,000 depending on the switch which is there. And the crown has a saline sheath, drive shaft, and a crown which is diamond coated on stainless steel. And this is the difference where from rota there is additional difference that it has two dual mechanism of action. One is it does cause atherectomy, but in addition it also modifies the compliance of the vessel, and it also modifies the deep calcium. This happens because of pulsatile force which this eccentric mounted the orbital crown, when it is rotating, it is giving this pulsatile force, and with this force the deep calcium is also getting modified. So you can appreciate how it's performing. It rotates and also it orbits. So there is a two-way it's moving, and also with mechanical force and pulsatile force it causes change in the compliance of the vessel by modifying the deep calcium. Even if there is a guide wire bias, the orbital makes it little less central when it moves and orbits. So this is also a difference with rota and this calcium modification which we also discussed. And we can appreciate here the pulsatile force and how the compliance differs. The left panel you can see before the orbital atherectomy, and the right side how the compliance has changed. So essentially as compared to orbital, rotational atherectomy, orbital has a dual mechanism of action, and also it cuts both forwards and backwards. That is an additional benefit, and that's why the entrapment is lesser. So it is not like there is no entrapment happens with orbital atherectomy. It happens, but it is very, very less common, and it's very user friendly. Lesion crossing is similar. Positioning the guide wire spring coil should be at least 5 mm distal to the the crown where you are going distal most. That is very important. And relieving the drive shaft compression is important. So this is one tips which I would like to share with everyone. When we are advancing the crown over the wire till the coronary tree, till the left main, the advanced knob should be at least 1 centimeter distal to the proximal most part of the entire advancing place. And once you are in, you come to the most proximal part, so the tension which was generated can be relieved. So this is a very important tips, and this should not be ignored and forgotten. Starting and stopping is also very we have to be meticulous, and it has the brake should be on, and this is the advantage in orbital. If the brake is on, only then there will be a rotation happen. Otherwise, the device will not rotate or orbit. Complete the procedure, come out with glide assist, and the movement is very important. And you can get the sound which gives you an idea that you are cutting and sanding more. And the movement should be 1 to 3 millimeter per second. And crown should never be stopped at one place. When it is moving, it should not be stopped, because when you're stopping and you are not moving it and the rotation is happening, it can cause injury, because it can be a larger cut and that can cause dissection. So it has to be on motion, although motion should be very slow. 1 to 3 millimeter per second is the kind of recommended speed, what is called traverse speed, and maintain 1:1 motion. So it should not be stopped. Same time should not be very fast. So 1 to 3 millimeter per second should be the rotational speed. As we can see here, the treatment diameter is affected by the traverse speed. So if your traverse speed is less and rotation is more, you are going to cut larger. So suppose you are stopping, just stalling somewhere, and it is moving and rotating, it can cut larger and larger and cause dissection. So it has to be some movement is there. 1 millimeter per second at high speed, it gives you the best possible cut, and this is the way it should be done. So these are the considerations. It treats bidirectionally, use fluoroscopy to monitor treatment, and is also one benefit. Once we are doing orbital atherectomy, the catheter is there, still you can push injections and you can see the vessel is flowing or not. Chances of slow flow is very less, because the particles which are generated is usually less than 2 micrometer, and which is lesser than an RBC size. So the chances of slow flow is very less. So this was a case which just a sample case. We can see here how big the calcium chunk is, and then IVUS you can appreciate all variety of calcium is there. You can see the calcium nodule, protruding calcium nodule. Now comes the arc of the calcium, which is this is a superficial calcium, but you can see the shadowing, which is very dark, and then it comes to 360-degree arc of calcium. So all calcium morphology was there. It was with orbital atherectomy we gave 80,000 to 120,000 rotations per minute. Both the speeds were given here with 6-7 runs, and finally this was IVUS after the modification. We can see a lot of modification has happened, and then there was further cutting balloon dilatation followed by stent expansion. You can see here the lesion yielding up, and this was a stent deployment. This was a post-bypass surgery patient with a CRT device done by me, and this was the final result. So this is my last slide. We all are aware when to choose which device. Orbital has a special place in all this algorithm where you can use this device at a replacement of rota, osteal lesions. It's very lucrative. It go in, cause reverse cutting, come down, and when the vessel is larger, orbital atherectomy also becomes handy. Thank you so much for the patient hearing.
Thank you, sir. Thank you so much for the lucrative and very descriptive discussion on this orbital atherectomy. Sir, do you prefer using orbital atherectomy in CTO cases?
So yeah, the CTO and angulation, these are two places where we should be avoiding orbital atherectomy. Yeah.
Sir. So this is the two basic learning in orbital atherectomy. Orbital atherectomy has basically two movement. One movement is on its own axis, and another movement across the axis of vessel. So if I have experience of 1 or 2 cases on CTO, and if you are trying to use it like a rota ablation, so just pull it little faster. Like if 1 mm per second is the suggested movement, you keep it like 2 mm per second and try to make it more like rota rather than it orbital. So it will create a gap inside the CTO segment, and then you imagine the segment, whether you are how much you are outside the intima. If subintimal space is quite longer and you have to use any atherectomy device, better to use IVL there.
So very true. So if you have come down on speed, or rather you have gone up on the speed, the effectivity of orbital becomes less. Yes. That's what you want.
Yes,
you don't want a very aggressive cut there to cause more and more massive, or nasty dissections here.
Thank you so much. Thank you so much, sir.
There is one unique case presented in DCT 2025. This guy is from, I think, Korea. His rota got stuck in RCA, calcified lesions. Then he passed another rota, parallel rota, to remove the rota. Did not work. Then he used orbital to cut the rota. So this is a unique case, and this is one of the best cases presented in DCT 2025. And also there are some reports in US. You can use this orbital to cut the to remove the rota.
So we have another case with Dr. Samsad, Dr. Ankit Gupta.
Let me summarize this case. We had a 75 years old diabetic male, hypertensive male with COPD. He had underwent PTCA to LED almost 18 months back. Presented to us with exertion angina on day-to-day activities in spite of being on medical management. He underwent coronary angiogram, which revealed LED stent ISR type 4 CTO with grade 1 to 2 collaterals filling from the homocollateral supply. Ejection fraction was 35 to 40%. He was optimized on optimal medical therapy again if he gets some relief from his symptoms. But he again presented with the same symptoms, persistent effort angina was there. So I will request Dr. Ankit if he is here. Dr. Ankit. Yeah, this is the angiogram. So basically it was a left dominant circulation, so I do not need to show angiogram of right coronary artery. Persistent symptoms in spite of being on optimized medical therapy. You can come over here on the dais, Dr. Ankit.
He's asking how you will approach the case.
Yeah, I think we can. I'm going to approach with a microcatheter to wire this big LED first, so that we can easily cross the lesion. And thereafter, if we able to cross the lesion, and thereafter we will going to do the IVUS, as the patient is elderly and with multiple comorbidities, so we can. Do you have any RCA?
It's a non-dominant RCA. What we can say. So homocollateral is there.
First, describe the angio properly. What do you see on the angiogram?
It is a heavily calcified LED.
It's ISR CTO. Angioplasty was done 1.5 years back. He told in history.
Yes. So basically we need to wire it first so that we can after imaging we can easily know the morphology of the plaque of the ISR, so that accordingly we can use what modalities to make the better lumen for this type of calcified. It seems like a calcified LED ISR.
So, Samsad, whether it was chronic or acute on chronic?
So basically, I think it's a chronic because the patient was symptomatic for more than 6 months.
Okay.
So it was hardly 7 to 8 months after angioplasty, he again went symptomatic. So he presented to me for more than 6 months of being symptomatic. So basically how I proceeded. So basically it is a CTO PCI, and another added thing is a stent ISR CTO type 4. So basically we have to choose the hardware and how we will do it. So first of all, what I did, I initiated with Fielder XT on a microcatheter. I just took the feel, how is the proximal cap. So the proximal cap was tough. It was, in the first feel I found that it is not going to be done by Fielder XT. So I shifted to Gaia 2. Gaia 2 was tried repeatedly. It easily then punctured the proximal cap. When we proceeded further, there was some difficulty. The feel of the wire was like that it is going through the strut and then coming back to the lumen. So repeated try was given for this, but finally we went to the luminal space and distally it was quite well visible that it is in the lumen, but still we were not sure that whether that stent has crossed through the stent struts in between, because the mid part of the stent in 3D view, during 3D wiring also, I found I was not sure that whether I was completely intranumeral through and through in the stent. So what I did, I went with parallel wire technique. So for parallel wire, I use Fielder XT. So initially,
can you perceive the angiogram? Can you see that in the mid segment of the LED there is a muscle bridge?
Yeah, there is a muscle bridge after the stented segment.
Yeah,
yeah.
So there is a significant muscle bridge. Even without angiogram, you can see.
So basically,
without inject, you can see the movement of the wire.
Yes.
You can play that so that people should know that this area should be avoided for stenting. Look, that probably that mid part is having muscle bridge, that segment.
So what I did for parallel wire technique, I used Fielder XT, but it was difficult to enter the proximal cap. So I dilated that proximal cap only with a 1:5 balloon, but only to the proximal segment, because I was not sure whether in the mid part of the stent of my wire was through the stent struts or not. But proximally I was sure that it went through the intraluminal space. After dilating that proximal part of the stent, the Fielder XT wire went easily over microcatheter. Then further the things were a lot easy. Serial dilatation was done by 2 balloon, 2.5 balloon, cutting balloon, Wolverine, and for initial pre-dilatation, this was the IVUS images which I can see. This was the distal to the stent, the first, then in the stent. So there was significant under expansion of the stent. That was the major cause. And second, the neointimal hyperplasia was there due to that significant under expansion. The proximal LED was a catch point here. It was an eccentric plaque. On the epicranial view, it was not that much critical, but on caudal view, it was an eccentric 70% plaque. On IVUS also, it was a calcified. The MSA, MLM, inner luminal area, it was hardly 3.5 mm square, that in the part of proximal LED. So after dilatation, what I found that the distal, after the stented segment, it was a bridge, but along with there was significant plaque, which was quite obvious on the IVUS images. So we prepared that also with a 2 into 10 mm cutting balloon Wolverine, followed by 2.25 into 20 mm NC. And after that, what we did, after adequate preparation at high pressure, that stented segment, which was ISR CTO, we did a deb with a 3 mm protege, 20 mm, and we can use it twice, thrice in the same vessel. So we use it repeatedly. From proximal part we went at high pressure, in mid part nominal pressure, and distal part of the stent we went at a low pressure of 6 atmosphere only. Then after that, the mid-distal part of LED, it was diseased and diffusely diseased. So we use a depth of 2.25 mm into 40 mm because the vessel size was not greater than 2.25 mm at a nominal pressure. So this was the final result. That proximal lesion, we can see there was a eccentric plaque, and IVUS it was clear that this is a significant stenosis, calcified stenosis. So we used a stent 3.5 mm 23 des, followed by high pressure post dilatation by a 4 mm NC, and this was the final result which we got. And IVUS images post stenting and everything, this is the final IVUS images. Through the stented portion we were able to achieve a good luminal area through the stent ISR, and the proximal segment we got it well expanded after high pressure ballooning. Thank you.
Excellent case, Samsad. And how did you do parallel wiring? Did you use dual lumen
No,
microcatheter?
actually I was using a 6 French EBU. Ideally it should be a 7 French at least for using a 2 microcatheter. So I removed microcatheter from the Gaia wire because it was a landmark for me, and then I went with filter XT through the same microcatheter.
He's asking about the dual lumen catheter.
Yeah,
So dual lumen actually we were not having. That's why we had to use a single lumen microcatheter.
Oh yeah, that's a great idea. I think that exactly same point I wanted to make. If you have recross like dual lumen catheter, if you're not sure whether the wire is subintimal, you can pass another wire, maybe a simple wire this time, much simpler, less harder wire, and you can enter from false to true. So dual lumen catheter. If you have a laser in your institute, this is just a 30-second case. You just pass the laser. The point which I wanted to make, there is a study by Margaret. She was in UK, now she has moved to US, and she is an avid imager and CTO operator. In that particular study, around 200 patients CTO, they have shown that 30% of this kind of mid-LED lesion CTO, they have muscle breach. So if you have a muscle breach, doing or putting another stent, it definitely is not the right way to do it. Drug-coated balloon is the best approach in treating the small vessel. So where is the data? Data from solution, ISR, DEB, present in TCT 2025. If you have one layer of stent, then perhaps your DS and DEB is as good as not. But if you have two layers of stents, definitely the DEB will be superior than another DS. Thinner DS will be preferred one because you do not know what thickness of stent you had. If you have that, better to go from thinner DS this time, like supraflex screws, Biomine. Thinner start is less.
So what will be your what will be your drug coated balloon choice for the native vessel? I mean, in the there has been some studies and controversial that some uses the side branches for the backlit axle, and the native vessels like LED, they are better results for the sirolimus.
One is agent trial, ID trial, but this is the RCT. Solution is RCT, stent versus balloon. Balloon means DEB, and you can use both. There are only two lima stent in India. There is Magic Touch and Solution.
Yes,
and
yes.
Several packed axle. You use packed axle.
Yeah, it is. It is.
So not much of difference. But if really a purist, there is a data on Solution only with ISR.
So
no,
basically,
about the not the ISR, sir. So native vessels for the in the distal LED is using the drug coated balloon.
Yeah.
He's asking.
It is not.
You can use anyone.
Okay.
Both are good.
The solution, the trial which was presented in DCT, there was little bit of the inclusive criteria was little strange. Usually what has been done in all the conventional RCTs with DCBs is the patients were randomized after the lesion preparation. Now lesion preparation is done, you can go well with DCB versus stent, and then you are randomizing. But this trial, Solution SR trial, they randomized before lesion preparation, upfront. So how much it has contributed to the end result is really unknown. So that is a little fallacy which was there in the trial.
This trial, that actually removes the bias.
No,
Yes.
sir. It can even
So
increase the bias.
it becomes
So
his
you can
open level.
Let's say you have a dissection after you have prepared the vessel. Then, it will be very difficult for you to choose a deb in that.
You can see in both ways, sir.
Yes.
There is a level playing field. Once the lesion is prepared, both way you can go. You know that both way results will be better on table. Then you are done. But in this condition, upfront you have decided, no, I will go with DCB. You will be more cautious. You will be more kind of ideas. Go ahead with the lighter ballooning and all. There will be a lot of things which will be there in your mind while you are doing the procedure upfront.
So one of the
so both way it can hamper the results.
But in this trial, very, very small percentage of people had cutting balloon or anything. This is a unique thing about this trial, that what we usually do is that the use of cutting balloon in pre-DCB is very high amongst us, but very small percentage, 10 or 12% only had this. So the lesion was prepared in a very traditional way, very traditional way.
Yeah, I fully agree that if you have this thing in your mind after cutting balloon, which is around 1/3, less than 1/3, mostly normal balloon, non-compliant balloon, OPN balloon has been used, then you have a bias. Like as an operator, if I see bad dissection, why should I send this patient for the trial? So it becomes an open label trial rather than truly randomized trial. So this is a truly randomized trial, and it has got non-inferiority margin of 5%. So it's a good trial.
Sir, practically how you going to assess the lesion preparation and the outcome? If you need to do the angiography outcome, like TME3 grade flow or TME2 grade flow, or just
Angioli, TME3 flow, less than 30% residual stenosis, bad dissection, non-flow limiting.
Because dissections angiographically is totally.
You have to produce dissection. Dissection means good result, but should not be so good that your vessel is knocked off.
Up to type B dissection is accepted, even early type C is accepted, but after type C it is not possible to accept those. We are running late. Thank you so much, Samsad. Your case was great. We have next session coming up.
By this case, we end this session, and then we move on to the clinical cardiology session. We have two prominent speakers for that session, and it is a well-curated session. It will, for the first talk is to be delivered by Dr. Rajan Narayan sir. The moderator for this session is Dr. Ajay Kumar Sinha. If he is here, he can join. Chairpersons, Dr. S.S. Chatterjee sir, Dr. Rajiv Agrawal sir, Dr. Ajay Kumar Sinha sir, Professor of Medicine from NMCH. Panelists, we will be having Dr. Mrityunjay Kumar Singh, Dr. Neeraj Bharti, Dr. Anshuman Kumar, and Dr. Amit Jaiswal.
So
over to Ajay sir.
Yeah. So thank you, Samsad. So good afternoon, everybody. So we are going to have this clinical cardiology program, which will basically orient towards prevention and cardiometabolic issues and lipids. And we have two eminent speakers who will throw light on these issues. And we have three chairpersons and three panelists. So I hand over mic to Dr. Chatterjee, our senior colleague and ex-director of Indira Gandhi Institute of Cardiology.
Yeah. First on the list is the cardiometabolic disease in 21st century, an unfinished agenda, the tsunami ahead. Now, we had we had the metabolic syndrome for last 2 decades, we know. But for last in 2023, the AHA advisory committee recommended the name of, recommended a new entity as cardiometabolic kidney syndrome, CKM syndrome. And then in 2024, they have now come out with the gradations from grade 0 to 4. And on this topic, we have Dr. Ajay Narayan and Dr. Rajan Narayan, who is a son of the soil. He is son of Dr. Mahendra Narayan, late Dr. Mahendra Narayan, who had been a great physician over here, and we had been his students. So it's a great pleasure to invite Dr. Rajan Narayan to speak on this topic.
He's organizing his slides, so let me give some review about Dr. Rajanarayan. He's for the last 21 years he's in UK. He's chairman Global Health Alliance. He works for St. George's. He's a member of European Society of Preventive Cardiology, and he is in the ESC guidelines for sudden cardiac death. So he has been coming to Patna frequently, and we have heard him a lot in past. So over to him.
So let's see.
Hello. Dr. Rajay is son of the soil, and though he stays in UK, his heart always remains in Bihar. So, you know, you can wake him up at 2 o'clock in the morning if you have a problem, and he'll be there to help you. You know, whatever he has done for Bihar will need pages to describe for, you know, training programs, all these things. So it is always a great pleasure for all of us to have him here, and his father was a very eminent physician of this town. He has passed from PMCH, so he feels that he owes a lot to Bihar, and he always trying to repay it, and it's a great thing for all of us. Thank you, Dr. Rajay.
Thank you so much. Just trying to get my slides working. So good afternoon, everyone. Thank you so much, Dr. Chatterjee, Dr. Sinha, and Dr. Pramod for the kind introduction. As you all know that I'm originally from Bihar. My father was a professor of medicine here. Bihar is my hometown, but Medanta is my second home in Bihar. So I'm very emotionally attached to everybody in Medanta. I may not know names of everybody, all the juniors, but I'm emotionally attached to all of you. I have known Dr. Ravi Singh for possibly over 2 decades for various things that we have done together in the past. So thank you so much for having me at this conference. It is very, very close to my heart. So I'm going to talk about the cardiometabolic challenges in the 21st century, because it was my privilege to set up UK's first cardiometabolic clinic in the NHS, because we know majority of the deaths. And this is a very interesting chart. This is the global burden disease, which talks about the top 5, 10, 20 causes of death globally. And if you look at the causes of death here, you will see that if you look at heart disease is going to be the #1 killer. But most interestingly, the next 20 years, heart, kidney, diabetes are going to be the top 5, 10 killers globally. So cardio, renal, metabolic that we were just mentioning are going to be the top 5, 10 causes of death globally. In fact, 74% of deaths globally are because of non-communicable diseases. And this is the latest global burden disease report that came out from Salim Yusuf, because the data sits with Salim Yusuf in Canada. He's got the maximum number of database from almost like 198 countries. And if you look at the numbers, diabetes, lipid problems, heart disease, heart failure, This is very interesting because only recently at the European Society of Cardiology meeting, Salim Yusuf presented a paper suggesting that the overall prevalence of heart failure globally is more than 60 million. Till recently, most of the papers suggested it was about 27, 28, 29 million, but the numbers were double that number. The number of, obviously, CKD is going up because we know that if you have more diabetes, you're likely to get more kidney disease. The UK population, almost 10 to 12% of UK's population has got chronic kidney disease. So again, that is why we thought that we should bring a holistic approach to manage all these cardio, renal, metabolic patients together. And that is how we set up this first cardiometabolic clinic in the NHS. But this is more scary. This is the report from the WHO, which suggests that almost 70% of the targets in non-communicable disease that we are talking about, heart, kidney, diabetes, obesity, cancer, are likely to be missed in the next 10 years because we are not screening enough. We are not optimizing their medication enough. You will be surprised to know that we keep talking about good medical therapy, 4 pillars for heart failure, but only 28% patients of heart failure get 4 pillars in the UK. In the US is even worse. 21% of heart failure patients only get 4 pillars in heart failure. But obviously, we don't have the national data for India, so I can't comment on India. It is what's happening. But what is important is that we have to holistically manage these patients. Coming back to heart disease, I'm sure all of you are aware of this data. But more importantly, almost 1/5 of CVD is happening in India. Looking at this number, this is very exciting, very important. We were supposed to hit 800 million diabetic patients in 2050. The WHO has just published its latest paper suggesting that we have already hit 823 million. That's the data from yesterday. 823 million patients are there with diabetes. So the numbers are going left, right, and center, and that's why it is extremely, extremely important to address these issues. If you look at the number of patients with diabetes in India, 68% increase in the last 3 decades. So again, massive numbers, almost 100 million plus patients are there with. We all know that India is now considered as the diabetes capital of the world. So again, coming back to CKD, 700 plus million, 100 million plus are based in India. So again, as we know that the number of diabetic patients are going up, so CKD is also likely to go up accordingly. But this is not just India. If you look at the South Asian population, the overall CKM, the CRM, all those numbers are going up. We have seen double, triple number compared to white people, compared to Europeans, compared to US. So South Asians, as we know, are more prone to cardiorenal metabolic issues, and this is what we have seen. And this paper just shows that why it is important to take this holistically and discuss all of this together. Because the moment you have metabolic condition, there is hyperglycemia, there is insulin resistance, there is sympathetic nervous system activation. That leads to myocardial infarction, LVH, hypertrophy, heart failure with preserved ejection fraction. In fact, the latest paper now suggests that heart failure is the first complication that happens in diabetes. When I was a medical student, we knew that if you have got diabetes, you're likely to develop coronary artery disease. But heart failure is the first complication that happens in diabetics, and that is globally. So again, this is very, very important because we need to holistically manage these patients. We are seeing a surge of patients with chronic kidney disease in the UK. As I said, the UK's population is about 77 million. Almost 8 million patients have got some degree of chronic kidney disease. That's about 10% of the population. So this is again very, very important. Obesity, the Prime Minister of India has also started talking about obesity because again we have seen a big number of patients coming with obesity in India also. The numbers have grown up 2.3 billion and counting. So number of patients with obesity is also rising. Not only that, if you are morbidly obese, there is 15 times more chance of developing all of these complications in morbidly obese patients. So again, CVD, hypertension, type 2 diabetes, these are all likely to increase if you have got obesity on top of other problems. We are learning a lot about this, NASH, MASH, MASLD, because we are seeing lots of inflammatory changes in liver associated with metabolic syndromes. And not only that, the latest paper published in JACC suggests that the risk of CVD, type 2 diabetes, CKD, it all goes up in patients with MASH. So again, all these problems have to be holistically managed and have to be addressed in the best possible way. This is again something that we are seeing more and more because we cater to southwest of London. We have got huge number of South Asian population, and I'm sure you all know more about this than me. that this is the typical lipid profile that we see in Indians and South Asians. Low HDL, borderline LDL high, and very high triglyceride. This is exactly what we see in majority of, the moment you do a lipid profile patient, you can predict what their lipid profile is going to be. But this is something that we have known already. All of us know that LDL is the main culprit for blocking all your arteries and causing coronary artery disease. This paper again published in JACC showed that having borderline LDL with high triglyceride can increase the risk of coronary artery disease, stroke, peripheral arterial disease by up to 30-40%. So high triglyceride on its own with little rise in the LDL has a synergistic impact on causing cardiovascular event long terms. So this is very, very important for understanding. Not only that, lots of new papers have been published suggesting that non-HDLC again plays a very, very important strong causal risk factor for coronary artery disease. Again, in the last 4 or 5 years, people who have attended the ACC or ESC meeting, they will know that every counter is there now to check your LPA, because LPA is equally important. It's an independent risk factor for coronary artery disease. You should definitely get it checked once in your lifetime. And again, it is extremely, again, more important in secondary risk people. So again, people who have already had a cardiovascular event, they also need to have their LPA checked at least once. So that was again all traditional risk factors. To top it up, we have already got lots of other issues, especially in developing countries, whether it be pollution, nanoplastics, sedentary lifestyle, and social determinants of health. Because again, even in countries like London, in UK, if you are living in North London, the chance of getting 4 pillars in North London is about 30%. But if you're living in South London, the chance is about 70%. So again, social determinant plays a very, very important role. And all of these are on top of the traditional risk factors that we have been discussing. There are other emerging risk factors that we have learned about. Inflammation is one of those important ones. There are a lot of evidence now, a lot of paper now being published that inflammation plays a very important role in type 2 diabetes, cardiovascular event, CKD, because all of these play a very, very important role. Antimicrobial resistance. No one knew, I never knew till recently, that antimicrobial resistance can be a risk factor for cardiovascular disease. There is now evidence in paper published that it leads to chronic inflammation changes that leads to blockages in our heart arteries, CV events. So again, all of these are 21st century challenges that we are facing. Air pollution. Everyone was talking about pollution in Delhi recently, that we have seen that there was increase in the AQI index 400. I have had very bad throat since I have landed in Delhi, because I came from a AQI of 35 to 400 in Delhi. So I'm sure Prof is also struggling a bit. Prof Nolan, who's come with me from UK. But as I said, that this is very, very important. PM 2.5 is now responsible for CVD, type 2 diabetes, CKD risk, about 10 to 15% increased risk of PM2 in these conditions. We are just hosting the global summit, the GHA One World Summit recently, speaking to 2 of the very important people in the non-communicable disease space. Dr. Maria Neira, who is the director for WHO, and she was saying that pollution is extremely important. She is fighting a battle with several countries around the world to control pollution, because there is evidence now of, as I said, with pollution, inflammation leading to cardiovascular event. Randeep Guleria, who is the head of respiratory medicine, he says that more people have died from air pollution related deaths than COVID in the last few years. So that again just shows that pollution is an additional risk factor on top of what we carry on as a South Asian, which again needs to be addressed very, very importantly. So what needs to be done? This is one of the solutions, because we know that if you have a cardiometabolic link, that what we set up, you can manage these patients holistically. Blood pressure, diabetes, cholesterol, lipid, obesity. We have a holistic approach. We try and manage everything in one clinic. We have 3 consultants looking after 1 patient. I know the NHS works completely different to the way things work here in the Indian subcontinent. But again, this was something that we started doing there. This is something that we started in September 2020 in the middle of the pandemic. And these are some of the numbers that have come out in the last few years, that we managed to take off almost 10 patients from the bariatric surgery list, because we started them on GLP-1, SGLT2. We managed to bring patients' weight down, HbA1c down. And obviously, there were some numbers to keep our managers happy as to how we can manage these patients. So long term, these are some very, very important evidence data. This is the pure study talking about how important diet is. We never talk to our patients about diet. So healthy diet, yoga, nuts, walking, All these are equally important when you're talking to a patient for cardiovascular risk prevention. Not only that, the European Society of Cardiology now says that 150 minutes of moderate intensity exercise per week is mandatory to prevent long-term cardiovascular events. This is very, very good. This is a network meta-analysis, because we keep saying about 10,000 steps, but about 20 papers on 10,000 steps showed that there is only evidence up to 7,000 steps. Beyond 7,000 up to 10,000, there is a plateau, as you can see. So again, 7,000 is the new 10,000. 7,000 is a must that everyone should carry on with. Between 7 and 10, we are not sure what happens, but again, you do lose some calorie, do lose some weight. Intermittent fasting, I'm sure we were talking when we are coming from with Prof. Nolan that what do we do about intermittent fasting. Evidence again is with 14 to 16 hours. Beyond 16 hours, there are some small papers to suggest there is a problem with cardiovascular problems after beyond 16 hours. But this is very important. The whole world, whole of Europe and the US is focusing on this tribe in South America. This is the Jimane tribe, 16,000 people living in a tribe. They were never been out of their island. They took about 200 people from in their age of 70s and 80s and did a coronary CT scan in their 70s and 80s. None of them had any coronary calcium plaque. None of them. And the reason was they walk for 4 to 5 hours a day. They have plant fiber rich diet, and that is the reason for their longer lifespan. Majority of them, they live beyond 90 years. So definitely lifestyle, diet, exercise, they all play a very, very important role. Again, alcohol is very important. I'm sure it's not for Bihar, but most of the papers have now showed there is no evidence. No red wine does any good to your heart. So any amount of alcohol is not good for your heart. The ESC now says that keep it below 2 units per day, which is very important to keep your heart going. 7 to 9 hours of sleep is important. Lowest risk was seen in patients with 7 to 8 hours of sleep. And this is my very important slide. Again, a paper published recently. At age of 50, if you don't have diabetes, no obesity, if you don't smoke, no lipid problems and no hypertension, at 50, you are likely to live 10 years more. So that's what we all have to aim for. Thank you so much. I'll stop here and then I'm happy to take any questions.
So thank you very much. Wonderful talk. I'll take quick comments from our diabetologist, Ansuman, and then Mrityunjay. Just one comment each.
So these cardiovascular metabolic diseases, all of them have some of the common pathophysiological features in common, like just you mentioned insulin resistance, systemic inflammation, endothelial dysfunction, neurohormonal dysregulation, and oxidative stress. So previously what we used to do, we used to tackle each of these diseases individually, give drugs to lower blood glucose, give drugs to control blood pressure. Now we are going for holistic management. We are targeting the main pathophysiologic feature behind all of these diseases, mainly obesity. We have a holistic approach that a cardiologist, endocrinologist, nephrologist, a nutritionist, a mental health specialist is seeing our patients. We have such drugs which tackle the burden of overweight, like SGLT2 inhibitors and GLP-1 receptor analogs. And so I think the way forward, newer drugs are coming, not only GLP-1 receptor analogs, but dual receptor analogs, triple receptor analogs. In the days to come, the area we will be having too much of drugs on our hands to serve our patients better.
I have got one comment. We had metabolic syndrome, which included most of these factors that you enumerated. Then why did this cardiometabolic kidney syndrome has been propagated by American Heart Association? This is probably because 2 new drugs have come, which addresses both the obesity as well as diabetes, as well as CVD, as well as probably CKD, the GLP-1 agonist and the SGLT2 inhibitors. So that may be the reason why the American Heart Association has shifted from this metabolic syndrome to cardiometabolic kidney syndrome. But I have got one more thing to say. The one most important thing which I personally, that inflammation and obesity is the basic factor which causes insulin resistance and then everything. And the hypertension and diabetes are well known to cause kidney disease for last decades we know about that. So why the CKM syndrome has been, is being propagated by AHA nowadays?
So that's a very good question, and the answer is that, since Salim Yusuf presented his paper at the ESC 2 years ago, he was trying to collect the data for the last 10 years. Many of the countries were not helping him out. But suddenly, post-pandemic, most of the countries started giving data to Salim Yusuf for the global burden disease. And that's how he came up with these numbers, that top 5 causes of death globally will be cardio, renal, metabolic. And that's why ACC, ESD, they have now prioritized this as an important thing. So thank you very much, everyone.
Yeah, so as you see, like this cardiometabolic syndrome has increased in last 20-30 years. I mean, it has gone linearly, like as the age improved. Like it says in one of the study, like when the age is like in between 20 to 30, the chances of having cardiometabolic risk is almost 7 to 10%. But once we reach at the age of 40 to 50 years, it linearly goes to almost 40 years. So the primary aim is to be primary prophylaxis of the metabolic syndrome. I mean, it should be targeted at the for primary prevention rather than like treatment. Yeah, thank you.
Is there a difference between male and female? Like a lot of studies are coming up which say that females are different phenotypes.
So again, there is more understanding of perimenopausal syndromes, because again, perimenopausal was something that we did not know 5-10 years ago.
No, even pregnancy, during pregnancy and all, they are at
there is some information kind of situation that happens, but again, in women, menopausal is the time that the number of cardiovascular event, thyroid, lipid, hypertension all kicks in suddenly because of the hormonal imbalance.
So thank you very much.
Thank you.
And now next would be Dr. Susil is presenting 3 cases, index cases, which will be discussed with Dr. Yeah. So that way, please.
Thank you, Medanta Patna.
While he's getting it, just a few lines about Rajiv, a very dear friend. We are more like a family now. We have been together for almost 40 years, and he's a hardcore clinical cardiologist par excellence. That's all I can tell.
I'll say to begin with, I am a half interventionist because I don't do that all kind of artistry which I am seeing since morning. And ladies and gentlemen, let me say what I am going to talk will be relevant to you, and none of you will like that what you have all seen should be practiced on your family members, on you. So you have to keep this away, whatever you have seen. I have traveled 2200 kilometers from Meerut to Patna, and he's so miser, he has given me 1 minute for 200 kilometers. And I largely feel that lipidology is for intervention cardiologist, is not meant for clinical cardiologist. And why I so, because you see the highest possible risk patient who have expressed the most difficult, dangerous form of the disease, and they yield the best returns. If you do primary prevention in lipidology, you get very little return. But if you do in intervention cardiology, you get returns and returns manifold. In my obsession to lipidology, sometimes I feel if a patient is coming back in 4 and 5 years following your intervention, you should feel ashamed of it, that why he's coming to us. This is a missed opportunity if it is not being taken care of by intervention cardiologist. All of us know that event rate is very, very high in first month. Although this figure is changing, we don't see that kind of recurrence now in first month because of exceptional medical therapy. Whatever you do mechanically is not a management of atherosclerosis, it's a management of sequelae.
The only thing which you do to modify the disease is lipidology and atherosclerosis. Rest of them are like cough suppressant and antipyretics in tuberculosis. They are not modifying the disease. So lipidology is atherosclerosis. This is US data, of course, a couple of years back, and you find that in US, 48% patient never had lipid profile following PCI. This is Jack. And roughly about 50% patient had LDL less than 70. US is very liberal. Still they follow LDL of 70. So 50% of the patients, they never had LDL less than 70. The same scene is here. We have very high percentage which is untreated, unmet needs. This is carry home. Unlike HbA1c, LDL is more homogeneous. Whatever you do, whichever way you do, what matters is the level of LDL. Like, let me summarize, if you reduce LDL by PCSK9 or inclisiran, qualitatively it is not superior to if you reduce it by metabolic surgery or by a triple combo orally. So qualitatively LDL doesn't make a difference how you reduce it. So don't get obsessed that I'm using inclisiran or PCSK9, I'm doing a big job. The big job is the number, not how you do it. We have to rethink the starting line. This is all recent data, 24, 24, 25. I don't have time to go into details, but in acute coronary syndrome, lower you are, better you are. This is a paper done by one of my colleagues, Dr. Akshay Pradhan. This is a summary of all the trials. These are injectable 5 trials, and this is our trial. I was part of it, LIREACT, where only triple combo was used. These are all PCSK9. 2 trials were imaging-based trials. We were awarded the Best Paper Award in Paul Dudley White in American Heart Association because it was the first presentation in AHA on triple combination. Our lipid association numbers are 50, the Europeans are 55, and Americans continue to be at 70. And we could get LDL less than 15, 44% of patients if we use triple combination. This is just a summary of all that. So we will be talking about little bit about what is imaging studies have shown us. If you do aggressive lipid lowering, don't get connected to the way you do it. Don't think this is a PCSK9 data, this is inclisiran data. Just remember the numbers. This is our publication, and we talk about strike early, strike strong. And this is Lipid Association of India. We talk about 50 in a special situation. If you have polyvascular disease, diabetic, recurrence of event, we call it extreme risk group category B. Then the recommended goal is 13. If you have recurrence despite using GLP and the EPA and everything on board, and patient is having recurrence, the recommendation, what we say extreme risk group category C, is 10 to 15 of LDL in acute coronary syndrome. Our guidelines continue to be the lowest and the first in the world. So we are ahead by at least 5 years than rest of the world. Now we have been recognized internationally in different publications as we are referenced more frequently. So simple mnemonic, early bird catches the worm. You have to strike it on day 1. Most of the guidelines, if you look at the performance measure of STEMI, say that you have to be on lipid lowering therapy at the time of discharge. That is a performance measure. The difference is you have to load your patient like you give antiplatelet drugs. You have not to wait for day 1, day 2, day 3 or discharge. You have to make a habit in your department that every patient is loaded the way you load the antiplatelets. If you use triple combination, you are 5% better than PCSK9 as a solo therapy. So it's a very, very powerful therapy. Don't think it is an oral drug, it won't work. Victorian Initiation is a trial where they have used inclisiran as a step 1, bypassing the oral drugs. If you can afford it, fine. And LDL achieved is something around 45. So I am not agent specific. I am number specific. C-reactive protein, the most C-reactive protein reduction is 42% with semaglutide. Otherwise, the right side, there is the reduction in C-reactive proteins, but on the left side, there is no reduction in CRP. LPA, reduction on the left side, no reduction on the right side. Statins may increase LPA. Why combination therapy is important? Because we need a very powerful LDL reduction. Unfortunately, all the guidelines, they stop at MACE. You don't want tuberculosis patient not to cough, not to have hemoptysis, no fever, and don't want to kill tubercular bacilli. The story of regression starts when the guidelines stop. I do not know why they are silent. So guidelines stop at 55, where you just modify, pacify the atheroma. Regression starts after 50 and it goes up to 10. So I am yet surprised even today that why guidelines are not conscious of regression of atherosclerosis, why they stop at MACE. MACE is a very soft surrogate endpoint. And this is what is being shown, that up to submolar 10 milligram there is regression of atherosclerosis and reduction in events. This is Hygen, which showed that in acute coronary syndrome patient, the fibrous cap thickness goes up, lipid core is down, and plaque become more stable. Look at Pacman. They use aliricumab. Look at lipid core burden index. At 52 is just gone. And unlike Odyssey, this time the Pacman boys, the Pacman investigator was smarter. In Odyssey they stopped at 50, but in Pacman they went up to 23 the way Fourier and Glagov people did. So they didn't stop at 50 because they realized their trial design was defective. And you see plaque atheroma volume, lipid core burden index, fibrous cap thickness all go in a favorable direction. This is 1 month NIR spectroscopy that look at the lipid core, what happens at 1 month. So it is a very realistic visualized concept that there is an acute regression of lipid core burden index on a longer term basis, less than a year, you can have fibrous cap thickness. How low we can go? This is a paper by Dr. Amit Khera and Fatima, and they show that in Southeast Asian population, persistent LDL-C can be reduced up to 10. So don't get emotionally disturbed that 10 is too low, and you can bite a pound of atherosclerosis if you go aggressively, like Shakespeare said in Merchant of Venice, a pound of flesh. So you can have additional reduction in events in atherosclerosis. Ladies and gentlemen, when you start from acute coronary, Dr. Hajra, you can go, you are getting restless. So you can have, instead of plaque stabilization, we have to go plaque repression. And I say we should stop saying lipid lowering. Initially we started with statins, then lipid lowering, that plaque placification. I think we should rename this as plaque therapy so that emotionally we are connected with the plaque rather than LDL level. LDL is safe, visit to visit variability is less with inclisiran, and this is prevent. Many of you like it, but there are several problems with this, that both in treatment and control group LDL was 64. They were partially treated patient, and the prevent trial was positive, because as an investigator I'll feel why their LDL was not treated, and we have a Chinese rebuttal on this, that there was a room for improvement of treatment in atherosclerotic plaque. So what I personally feel, a prevent trial should have been done in a different way, where with current understanding the LDL should have been reduced more. Aspirin for secondary prevention. Now there is an emerging concept that after 30 months, you don't need aspirin. And why? Because lipid lowering is modifying plaques enormously. And you don't have that kind of plaque ruptures that aspirin can help. And there is a far-fetched idea that aspirin should be given after acute coronary events like antibiotics. And it is pill in pocket, like pill in pocket. You see, when you have AF, there is a Passman has postulated that you give anticoagulant for 3 months, wait for recurrence, and then you restart. So there is a rationale for thinking that way. And lipid modification, aggressive lipid modification is the way forward. Antiplatelets are management of sequelae, not modifying the basic disease. The drug therapy has to be simultaneous, not sequential. And this is my very favorite diagram, that ACS, when you treat, what you do? You make ACS CCS. That is what you do. But many of us forget there is an exit route of eliminating atherosclerosis. So we are in the world of ACS CCS, ACS CCS. We don't get an exit route because we don't know that route. And probably I feel you need the least of IQ practicing lipidology. 3 drugs, simple drugs, cheap drugs, you can give in $1 to all the patient. And this is Patrick Sarai's. The future is pharmacological revascularization in 2040. It is not mechanical. Atherosclerosis is a metabolic disease. It is not mechanical disease. It requires lifelong treatment. And I'll end up that Michael Jordan said, my best skill is I am coachable. So ladies and gentlemen, I provoke you to change and be a sponge-like. Practice it. Make it a habit in your department. Give all 3 drugs in the morning in every ACS patient. See what happens. It's the simplest intervention you can do, and the patient will be benefited. Thank you very much.
Excellent talk, I'd say. It's worth spending another 15 minutes with you. So I'm really surprised you have not mentioned anything about Vesalius trial, recent trial on primary prevention. And until unless you lower the target of LDL lowering, which is 45 in Vesalius just presented recently, you cannot bring it down to 10 in secondary. So perception of prevention starts in the primary, having a more lower, to the range of below 55, range of LDL lowering in primary prevention. So you understand that secondary from your lecture.
Dr.
So what is your take in patients who are not having any disease?
My talk was ACS, so it was secondary prevention. But let me tell you one thing. We had Jupiter, where the LDL was 130. And, and the LDL achieved in Jupiter was 50. I often used to say at that point of time, when LDL was 70 as a goal, that if in primary prevention you can bring it down to 50, why not in secondary? People used to laugh. So I fully agree with you. Braunwald in Universal Health Primordial Prevention has predicted a population LDL of 70. Population LDL of 70 in primordial prevention. So lower you go, better it is. I say at least do in secondary in cath labs. Because these are the highest risk patients who have expressed disease. You are the guy who will do magic. In primary prevention, yield is less. At least practice in secondary prevention. I agree with you. I endorse you.
Sir, one question. The non-HDL has emerged as a co-primary target. So we have a lot of options for LDL cholesterol reduction. But the reducing non-HDL is a big challenge.
I'll answer you once we have the cases. I have those slides. I'll tell you. Your question is valid. Let me confess another secret. I asked him to show me the cases so that I look smarter in answering them. He didn't do that. So I am blinded to all the questions. My response will be very spontaneous, as if I am sitting in the clinic. I should enjoy it.
Okay, now we would like to invite Dr. Sushil Kumar for his case presentations, case scenarios.
Okay. Good afternoon, sir. My first case is Mr. A, age is 42 years, and his BMI is 26. He has hypertension. He presented with an STMI, and we did one single vessel angioplasty in RCA. You may see the first slide of there is a minor plaque in circ, while in second you may see the second video. First one. Yes, there is a minor plaque in circ, while we did few days in proximal RCA. We did angioplasty of single vessel stenting of proximal to mid RCA with some plaque persistent in distal RCA. The post PTCA, my patient is on 40 mg atorvastatin and 10 mg estimab, and his LDL is currently 108 mg per deciliter.
So we can stop here, and we'll request the panelists, the chairpersons, and Rajiv to tell us what do we do now. How many months or days after the
6 weeks. 6 weeks, sir. Yes, sir.
6 weeks LDL. So LAI doesn't agree with it.
LAI recommends 2 weeks, and we have enough data that 95 to 99% of LDL reduction is possible in 2 weeks. Don't waste time for 8 to 12 weeks, as ESC says. So first thing I'll do, I check LDL very fast.
Okay.
2 weeks is LAI recommendation. The rest of the word says 8 to 12 weeks. Yeah.
Okay. Then we.
How frequently you do lipid?
After 6 weeks. After 6 weeks.
So the Lipid Association of India is
2 weeks.
very aggressive. And let me tell you another thing, that we do not have a, let's say, an RCT to say that, because we do not have any clinical endpoint seen in those trials. But the trial which Rajiv was quoting, they have measured it at 2 weeks, 4 weeks, like that.
Yes.
And they could see that if you use a very strong combination, you can bring it down rapidly. And it's a very highly inflammatory condition. And so if you can bring it down as early as possible, the benefits will be higher.
So I have a query and question.
Yeah.
Firstly, compliment, very good talk. But see, large number of patients, behind you is Dr. Ranjan, who is a radiologist, and he does nth number of CT coronary angio. See plaque, 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 plaque and plaque. LDL, LDL, how much is the LDL? 70, 80. So this is a big problem. There are non-LDL factors. Whatever may be the guidelines, doesn't matter. But what do you do about LDL, non-LDL factors? One. What do you do to the inflammation? Number two. And yet after that, you see atherosclerosis progressing. So these are my, queries to you.
When you have plaque and whatever is the LDL, you have expressed disease. So now he is not a normal epidemiological data that 100 is normal and he is 80. Unfortunately, in lipidology, the only evidence is based related to LDL, which is not yet complete. Like if you have non-HDL high, what to do? You don't have any drug. You know it is a risk. But the only thing you come back that reduce LDL further. You have high LPA. You don't have data that treating LPA works. So what you do? Come back to LDL, reduces further. If it is FitFi, you make it 10. And this is the end you can do. So it may not abolish the risk, but yet this is an opportunity which you should use. Regarding inflammation, CRP is one which is not a very good marker, but still, and colchicine is coming in a big way, that 0.5 milligram OD can be used. Other drugs are not possible. As I showed you, semaglutide does CRP reduction by 42%. So that is something you can utilize if your patient is obese. So additional therapies come, like the way you treat diabetes with SGLT and GLP-1 receptor analog, that will be additional anti-atherosclerotic measures. And this all is not sufficient.
You mean to say that if we have drugs which can increase HDL or which can increase, decrease LPA, the role of the LDL will go down in future?
This is a hypothetical question because there is no such thing in the pipeline also. So let us stop it because there is no point when there is nothing around. This is a philosophical question we cannot answer on the data.
Just a question to sir. In real practice, how often you get LDL like 10 or 20? And with how many drugs at what dose?
Many of our patients are hyper responders. You give them drug, they get down to 10. At least I will say 75 to 80% of your patient will come down to less than 50 if you use triple combination. 25 to 30% will have in 20s and 10s. Another trick, if your patient is on triple combo or on any drug, suppose he is a hyper responder, gets down to 10. Don't get upset. Don't reduce the drug until unless there is a side effect, because he is a lucky guy who is responding more, and tell him that I have done it, because there will be another person who will say aapki dawa zyada likh di gayi hai. The chemist may say. So I often tell my patient, I am expert on this, I have done it deliberately, I am taking note of it, don't reduce it. So if your patient who is not having any complication comes down to extra low values, feel happy about it, make him happy about it, give him a note that you are a lucky guy.
So, our lab will not give you a value less than 20, like 10.8, that is Medanta lab. So they will just send you a report that it is less than 20. And I am very happy with that. You put a patient, two of our patients are in inclisiran, both of them have LDL less than 20 and they have maintained it. That is one of the, another concept, that the more you are in the safe zone as far as LDL concerned, the risk of atherosclerosis gets down. If you have an LDL of 100 one day, comes to 20 the other day, and third day it goes back to 200, and you're not safe.
Like CGM, like blood pressure, ambulatory blood pressure, longer you are maintained in therapeutic range, better you are. The concept is same way applicable to lipidology also. Lipid variability is a bad sign, and since inclisiran is long acting, you are likely to have less variability, like you have longer acting drugs.
Okay.
Consider lipoprotein A and HSCRP measurement in each and every patient, and do you stratify the patients based on these measurements, and then you consider LDL lowering to further lower points?
HSCRP I don't do at baseline, I do it at 2 weeks, because all these drugs can also reduce HSCRP. So I see what is my status of HSCRP at 2 weeks. If it is high, I bring in colchicine. LPA, you have to understand, LPA is a risk marker, is not a risk factor. A marker means if you have high LPA, you are likely to have bad prognosis, but we don't have outcome data. There are drugs which can reduce LPA, 80%, 90%, but there is no outcome data. So right now what we know, like triglycerides, they are risk markers. They are not risk factors, because we don't have drugs to reduce triglyceride which result in outcome benefit. There are drugs to reduce triglycerides, but the outcome is not there. So that is the problem with triglyceride and LPA, and that is why we know if your patient is having high non-HDL, high TG, high LPA, he is higher risk, but we don't have treatment for that. We may go for additional thing, weight reduction, GLP, SGLT2 inhibitor. Maybe he's a COMPASS patient, we bring in rivaroxaban, but not to treat LPA.
We,
at the moment.
we do use eicopentazoic acid, Vascepa, for high triglycerides.
EPA, yes, yes.
In the UK, which has got MACE data and
Yes.
cardiovascular outcomes.
Yeah.
In secondary prevention.
No, we have EPA. We have
So for high triglycerides, we have started using, although
Aris
the
makes it.
guidance from ESC and NICE at the moment is for secondary prevention, not in primary prevention. But we have started using in some of those cases with the triglycerides are very high.
And less than 500. If you are more than 500, then you go on fenofibrate. All these drugs are showing benefit in reducing the surrogate markers, but we don't have an outcome data. So you are treating something like triglyceride lowering. You reduce triglyceride with fenofibrate or pemafibrate, but there is no benefit. So it's just a cosmetic correction of triglyceride, not an outcome data. So we don't use the word drug for treatment. But I hope I'm clear.
But there is a possibility of at least half a dozen small iRNAs coming out there in phase 2, phase 3 trials. So the next 6 months, we'll have at least 4 or 5 drugs for LPA, for non-HDL, which will address all these problems, at least. For LPA, non-HDL, there's no direct. We have to address all the other issues.
Now, do you have outcome data for less than 20 LDL?
Up to 10.
Up to 10.
Up to 10.
Most of these trials, if you take the Jupiter trial or the inclisiran trials, where almost 30-40% of the patients had LDL less than 30.
So
That's a composite group having different.
no, there is an outcome.
Only who have 20
These
or
are
20.
not actually clinical outcome data on inclisiran.
I'll answer you. Up to in 4 year, you have data up to 10. There is incremental benefit. There is no data on single digit like 6 LDL, 7 LDL. We don't have. Up to 10 in 4 year, there is a linear reduction in events and plaque regression. So we have data up to 10, but this is subgroup analysis. There is no trial where 10 is compared blindly to 50. But subgroup analysis in 4 year is there. You have to watch for myalgia because you will go on 40 milligram of rosuvastatin, and ezetimibe is a very safe drug. Bempedoic acid, yes. Uric acid and muscle ruptures. But if you combine SGLT2 inhibitors and bempedoic acid, which many of patients are there, then uric acid problem is taken care of.
Okay. My second case is Mrs. B, for 49-year-old female, is high hypertension and type 2 diabetes mellitus. She has undergone 2 PCI in last 2 years. In last year March, we did PTCA for SERC. You may see the with good result, but in RCA there is some plaque around 40% proximal and mid. After approx 18 months, she again came with chest pain with unstable angina. We may see proximal approx 90% stenosis with good left. We did PTCA with a long stent, 48 millimeter long stent in proximal to mid RCA. The post PTCA she is on 40 mg Rojuva and 10 mg Estimib and also 180 mg bempedoic acid, and her LDL is 60 mg per deciliter after 6-week follow-up of second event.
She deserves a better way of treating diabetes, that compulsively she has to be on SGLT2 and GLP-1, because we need to treat it diabetes from atherosclerotic point of view rather than HbA1c point of view. And I'll use inclisiran in this. I have to bring down LDL to 10, 12, 15, because this patient is having recurrence of events. And maybe after this event, after a year or so, I'll put this patient in COMPASS. That means SAPT and rivaroxaban 2.5. She is a very high vascular risk patient. Another trick is that some of the industry in India has given a combination of rosuvastatin and bempedoic acid. Never use that combination because both the drugs work on the same axis. So agitamib has to compulsively come after statins. Then bempedoic acid. Like you cannot combine PCSK9 and inclisiran. Yes. They work on the same axis. Inclisiran works more proximally. Gene deletion works more proximally. So similarly, never commit an error of combining rosuvastatin and bempedoic acid. So my answer is, she deserves more aggressive LDL reduction. Inclisiran is on board. And after 1 year, I'll bring in COMPASS on board. And HbA1c is to be better, different treated with GLP-1 and SGLT2. That is the best we can do for her.
Thank you, sir. My next case is Mr. C, who is a 52-year-old male. Mr. C is a teacher and leads active lifestyle. He has hypertension and obesity with BMI 32. We did PTCA for same patient with in both vessel. You may see in angio. In left side, OM2 have 50 to 60 ostial lesion. In left side, LAD has very diffuse mid to distal disease. And in RCA, distal totally cut off. We did PTCA in both vessel, RCA and LAD. In left, you may see LAD, there is very long stent, 48 size millimeter. And there is some residual plaque in OM. After 6 weeks of follow-up, LDL level is 120 mg per deciliter. He is on 40 mg Rojuva and 10 mg Estimib.
So he is a very high-risk vascular patient. Vascular risk patient, you not only see the host factors, there is a concept of total plaque burden. So you see disease all over. If you do CTCA for this patient, he is loaded with atheroma. So this patient need to touch to 10, 15 kind of thing, and that is what you should do as long as possible, and that is the best we can do. It may not eliminate atherosclerosis, but that is the best we can do. So never miss a vascular risk based on coronary angiogram. You may have single vessel disease, but diffuse non-obstructive atheromas. So you have to touch down. And I'll tell you another thing. I am in a private sector. We do culprit vessel angioplasty and ask the patient, we'll do it again. Not more than 10% patient, they are willing for repeat procedure after a couple of weeks. And I'll say, I am a very aggressive lipidologist. None of them, large number of them, they never need anything, which is not evidence-based data I am talking, because everybody talks about complete revascularization. But I'll say those patients who do not want a repeat revascularization, culprit artery vascularization, I personally feel I'm open for criticism. You have taken note of culprit vessel, and then rest of the blocks you treat as CCS, they do extremely well. It is not a choice of treatment, but definitely those who are not affording, they do very well on very aggressive lipid modification. Once again, this is not a guideline position.
My question is that in caseous patient, the baseline LDL cholesterol is 180. You cannot expect to bring it down to less than 55, 40 with triple drug combination like Dojolone 40, anticoagulant 180. Should we use inclisiran day one during index hospitalization?
100%. You know that your triple combo is going to reduce 65%. If your LDL is anything more than 150, you have to use one of these molecules, and smart doctors like you will use it on day one.
So why this patient was not used?
That is his problem. That is his problem.
80,000 rupees.
The problem is concept. concept is valid. Yes, patients have to be motivated. That it will be recurring.
Because that is happening in installments. But if you ask them to cough out 80,000 rupees, very difficult.
And except for
We are trying our level best to push it, especially in such patients, where high vascular risk is there. But very difficult to convince.
And I'll tell you, in my area, people see me like a fool. Is there an injection costing 80,000 rupees? In oncology, they understand the cycle cost. But in day-to-day life, even talking about tenecteplase costing 20,000 rupees, they see in shock. And 80,000 rupees of injection, they say there is some garbage.
Thank you, Dr. Rajiv and Dr. And
Thank you, sir.
Dr. Arvind, for a very interactive session. We are already late. We are closing the session. And thank you.
Thank you, everyone. We are moving to the next session, which is focused on radiation safety. Every interventional cardiologist, on an average, goes through a cath lab career of 25 to 30 years. Every radiologist goes through a radiation-associated career of 25 to 3 years. So for this, on the topic of radiation safety, essentials for a long cath lab career, we have Professor James Nolan. He is a authority for academic knowledge for radiation safety. So I invite Dr. James Nolan. And for this session, I will invite our moderator, Dr. Arvind Kumar, sir. If he is here, kindly join us. Our chairpersons will be Dr. Rajiv Ranjan Prasad, sir, who is the head of radiotherapy department in Medanta. Dr. Ranjan Kumar, who is the head of radiology department, Medanta, Patna. As a panelist, we will be having Dr. Mani Shankar Pandey, Dr. Nitish Kumar, if he is available.
Rajiv,
Dr. Avinash, if he is available.
Let me do.
Dr. Niranjan Kumar, he has come all over from Nepal. He can join us. Dr. Deepa Shri, she is here. Dr. Poppy Wala, she is our electrophysiologist. Every electrophysiological procedure, it requires 1 to 5, 6 hours of radiation exposure. So she needs to be here.
Yeah, let me introduce Professor Dr. Nolan. Professor Dr. James Nolan is a leading figure in UK cardiology, serving as Professor of Interventional Cardiology at Keele University and a consultant at University Hospital at North Midlands NHS Trust. He is one of the UK's foremost expert in intervention cardiology, combining a busy clinical practice with an active research program. Professor Nolan is particularly renowned for his work promoting the use of transradial access for coronary intervention, a technique he helped stimulate major changes in the UK practice, leading to a significant patient's benefits. With this short introduction, may I invite Professor Nolan to please deliver your prestigious lecture.
Okay, thank you. So radiation is something we should all be concerned about because every time we go into the cath lab, we're exposed to radiation. This is the first ever X-ray that was taken. It's Mrs. Rontigen's hand in 1895. I think it's kind of interesting that Rontigen discovered X-rays and he got his wife to put her hand in there to take the very first X-ray. Didn't put his own hand in. This is an early X-ray machine, and these guys used to control the output of the X-ray machines by putting their hands into the beam, and if they couldn't see the bones, they turned the output up. It's not a good idea to put your hands into the primary X-ray beam. Most of the early radiation workers suffered severe injuries. They lost digits, hands, limbs, and many of them died from radiation-induced cancers. And so they, in the first 10 years after X-rays were discovered, there was a rapid accumulation of knowledge as to the adverse effects of radiation. So we now know that 100 millisievert exposure is enough to increase your cancer risk. You should hold on to that figure. 500 millisieverts, if you receive it quickly, will make you acutely unwell, although you will probably survive that exposure. More than 2,000 millisieverts has a significant chance of killing you. If you get 5,000 millisieverts, there's a 50% chance of dying. 10,000, you almost certainly will die. Once the early workers became aware of these risks, they started to work on radiation protection. You can see in this 1950s cath lab, the operators are wearing lead aprons, but there's very little else in the way of protection. Nonetheless, they were able to work in cath labs. This is the first ever cardiac catheterization performed in a human on the left of the picture there, when Werner Forssmann inserted a ureteric catheter into his own heart and walked down the hospital corridor, had a chest x-ray taken. And the first cine coronary angiogram from 1958 by Mason Soames, this was done by accident. The operators didn't realize the catheter had entered the right coronary artery and power injected the right coronary artery. The patient survived. Okay, so we work in cath labs like this now. They're computerized, we have much better protection, doses are lower, the coronary angiograms produced are of fantastic quality. But the risks from radiation have not gone away. So here are some patient doses from some performed radiological procedures, so you can see how much radiation the patient gets from a chest x-ray. If you look at the bottom of that column, you can see that the cardiac catheter lab is the most radiation-intense environment that operators work in all around the world. So patients can receive upwards of 25 millisieverts from one single complex angioplasty. A CTO procedure, a couple of check angiograms, those patients can be hitting 100 millisieverts doses, 10, 20, 30 years of extra background radiation. The primary beam is what generates the picture from the patient, the yellow primary beam in this picture. But what happens to the primary beam as it passes through the patient is it's scattered outwards. And it's the scattered radiation that is dangerous to us when we work in the cath lab. The scatter can be really modulated and modified by patients. This is a patient of mine having a left and right heart catheter. And as patient's body mass index increases, the amount of x-rays that you have to administer to generate your angiographic and catheterization data increases significantly. And what you have to remember is that patient dose is linearly and closely related to operator dose. So as the patient dose rises, your personal dose will also rise. For an interventional cardiologist working in the catheter lab, annually, doses are often around 5 millisieverts. That's equivalent to 250 chest x-rays, 2 extra years of background radiation. Over a 40-year life in the cath lab, that can be 200 millisieverts, and remember that 100 is enough to induce cancer. That's the same as getting 10,000 chest x-rays, 80 extra years of background radiation. And in fact, you're allowed to get 20 millisieverts a year. So you could receive up to 40,000 chest x-rays worth of radiation, and your employer wouldn't be remotely concerned about that. Radiation exposure for operators and cath lab workers can be associated with major impacts. These can be direct tissue injuries. This is a patient who had a complex angioplasty, suffered severe injury to their skin. The operators didn't move the tube around enough. This is a really difficult thing to treat. This is a patient having an EP procedure. Their arm was left down by the side, not moved out of the way during a long complex EP procedure, severe injury to the patient. We saw some cases presented during the course of today where operators were putting their hands in the primary X-ray beam. I see it many times. Don't put your hands in the primary X-ray beam. This is a consultant who worked with X-rays and regularly put his hands in the primary X-ray beam. This case is from just a few years ago. This person can't work anymore. He's had amputations of his fingers and has malignancies affecting his hands. And don't put your hands in the primary beam. If you only remember one thing from this talk, don't put your hands in the primary beam. You also get other injuries as an operator. The pale areas on this cardiologist's legs are areas where the hair has fallen out of their legs, hairless legs. Underneath those hairless segments of skin is bone marrow. turning over really quickly. You can see why there's a malignancy potential there. This is a cataract. It's not a standard cataract, not an age-related cataract. It's a posterior capsular cataract. It's bits of calcium and stone formation in the backs of your lenses. This is an analysis of people attending a cardiology conference in the USA, and it looks at the rate of specific radiation cataracts in controls, 9%, cath lab nurses, 45%, cardiologists, over 50%. There's probably an epidemic of cataract formation on the way for those of us who've worked in the cath lab for a long time. Cancer induction is important. This study on the left of the slide shows markers of DNA damage in people who are not exposed to low levels, and exposed to higher levels of radiation. Markers of DNA damage rise with radiation exposure in the cath lab, and you can see in the right-hand panel in another study that there's an almost linear relationship between exposure and markers of damage. And so here we see in a study of 309,000 patients that once again there's a relationship between your exposure and your risk of cancer. One particular area of the body that's hard to protect in the cath lab is your head. And because of that, your brain receives a significant dose of radiation. So you can see that a patient undergoing interventional neuroradiology procedures can receive between 200 and 1,000 millisieverts to the brain. And the brain of an interventional cardiologist will receive on average about 2,000 millisieverts over their working career, more than the patient having a neurointerventional procedure. One big risk for that is brain cancer. Left-sided brain cancers have been reported in interventional cardiologists, and your risk, if you're a cath lab worker, of getting brain cancer is double that of the general population, maybe more. It's not just brain cancer that can be induced by radiation exposure. These are neuroregulatory studies of neuroregulatory proteins in cath lab workers. So the pale bars are unexposed individuals, and the dark bars are people exposed to radiation in the cath lab. And their levels of neuroregulatory proteins, the things that control the function of your brain, keep your neurons healthy, they're down-regulated when you're exposed to radiation. And on the bottom there, you can see a clear relationship between the level of exposure and the amount of down-regulation that occurs. And perhaps not surprisingly, in this analysis of 853,000 patients, a 100 millisievert dose of radiation significantly increases your risk of dementia in the top panel and of Parkinson's disease. So working in the cath lab and not being careful with radiation is not good for your brain. Radiation exposure and risk is not uniform. Women here in the red lines are more vulnerable to radiation than men, and young people are more vulnerable than older people. So our patients, their risks shouldn't really be a concern for us. It's the cath lab workers or young people. These are cancer rates in children treated with radiotherapy in childhood. You can see that as the dose rises, the risk of death from cancer rises in those children. This is the risk of breast cancer in women who work in the cath lab. It's significantly increased. It's almost doubled compared to an unexposed population. And that is why I wrote the radiation protection segment for this year's BCIS guidelines for performing angioplasties, and we wrote a specific section in to recommend that women have additional shielding for breast tissue on the axilla. Low dose radiation, this is a cascade of things that lead to atheroma formation, and the yellow flashes represent points where radiation interacts with that pathway and increases the risk of vascular injury. And so we see that there's a clear linear relationship once again between dose exposure and your risk of cardiovascular disease and ischemic heart disease events. You can reduce your radiation exposure. This is a radiation worker from 2017. I don't recommend you get yourself a set of these and go into the cath lab on Monday. You might frighten the rest of the staff. Shielding is really important. This is dosimetry in a cath lab. And you can see that the lead shield placed in front of you makes a massive difference to your exposure. And of course, now there are many different types of advanced lead shielding, the Rampart system, the egg nest, ceiling suspended zero gravity systems, this Israeli system that collimates the beam more tightly, and they all work. So you can see here compared to controls that they all work. Shielding always works. The Rampart system is the most effective, but I've tried the Rampart system and it's really difficult to work with it. You can't get access to the patients. When we go into the cath lab, most of us wear a 2-part lead apron and a thyroid shield. You can do a lot better than that. You can wear lead protection glasses and you can wear leg shields. I see hardly anyone wearing leg shields. The dose to your legs is really high because a lot of the scatter radiation comes out under the tables. So you see here markers of DNA damage before and after working in the cath lab in the 2 red bars without lead shields. And you can see that that DNA damage is really limited by wearing leg shields. The cath lab is more dangerous in some countries. So you can see here that in the UK, we're quite good at limiting radiation exposure compared to our European counterparts. Why is that? Is it education? Is it differences in, it must be differences in practice. You can also see that different operators generate very different levels of radiation. For radial in red and femoral, femoral in red and radial in grey, the operator at the top there generates far less radiation than the operator at the bottom. The guy at the bottom doing the same procedures generates 8 times more radiation than the guy at the top. Perhaps this is one of the reasons. This is some data from India, 185 people who are cath lab operators who were surveyed. These are 9 different ways of reducing your radiation exposure. Simple things like using the over-table lead shields, turning the frame rate down, limiting your amount of acquisition runs. Okay, and what you want to see is a green bar stretching towards the right. And in only 2 of these routine methods were they used in more than 50% of cases. So it's the operators who are not doing the simple things. I've written extensively about radiation protection. I just flagged this up for you. You can find this in Heart from 2020, and it will cover some of these issues in more detail. This is my personal dosimetry over 20 years. Okay, so my annual exposure from working in the cath lab, latterly doing 100 TAVIs a year, doing 200 angioplasties with a complex case mix, my annual exposure was 0.372 millisieverts. So over my career, I probably received less than 20 millisieverts. And to be honest, there are places in India where background radiation is at that level. Some of the coastal areas. So my radiation exposure, because I was worried about it and I was careful with it, was minimized. Okay, so what can you say in conclusion? Radiation exposure for healthcare professionals is a significant risk. It's associated with increased rates of cancer, cataract, skin injury, neurodegeneration, and cardiovascular disease. And if you're good at radiation protection and you optimize your strategies, you can minimize your exposure. But the knowledge and application of these procedures and ways to minimize exposure is poor amongst us. Thank you.
Thank you, Professor Nolan, for a wonderful lecture. A couple of points that I would like to highlight is that when we talk of radiation protection, there are a couple of things very fundamental and very basic which needs to be understood. The most important is awareness of radiation. Second thing is the time, distance, and shielding. These 3 basic things. You should spend minimum time. You should be away from the source as far as possible. And of course, time, distance, and shielding. You did mention a list of cancers that can happen because of radiation, and it's a well-documented thing. There are certain mechanical things that also happen because you wear the radiation protecting gear, like orthopedic problems. These are well known. And radiation is something that if you use properly, nothing will happen. We have been using it for years, and it's very safe, but you should know how to use it and how to tackle these problems.
Yeah.
If you give a dagger in an oily palm, obviously it's going to cut. So that is the message that I would like to say. Yeah. It's very important. Second, one more important thing, I was looking at a data from Italy, and I saw that intervention radiologists, only 10% of ladies are intervention radiologists. And this is because of radiation fear. So there is nothing to fear, but you have to be careful. And in the panelist, I see 2 intervention ladies. So it's heartening to see that at least in Bihar, they have a good number of intervention.
Sir, in a single center where only one intervention cardiologist is available, and every day he has to do 10, 15 procedures, how can we prevent ourselves from exposure?
I mean, you've made all the right points, time, distance, and shielding. So I'll give you a couple of examples. We used to run our frame rate for fluoroscopy at 12.5, and I saw some data that you could turn it down to 7.5, drop the dose to the operators, and maintain image quality. And I asked our chief radiographer, I said, turn it down to 7.5, but don't tell anyone. And nobody noticed. None of them noticed. You can turn it down, and it will still be fine. And when I was doing diagnostic angiograms, if the catheter was stable in the coronaries, I would stand down the bottom end of the table with an extension tubing attached to the manifold, because moving a couple of feet away makes a massive difference to your dose. In terms of, it's harder to protect yourself in electrophysiology procedures, particularly pacing, because you're up at the top end there. Bit better for invasive EP, but it's hard to protect yourself when you're near to the patient's head end. The same for interventional echocardiographers. So you have to be really careful. I think it's your own health that you're looking after there. It's really important that you take control of it, you get yourself some leg shields, you get some radiation protection glasses, and if you're a woman, you get the additional auxiliary shielding that's available. Even if you have to pay for it yourself, because the hospital won't do it, it's really important to do things like that. I mean, I have a whole other talk of exactly how to set the lab up, but you know, I can't do it today. It's too short a time period. Another thing that's important that most cardiologists don't realize is that the equipment that you use, the cath lab equipment, the different manufacturers produce different amounts of radiation for the same image quality. So newer equipment is always better than older equipment. When our cath labs came up for renewal in the hospital, there were 4 Siemens catheter labs, and the hospital had a block contract with Siemens. And I knew from looking at the literature that Philips was producing only 50% of the radiation of the Siemens systems. And I had a whole year-long fight with the hospital managers because I wouldn't accept more Siemens labs. And we did eventually get 4 Philips labs. So, you know, the different, nobody tells you that. That information's not given to us. We're the people who go in there. Nobody bothers to tell us. You have to search for it and find it yourself. Get a Philips lab, you know, if you, I have no affiliation with Philips, by the way.
Sir, can I ask you a question, sir? So there is a new thing called lead-free approach. Is it good for the cath lab?
I'm never going in a cath lab if you send me in there without lead. I don't care what you do. Okay, you as you said, orthopedic injury from the weights and the cervical spine, lumbar spine, they're an issue. But you never completely eradicate radiation exposure in a lead-free lab. It's never completely eradicated. So, you can wear the lightest possible gear in that situation, but I would still always be wearing a 2-part lead apron. The other thing, the commonest reason that women give for not pursuing a career in interventional cardiology or EP is concerns about radiation, particularly around pregnancy. And, there's some validity to those concerns, but the fetal exposure is actually tiny when you look at what is known to be pathogenic to the fetus. So if you're good at radiation protection, you understand it, you can work, as a woman, you can work without any significant excess risks. But not in a zero gravity thing. I don't think so. Anyway.
Thank you, sir.
Okay.
Excellent. Ranjan? Yes.
Last question. Excellent talk, sir. And the important thing is we should be aware about the radiation and we should follow strictly the protection methods so that we can reduce what we have said to 0.3 millisievert a year.
Yeah.
Thanks a lot, sir.
Yeah, thank you everyone. Now we move to the next session. Basically it is a combination of 2-3 sessions. From some topics were left, we will be covering all those. First of all, I will invite moderator for this session, Dr. Shraddha Ranjan, if she is here. Dr. Supreet to chair this session because one cardiac surgery session and pediatric session has to be in this session. Dr. Rajesh, if he is here. Dr. Ashish Sinha, if he is here. Dr. Nishchal Shah, Dr. Aman Sinha, Dr. Rajiv Agrawal sir. I will like to call Dr. Chandraket to panel this session. Dr. Deepankar Sahgal sir, he is Director of Cardiac Anesthesia. So the next talk will be Dr. Mayank on robotic CABG. Dr. Mayank. I would like to call Dr. Shushil on the stage.
Yes, Dr. Mayank, you can start the session.
Thank you. So, good evening all, respected chairpersons and panelists on the dais, senior faculty members in the audience, and dear colleagues. I am here on behalf of the cardiac surgery team at Medanta, Patna to give you a glimpse of what the future of cardiac surgery would look like through this case presentation. So, our patient is a 70-year-old male, 170 centimeters in height and around 69 kilos, BSA of around 1.8 meter squares. He is a known hypertensive and diabetic on oral medications, well controlled. On echocardiographic examination, the patient was found to have an ejection fraction of around 40% with hypokinetic anterior wall. No valvular abnormalities were detected. On CHE, there was a discrete proximal LED stenosis of about 90% with normal circumflex and right system. Coming on to the anesthetic considerations, which are slightly different for a robotic case, followed by a standard induction. The intubation is done with either a double lumen tube or with a single lumen tube with bronchial blocker for lung isolation. Central line and Swan-Ganz catheter is inserted to monitor the PA pressures during one lung ventilation. It is imperative because we know the CVP is a poor marker for fluid resuscitation, and also with one lung ventilation, the PA pressures change and then it becomes important whether we want to give inotropes to manage the blood pressure or we want to give fluids. Arterial pressure is monitored through routine radial and femoral arterial lines, and TE probe is inserted to monitor the activity of the heart. Followed by this, the patient is positioned on the, sorry, the pointer is not working. So on the left hand side of the screen, we have the image of the patient. The neck is flexed, the arm, left arm is slightly abducted and flexed at the elbow joint to expose the left side of the chest. The left hemithorax is also elevated by approximately 30 degrees by either the help of a bolster or with the help of an inflator bag. On the right side of the screen is the position of the ports that are placed for docking and instrument insertion. So if the patient is tall, like for this example, this patient, we prefer the 3rd, 5th and 7th intercostal spaces, and if the patient is short with a short hemithorax, then we prefer 2nd, 4th or 6th intercostal space. So after port placement, the robotic arms are docked and the instruments are inserted. The pericardium is opened and the site of grafting for the LED is identified. After this, the lima is visualized and harvesting begins in usual fashion by removing the endothoracic fascia. Distally, the IMA is harvested up till the bifurcation and proximally up to the first intercostal branch. The bigger branches are clipped and divided, and the smaller branches can be safely cauterized. Hemostasis of the lima bed is done in the same sitting. After this, the robotic arms are undocked and the port site hemostasis is checked. Followed by this, there is thoracotomy. The thoracotomy usually follows the same intercostal space as the port which is used for camera insertion. And after thoracotomy, under direct vision, the lima is divided once heparin time is over. So this is a picture of lima that has been harvested almost completely. It is slightly, you can see, because of the magnification that the robotic system offers, it does look a little messy, and even a single drop of blood appears magnified and it may look more bloody than it is. After this, the stay sutures are taken on the lima to prevent any axial rotation. Followed by this, there is octopus application for stable epicardial stabilization, and grafting is done as in standard fashion. This image shows the setup that is used for the retraction of the rib spaces, and you can see the epicardial stabilizer that has been introduced through the port that was used for left arm. This is the image of a finished lima to LED anastomosis with the epicardial stabilizer in situ. Well dilated lima has been anastomosed to a good caliber LED. And this is the final result. The scar looks neat and clean, 7 centimeters usually, which we are working on to make it even smaller. And if I may be so bold, the incision is hardly any bigger than a standard pacemaker pocket incision. The post-operative course, the patient was extubated on day 0 without the requirement of any inotropes. The chest drains were removed on day 1 and the patient was made to ambulate. The patient was shifted out of the ICU on day 2 and was readied for discharge on day 4. Patient did not require any intra or post-operative transfusions of either the blood or blood products. He had minimal pain, which was well managed with oral analgesics. So coming on to the theoretical part of the talk, the robotic CABG are primarily of 2 types. One is the robot assisted CABG, which most of the people and we are also using, where we use the robotic thoracoscopic internal memory artery harvesting followed by an off pump lima to LED or multi-vessel anastomosis using a mini thoracotomy. Whereas there is also something called as TCAB, which is totally endoscopic coronary artery bypass. The robotic thoracoscopic approach is used not only for IMA harvesting but also for the anastomosis. These are the different robotic systems that are available in the market as of today. Da Vinci robotic systems by Intuitive Medical, the oldest and the most established one. The SSI Mantra, which is made in India for the world as they say it. And this is the robotic system that we have in our hospital. The newly launched Merrill robotic systems, which is still in the testing phase. The Versius from CMR Surgical and Hugo Ras from Medtronic. The operating room setup is also slightly different. Most of the robotic systems have 2 major components. One is the surgeon console, where the surgeon sits and has a 3D HD camera to visualize the surgical field, and the instrument cart. The surgeon's display system has 3D high definition image, a user interface, and electronic controller, and the instrument cart has 3 to 4 columns on which the instruments are mounted, and usually the center column is used for camera port as a camera port, and the side arms operate the instruments. So this is what a typical image of a robotic OR looks like. On the left hand side, we have the 3 robotic arms that are docked into the patient's chest cavity, and you can see a screen in the corner which gives us a magnified, 10 times magnified image of the surgical field. And on the right hand side, we have the 3 ports that are inserted through which the instruments will be inserted. So the advantages of robotic assistance, there are clinical and technical advantages. The clinical advantages include less post-operative pain, better wound healing and less chances of wound complications, fewer transfusion and transfusion related complications, early mobilization, and ultimately a shorter hospital stay. The technical advantages are there is an enhanced vision, there are precise micro movements, there is better control and better dexterity, there is motion scaling in almost all the robotic systems that are available in the market today, and there is also tremor filtration in that. With this, they offer around 7 degrees of freedom of movement, and that basically means there is a greater range for movement. Although the robotic system that is available today also has slight disadvantages. The learning curve is steeper. We have to learn to control the robotic instruments and the arms, and we have to train our entire team to get used to and accustomed to the robotic setup. There is lack of tactile feedback. None of the systems as of now have tactile feedback, which basically means that we don't know how hard we are tugging on a tissue, and that poses a problem for most of the surgeons. Although this can be sorted out with little practice and with experience. And also the cost of procedure for a country that has economical problems, it is a problem. But minimally invasive surgery and robotic surgery is the future, and it is here, and we have to embrace it. And we, at the Medanta Patna, we are shifting to non-stenotomy approaches for common procedures, including multi-vessel and single-vessel CABGs, mitral valve replacements, aortic valve replacements, tricuspid valve repairs, ASD closure, with progressive increase in numbers each month. So this graph basically has our monthly data. We can see that towards the end, like in October and November, we have done quite a few number of cases through minimally invasive approach, and as of this month, around 20% of our cases have been done either by robotic or minimally invasive technique. These are some of the images of the final scars, what they look like. These are immediate post-operative period. They tend to get better with time. The image on the extreme left-hand side is a right anterior thoracotomy AVR. The middle image is of mixed mitral valve replacement. On the extreme right is the robotic CABG. Again, mixed mitral valve replacement on the left-hand side. In the middle, we have a mini hemistenotomy AVR. And on the extreme right is transaxillary mitral valve replacement. This was done on a young female patient. There was no need to go through the breast tissue. We had gone through the transaxillary approach, excellent exposure, and the scar was not even visible because it comes under the patient's arm. We are also trying to maintain a better registry by collecting patient data through the STS, Adult Cardiac Surgery Database Collection Form. We are trying to do it diligently so that we have an authentic registry of the patients in our follow-up. And the vision for the department is to expand the use of robot, get into thoracic and thymoma surgeries as well. We want to do all mitral valve operations via minimally invasive techniques, and most AVRs via mixed techniques. Ultimately, we would want to venture into double valve procedures through minimally invasive techniques, and we would like to compile and analyze all our patient data from the last 1 year. The Department of CTVS and Cardiac Anesthesia thanks you. Thank you. Questions are welcome.
That was a great presentation, Dr. Meng, and congratulations for the great work you are doing along with the CTVS team. I would like to request for some comments. Dr. Dipankar, sir.
Are you trying to compete with us?
Definitely not, sir.
Definitely no competition, but the things are doing in a great. They are doing in a great way. Even this MICS cases are more than Gurgaon Medanta. I can tell you, yeah. This month at least, I can say.
I think it's a good thing that our talk was shifted down, you know.
So, how it feels, it is different from laparoscopic surgery. How robotic surgery is different from laparoscopy?
So unfortunately, I have not had any general surgery training.
Okay.
So I had the 6-year course. I came directly nose-dived into CTVS. So I have, no experience to compare it with laparoscopic surgery.
No, if we compare from the lap surgery, cardiac surgery is entirely different from any other surgery. Because what we are doing, we are using heart-lung machines, where we are dealing with a high-risk patient. Patients, most time they're unstable patients. It's not like any other surgery. वहाँ पे patient stable होते हैं, you have to perform a surgery. Here, patients already unstable. We are insufflating CO2. We are putting one lung down. It's such a high-risk condition. So we have to be very, very cautious. And thanks, you are also playing very important role managing patient during our surgery. So I would like to tell you, last month we have performed 4 robotic cardiac surgery, robotic CABJ. So this is a very good number, and progressively we are increasing our number. As Mang told, that we are trying our most of the mitral valve surgery, aortic valve surgery, even we are trying to do double valve surgery also, because few of my friends are doing double valve surgery also, ASD, and even LA tumors, RA tumors. We are trying to do all such kind of procedure through minimally invasive technique and robotic technique. Last month we tried one ASD also, robotic, but we are facing some problem with our heart-lung machine. For that also we have ordered, we are trying to procure one special equipment for that, so that we can get rid of that particular problem also. So we are not here to compete with cardiologists. Pramod sir is our leader. And we are the cardiac sciences department. Yes. So we are the department of cardiac sciences, and Pramod sir is supporting us like anybody else. So we are here to work under Pramod sir only, under his guidance only. So we are trying to do more and more robotic cases in near futures.
As compared to laparoscopic surgery, the magnification is going to be much higher in case of a robotic surgery. However, having said that, we would also be trying to have a endoscopic surgery for a ASD closure initially, which again will have minimal of chest retraction, so that once the ribs get spread, there is, even though it's a misnomer that a thoracotomy would not have a pain, but it is actually more painful than a sternotomy. So without a rib spreading, if we can offer a surgery, it is going to be much more less invasive and less painful to a patient. And in future, we would be trying that as well.
Just one question. Are we getting additional imaging before robotic surgeries like CT or MRI?
We are trying to do in some kind of procedure, like if we are planning aortic valve replacement, when we go for CT chest. And for CABG, although few guidelines are there, we have to see some particular distance, CT chest of the patients. So there are few investigations like CT chest, we have to go for that.
Getting our imaging done, but as per European Society of Cardiology guidelines as well, for all aortic surgeries, they suggest a CT aortogram to be done, so that a proper estimation of your valve annulus can be done, and you can make a measurement as to what kind of a valve you're going to be putting in at the time of surgery, prior to surgery, rather than at the time of surgery, that you make a decision that this is the valve that is going to be put inside the patient.
Regarding the lung adhesions.
Yeah, so just a side comment on that, sir.
CT chest,
Hi, so exactly, sir. The problem with CT chest is most of the times even they are not able to tell us if there are finer adhesions in that. And that is something that we know only when we insert the camera. Like for our last case also, where we are doing CABG, there were lung adhesions, but fortunately they were on the medial side and on the pericardium, and we could deal with them after we had harvested our internal mammary artery. So, it's a good guess as anybody else's, and it doesn't really pose a problem if we have no imaging. Like our seniors mentioned that For aortic valve surgeries, CT aortogram is more important, but for ordinary CABG, I don't think.
But I should think as an anesthetist that if CT chest and neck should be done, it will be helpful to anesthetist also, because while this putting this double lumen tube and bronchial blockers, so sometimes tracheal stenosis and these kind of things are there which are not they are not visualized on normal X-ray. If X-ray quality is not better, then we cannot visualize the trachea.
Obviously, it's not robotic is not for all cases. We have to have a proper case selection for robotic or MICS cases. So there are a few criteria, like in CT chest, we have to see the distance of the sternum from the mediastinum, and various angles are there that we have to see before planning for the surgery.
Thank you.
We'll conclude this session because our next speaker is going to be online, and is Dr. Bharat Dalvi. He could not join us because of flight delays. So his topic is, are my rims adequate for ASD closure? Good evening, sir.
We can hear you, sir.
And can you see my slides?
Yeah, we can see, sir.
Okay. So at the outset, let me thank Dr. Ashish for the kind invitation, and unfortunately due to SpiceJet, I cannot be with you in Patna. I have been asked to speak on are my patients, or rather are my rims adequate for ASD closure. Now you will wonder how patient is aware of this fact about rims. So it's important to realize that in 2025, before your patients meet you, they meet a cardiologist by the name Mr. Google, who has already increased his group by taking into his group 3 more doctors, Dr. OpenAI, Dr. Gemini, and Dr. X. So it's not unusual in our practice for the patients to ask this question, are my rims adequate for ASD flow? Now if you look at this particular cartoon, you will have an understanding of how the rims are and where they are located. So this is an en-face view of the interradial septum, and if this is the ASD, then at 0 degrees on transesophageal echo, when you view from mid-esophagus, at 0 degrees what you see is the AV valve ring and the posterior-superior rim. At 40 degrees what you see is the aortic rim and the posterior-inferior rim. And at 90 degrees, or in bicable view, what you see is the SVC rim and the IVC rim. Now, it is very important to understand that these rims are not a single tissue line, but it is a complete sector. So, it's a continuum. Don't be under the impression at 40 degrees there is no rim, means there is no aortic rim. It's not like that. Aortic rim is a continuum from this portion right up to here. And that is why it is important to look at the interradial septum and scan the interradial septum in 360 degrees. Unfortunately, there is no universal definition for a deficient rim. It also depends upon your experience, expertise in deciding what you would consider as deficient and try and refer that patient for surgical intervention rather than taking him into the cath lab. When we started the program, the rim length of less than 7 millimeters was considered as inadequate or deficient. Whereas as we grew in experience and expertise, I think maybe a rim less than 5 or even 4 millimeters can be considered as deficient but sufficient for device closure. There is only one exception to this rule, and that's the mitral rim. If it is less than 7 millimeters, irrespective whether it was 1998 or 2020, I think we would probably not consider this patient for device closure because of the issue of mitral valve injury over a period of time, which can have really very serious implications if the patient were to go for mitral valve repair or replacement. And lastly, aortic rim, that was never a problem. Even a complete absence of aortic rim is not a contraindication and should not be considered as being deficient from point of view of transcatheter closure. Now, what is the important thing about aortic rim deficiency is the fact that this was thought to be a predictor for cardiac erosion. And some people really brought it to the center stage saying that the deficiency of aortic rim is an incremental risk factor. I'm not trying to say that it's not an incremental risk factor, but suffice to say that the data in literature as of today is anything but robust, and that's why deficiency of aortic rim cannot be considered as a contraindication. As a matter of fact, in most of our experiences, and you will agree with me that almost 75 to 80% will have aortic rim deficiency, and maybe more than 60% will have a complete absence of aortic rim deficiency. So this is a classical case of sufficient rims. This is the AV rim, that is the posterior superior rim. Then in short axis, you have the aortic rim, and that's the posterior inferior rim. And in bicable, this is the SVC rim, and that's the IVC rim. So this is the best case, a book picture for transcatheter closure of atrial septal defect. And this is how the defect will look on a 3D echo. That's the SVC, that's the IVC, that's the posterior superior, that's the anterior inferior, that's the anterior superior, posterior inferior, and this will be the SVC and the IVC. Now this is an example, exactly the other side of the spectrum. AV valve rim is maybe just borderline, but posterior superior rim is almost absent, aortic rim extremely deficient, posterior inferior rim is absent, and both SVC and IVC rims are absent. So no matter what your experience, no matter what your expertise, this defect cannot be closed in the cath lab as of today and has to go to the operating room. And these are some of the defects on three-dimensional echo. Will show you complete absence of the IVC rim, extremely deficient aortic rim, also deficient in posterior rim. So these are not the best cases to be taken to the cath lab. Now I will just show you some of the examples of deficient rims. So this is a case where you can see in the short axis view, there is hardly any aortic rim. Even when you go to between short axis and bicable, around 58 degrees, again, no aortic rim. And when you go to nearly bicable, you see here, there is hardly any SVC. So this is a candidate which has a very high propensity for aortic erosion. So it's not only in one plane, but over a part of the sector, when there is a rim deficiency, you should be careful. On the other hand, you can see here that you have the posterior superior rim, which is just adequate or deficient. This is posterior inferior rim, again a large defect, but just adequate. And you can see the IVC rim, again maybe deficient, but just okay for device closure. Now this is a patient where, since the image sector shows you a small rim or a deficient rim, is likely to be prone to embolization. And these are some of the things which are important. It's not only one plane, but over a sector, when you have deficient rims, you have to be careful. However, before saying that the rims are deficient, you should be sure that they are not pseudo-deficient. And what do I mean by pseudo-deficient? More so seen in posterior inferior rims. Look at this case. So you will feel that at 0 degrees, the posterior superior rim is deficient. The moment you retroflex the probe, you can see how beautifully you can see the posterior superior rim. In a short axis view again, posterior inferior rim, not seen at all. But you retroflex and you can start seeing the posterior inferior rim. And that's the bicable view. You don't see the IVC rim, but the moment you retroflex. So this is what I mean by pseudo-deficient or pseudo-absence of rims. You have to image the interatrial septum well, and that's why imaging is a very important aspect. It's not only intervention, but understanding the images. So if you have severe deficiency of rims, if you have multiple rim deficiencies, and if this rim deficiency is associated with a deficiency in the strength of the rim, that is floppy rims, and if that is associated with large defect, please do not hesitate to send this patient for surgery. Surgery is not a four-letter word. You have to know when not to take the patients. I mean, it's very, very important to know the limitations of device closure. However, if the deficiency is not very severe, only if one of the rims, like aortic rim, is deficient, all other rims are sturdy and not floppy, and if the defect is moderate size, always attempt a device closure before sending him to the operating room. I think this is the most important part of my talk, is the counseling of the patient and the family. You must do it in the clinic, when you meet the patient the first time or the second time during your OPD visit, and more importantly on the day of the procedure. It's not a great idea to allow your registrar or a clinical nurse to do the counseling, but you should do it yourself. Always be friends with your surgeon, because in case of eventuality, they are the ones who are going to help you. Keep everything ready in the cath lab and OR, because complications don't knock before coming. And in case of embolization, you should be ready to do it immediately. In case of erosion, I think it's very important that you tell the families that erosion may not occur immediately, but can occur in weeks, months, and sometimes even after years. But it's very important that any excruciating chest pain in a patient with device closure should go to the emergency room as soon as possible. These are the technical tips. If there are deficient ribs, please prefer assisted deployment. You may use catheter assistance, dilator assistance, or balloon assistance. Many people do it after failing a couple of times. We do it prophylactically. The general dictum is, if you have superior and anterior rim deficiency, deploy the device through left superior pulmonary vein. If you have inferior and posterior rim deficiency, deploy your device from right superior pulmonary vein. I just discussed 2 cases with you before I conclude. This is a 22-year-old, shortness of breath, palpitation, has a large ST. And you saw this just before. You can see that at 0 degrees, again at 39 degrees, again at 56 degrees, and 86 degrees, nothing. So this patient, we came from the left superior pulmonary vein, and you can see how beautifully at 0 degrees also that tiny little nubbing is held. At 40 degrees, there is hardly any rim, but the device is sitting beautifully across the aortic root. This is somewhere between the bicable and the short axis, and that's the bicable view. So this patient had a great outcome with left superior pulmonary venous deployment with balloon assistance, of course. This is the second case, a 76 years old, again, exactly opposite side of the spectrum. NYHA class 4, severe heart failure in atrial fibrillation on hemodialysis, has a very large ASD. You can see this. It's a very large ASD, but trims are not too bad in porchamber view. But in short axis, you can see there is hardly any posterior inferior rim, and in bicable, you can see that the IVC rim is quite deficient. And in 3D, you can see that there is just a sliver of tissue all around, with the device being barely, with the defect being almost 40 millimeters in diameter. And in this case, we used a 44 millimeters fenestrated device, and this is the balloon assist technique. This is the 44 millimeter device with LA disc and now the RA disc, and then the balloon is deflated, and you can see that after removal of the balloon and the wire, the device is released. And this is how it looks on transisphageal echo. This patient had a fenestrated device because we were worried about diastolic restriction, which may get manifested after closure, given his age and other comorbidities. Now, these are the patients where you have multiple rim deficiencies, very large defect. You can see here, so many rims are just not seen, and it's the best idea to send this patient to the operating room. And you can see here in the operating room, the IVC rim was almost completely absent, and the posterior rim was significantly deficient. You can see this is the posterior rim here, and that's the IVC rim there. So it was a wise decision to do it. But despite whatever you may say, you know, nature is always one step ahead, and no matter, we have now been in this business for 27, 28 years. But once in a while, we face this problem, because I think we overstep a little bit, thinking that we may be able to get there. This was a patient who had to undergo surgical removal because this is a 40 millimeter device. We couldn't have put anything bigger. And again, you will see that there is hardly any IVC rim, and the stitches have to go actually through the atrial wall to fix the patch. So in conclusion, ladies and gentlemen, it is preferable, those who are beginning their program, not to attempt in first 100 cases patients with deficient rims, because what happens is that you will get the blame and the procedure will get the blame. Once you do 100 cases successfully, then people will say, oh, maybe that the patient was complicated. So never do it in first 100 cases. Maybe you should never do it, but certainly not in 100 cases. Probably you should never attempt patients who have multiple rim deficiencies, along with the length of the rim being deficient, the strength is also deficient, that is, you have redundant septum primum, and if that is associated with large defect. Most importantly, counsel the patient and the family regarding embolization and regarding erosion, and keep cath lab and OR ready for any form of eventuality. Lastly, when in doubt about the adequacy, please don't send the patient to surgery. Thanks for your patient hearing, ladies and gentlemen.
Good evening, sir. Ashish here.
Yes, sir. Go ahead.
Thank you, sir, for taking this pained late Sunday evening and giving this wonderful talk. It's all clarity what you give always. For the audience, I mean, a lot of this technique sir was discussing. He has pioneered these techniques and we have been learning from him. Sir, I got two questions. One is particularly if you have seen a patient who has got poor transthoracic images and you have done a TE in the OPD and you found that it is suitable for the device and you take to the cath lab, how many often you will do a TE on table also, or you will go with your transthoracic image?
See, I'll tell you, Ashish, there are many groups who do it with transesophageal in the outpatient, and then if the defect is quite central with adequate rims, they don't use transesophageal during the procedure. But it has been our practice to use transesophageal in 100% of our cases, and we do 100% of our cases on under general anesthesia. Somehow I find it very safe to do it under transesophageal echo, and we have such wonderful anesthetists that complications of general anesthesia or transesophageal echo are minuscule. I'm not saying they are zero, but they are very, 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 very small, and I'm willing to pay that small price for the kind of safety and for the kind of peace of mind that I have while doing the procedure, and that's why this is our approach. But I would not certainly criticize somebody who does it only on outpatient basis and then goes on to do only with transthoracic in the cath lab. But gain some experience before you shift from transesophageal to transthoracic. Don't do it in your first few cases.
Yeah. The second question I got is that sometimes we find the malalignment of the septum. So in those cases, you will go with the same rule of rims like 7 millimeters, 5 millimeters, or you will have some different approach on that. And another follow-up question, since the audience is most of them are adult cardiologists, recently there has been buzz about the late onset diagnosed ASDs, which has been discussed in a lot of meetings recently. Papers are there from Japan and all. They are doing it 70s and 80s. What is your opinion on that?
Excellent. Both the questions, great questions. So first let me talk on malalignment of the ASD. I did not purposely touch it in the interest of time. When you talk about malalignment, what it actually means is the malalignment of septum primum with septum secundum. So you will see septum primum go away from septum secundum and attach itself to the roof of the left atrium, beautifully seen in bicable view and sometimes in short axis view. Whichever view is not the best view to define malalignment. And people who are used to transesophageal echo, they diagnose this as a spiral septum. The only problem of a spiral septum when there is a significant distance between septum primum and septum secundum is that the only way of closing this ASD is oversizing the device. If you don't oversize the device, the problems are you will either embolize the device in the left atrium if you have only captured septum primum without capturing septum secundum, or if you have captured only the lower part of the septum primum and septum secundum, the device will embolize into the right atrium. What you need to capture is both upper and lower part of the septum primum and septum secundum, and that is possible only by oversizing. But when you oversize the device, there is a trade-off that you might end up with erosion. So if you think that the malalignment is very significant, I would prefer that that patient goes for a surgical closure rather than coming to the cath lab. Not that it is not possible to close it technically, but there are concerns, more so if you are doing it with large defects, both of embolization and of erosion. Now coming to the second question regarding closing ASDs in 70s, 80s. Really, when I was a fellow in cardiology, we were told that beyond the age of 50, if you close ASDs, it doesn't really make a huge difference because many of these patients used to have significant morbidity and mortality as well. People really did not realize the restrictive physiology of the left ventricle as being contributor to the morbidity in the post-operative period. But having realized this, what the Japanese data very clearly shows is that the quality of life improves significantly. But two or three things. One is these patients need to be well prepared before bringing them to the cath lab. So put them on diuretics, put them on vasodilators. If there are other comorbidities like diabetes, hypertension, treat them adequately before bringing them to the cath. Before releasing the device, please confirm that LVDP has not gone up significantly. You can do it with balloon occlusion, you can do it with device occlusion, what we call as test occlusion. And only when you are convinced, then only you can release the device. If you are in doubt, the best way is to fenestrate the device and then close the ASD. And if you think that despite fenestration also that the LVDP is going up, it is better not to close it. It is better not to close this ASD. Whether you close it in the cath lab or in the theatre, I think you need to treat this patient medically even more aggressively before getting into the cath lab or stepping into the OR again. So these are my thoughts about closing ASDs.
Thank you, sir. Thank you for your time, sir.
Sir, I have one more question.
There is another question.
One question, sir.
Yes.
So when we are planning ASD closure in aortic deficient rim, aortic rim deficient, the textbook teaching is to size it with plus 4 millimeter. But in the other hand, when we are closing in aortic rim deficient plus larger size, there is a more chances of cardiac erosion. So how to size in such situation?
I don't think that I have really a magic formula for this. However, it has been our practice to size every ASD with a balloon. And why do we do it? Because we use balloon-assisted technique very often in large ASDs. And see, I will tell you that no matter whether we use balloon or whether only transthoracic or only transesophageal to decide the size of the defect, anything as far as ASD defect size is concerned is an approximation. But in our experience, balloon approximation or balloon sizing is the best approximation amongst all approximations. And that is why we go by balloon sizing and we decide what the size is. Usually in aortic rim deficiency, I completely agree with you, we will go more than 2 or at the most 4 millimeters if the defect is very large and put that device. More often than not, we have been successful. But if you have multiple rim deficiency along with aortic rim deficiency, then the chances of embolization are high. We have not had cardiac erosion so far, touch wood, but I can't put my hand on my chest and say that we will never have it. So that will remain a problem, and I don't think that people understand the exact mechanism of cardiac erosion. So just blaming it on the aortic rim or only blaming it on the device size is not a great idea. Having said that, you must use as small a device as possible without risking embolization. That fact has to be emphasized. Oversizing the device is not a great idea. Not only from point of view of aortic erosion, but also from point of view of AV valve regurgitation.
Thank you, sir. Sir, one more question. We usually find there is a discrepancy in ASD size by transthoracic echo and transesophageal echo. Which one should be considered as appropriate for to begin the procedure? Although balloon sizing is most appropriate, but to keep the devices available and all.
Yes. So yeah, I will tell you very frankly that transesophageal echo, the resolution is far too better than transthoracic, and more so if you are doing adolescents and adults. In children, if you are doing ASDs in 8-9 kgs, then probably, yes, you can do it with transthoracic. My concern about transthoracic is that when the device is in position, looking at the SVC rim, looking at the aortic rim really becomes difficult because of the lot of artifact of the device during transthoracic. Transesophageal gives you a very beautiful picture of the rims, of the defect size in various planes, and that's why transesophageal echo has been our procedure of choice. There are people who use intracardiac echo. The problem of intracardiac echo is twofold. One is that it is very expensive, and second is that there is a very steep learning curve. So it will take time even if you were to start using intracardiac echo. But the biggest advantage of intracardiac, you completely get rid of general anesthesia in adolescents and adults. Of course, in children, there is no way you can avoid general anesthesia.
Thank you, sir.
Okay. Thank you.
By Dr. Anupam Bhambani on her behalf. Dr. Rajat will be presenting the case. Can I have Dr. Rajat? We have few sessions left in between. So we will be covering those. We have almost 4 or 5 sessions in total left. Can I have Dr. Ashish Sapre on stage?
So good evening everyone. I would like to thank the organizers as well as my guide Dr. Anupam for giving me the honor to present on this forum. So I will be talking about bifurcation stenting complication, the case we encountered. So talking about the patient details, it was a 71-year-old male presented to us with angina on exertion. ECG was suggestive of normal sinus rhythm, so we subjected the patient to TMT, which turned out to be positive for inducible ischemia with an intermediate risk and a DTS score of -4. So the echo was within normal limits with no wall motion abnormalities, and routine investigations were sent. Patient was planned for angiography. Angiography was done, diagnosed as triple vessel diseased, and planned for stenting to RCA as well as LAD-D2 bifurcation. So we went ahead, it went smoothly in the RCA. There was a proximal 70, mid 70, distal 50% lesion. We used JR 3.5, went with BMW, pre-dilated with semi-compliant balloons, and post deployed a sirolimus eluting stent of Ultimaster 2.75 into 50, and then post dilated with stent balloon as well as a non-compliant balloon, and the results were fine enough. We were happy with the RCA and shifted our focus towards the left side. So we went ahead in the LAD. It was a normal left main type 2 long mid to distal long segment 70% stenosis, and D2 was also involved. So we used a EBU 3.5 guiding catheter, and the plan was to go for a LAD D2 bifurcation stenting. We decided with a mini crush technique. So we used a BMW in LAD and a run through NS in the diagonal. We pre-dilated the diagonal with a semi-compliant balloon 2.5 into 12 millimeters, and then we positioned the diagonal sirolimus eluting stent Ultimaster 2.75 into 21 millimeters, and we crushed it using non-compliant balloon 2 into 15 millimeters in LAD at 12 atmospheres. So, but once we crushed it, so we realized that rather than being at the optimal site, we had landed the diagonal stent a bit more in the proximal LAD. So we decided to optimize the diagonal flow. So while we were trying to optimize the diagonal flow, we could not cross a 2.5 non-compliant balloon. So we went ahead with a 2 into 15 millimeters non-compliant balloon. However, once we were trying to cross it, while optimizing the diagonal, the LAD flow went off. So patient had slow flow as well as no flow in the LAD. So we managed with the tirofiban as well as now once the LAD flow started to compromise, so we decided to crush, leave the diagonal as such at that present, and first optimize the LAD and then shift our focus back to the diagonal. So once we shifted our focus towards the LAD, so because of that proximal crushed part of the stent, we were not able to cross it through anything. So we had to initially crush it with at higher pressures using, we went ahead till 22 atmospheres. We crushed the proximal part, but despite that we were not able to cross the stent across. So we had to use a guide liner assistance, and with the use of the guide liner we were able to deploy a stent in the LAD and establish the flow in the LAD. However, once the LAD flow was established, the diagonal flow was again compromised. So we again recrossed the diagonal with the guide wire, did post dilatations, and finally a kissing balloon inflation was done in the diagonal and the LAD with non-compliant balloons, and we were able to get good results. Both the diagonal as well as the LED flow were optimized, and we also did the pot in the LED stent with a non-compliant balloon of 3 into 15 millimeters. So this was our final what we could achieve in both the LED as well as the diagonal, and we had called this patient at 1 year follow-up. In the CTCA we could see that both the stents were patent, and we could still see that crushed part was placed in the LED, although it was there only, but no flow compromise, as well as both the stents were having an established flow in the LED as well as the diagonal. So the take home messages from our words was, first is the adequate knowledge of available instruments is always help in the bailout procedures in the cath lab, and critical decision making is always required in cath lab, when to justify which vessel to leave or which vessel to go ahead. And then we should always strive for optimal results when we have bailed out of the procedure, and patience and calm are the key to success in our cath lab. So this was our case. I would like to thank, and if any questions.
I
Why did you crush with the 2 into 15 balloon?
Actually, sir, we were initially not able to pass any balloon. Once that stent had...
No. Initially, while deploying the stent, you have kept the balloon, no?
Yes, sir.
So the size was 2 into 15.
Yes, sir.
Which is very undersized.
Yes, sir.
You should at least keep the size of the distal LED vessels, or sometimes now it is that new tendency to you can keep the you can take the balloon of the size of the proximal vessels diameter, and you, firstly you should dilate at the sub optimal pressure, and then just pull it, and then go with the nominal or high pressure, so that it should be crushed.
Gosh.
The 2 into 15, I don't think that was the proper balloon size you should have taken.
That is the reason everything has happened. The 2 mm means nothing. You have not crushed the stent, and then you remove the balloon, then try to pass another balloon. And the mini crush, both stents should be deployed. First deploy the LED and crush with the, remove the balloon and crush the diagonal with the LED stent, and then recross and pot. Recross, kissing and pot.
So we move on to the next speaker. Our next speaker will be Dr. Pawan Kumar Singh boss. He will be presenting a nightmare in the cath lab.
Pawan.
पेन डालेगा. And after his session, we will be shifting to the session dedicated to calcium management. So first speaker will be Dr. Ashok Kumar Bose, and his case will be moderated by and taken care by Pramod sir for calcium management, and the second session for calcium management will be by Dr. Shaheen Bose, and his session will be moderated by Dr. Neeraj Bose.
A very good evening to all. Coming to the case, this is the case of a refractory no flow penumbra saved my day. Slides. He was the 50-year-old gentleman, a known case of diabetic and hypertension, had recent NSTS, and he was admitted for the elective angiogram. Echo was a fair LV functions, and there was a RWM in LED territory. Lab parameters were within normal limit. And this was the angiogram. RCA was having the borderline lesions, and the LED showing the critical lesion, as well as the diagonal was very large caliber with the critical osteoproximal lesion in the diagonal. Plan was the provisional strategy. Actually, we wanted to do the depth to the diagonal and stenting to the LED. wired with the BMW in both LED and D1 and started pre-dilatation with the 2.5 into 15 NC balloon at 12 atmosphere in LED and at nominal 10 atmosphere in the diagonal, and then followed by the 2.75 into 15 Wolverine at 8 atmosphere in LED and 4 atmosphere in the diagonal. After pre-dilatation, the patient started having chest pain, and there was the slow flow and no flow in the LED. And this was the no flow which developed in the LED. Actually, and ECG was having the STEMI, anterior wall MI, and patient became restless. The first thought was that it was dissection which has caused the no flow, and we proceeded with the stenting. We thought that we will stent it and we will come out. Stenting was done with 3 into 38 Giant Sierra. After doing stenting, the proximally we could not get the no flow was persisting. We thought that we have missed the lesion in the mid LED and went ahead with another stent. As we can see that the distal stent was overlapped with the proximal stent, and there was some critical lesion which was not covered with the first stent. We thought that now we can get away with this the no flow, but no flow persisted, and then we thought that no, we are dealing with something else, and this is not the dissection which has caused the no flow. There is something else, and we immediately checked this ACT, and ACT was horribly very low, and it was 132. And then we started heparin and GP2B, and multiple rounds of thrombuster 6 French thrombosuction was done, and still and given all sorts of vasodilators like adenosine, nicoran, NTG, and adrenaline. Some flow was achieved with use of these drugs, and we could deliver these drugs with the use of the 6 French thrombuster distally also. We tried to deliver it as far as possible, and multiple rounds of this adenosine and adrenaline was given, but slow flow was persisting, and patient was in deep agony. Actually, we have to sedate him. Finally, we used penumbra, and we have used it twice, and after using penumbra, and this was the flow we could achieve after almost 2 hours of struggle, and patient was still better, but he was having pain, he was sedated, and we could come out with this. We have to just call up the day after achieving this flow. What I learned with this case, actually the patient is doing fine, and almost it has been more than 10 months after doing this case, and actually he is coming to my OPD. So he is doing fine, he is better. EFA ejection fraction is around 35 to 40%. Understanding the cause of no flow is crucial for its management. Checking ACT at frequent interval can save us from such disaster. Sometimes heparin can be faulty. When recurrent case of suboptimal ACT, check heparin brand and replace it. Avoid stenting until very sure about dissection, and penumbra can be savior in patients with very high thrombus burden. In my case, actually, on 2 consecutive days, it had happened with that heparin brand. So we subsequently changed that heparin, and we also made ensured that after giving heparin every 10 to 15 minutes, we will check the ACT during the procedure. And now we are fine with it, and till now, okay. Thank you.
So it was a great case. This was the day. From that day, we made a strict order to our cath lab nursing staff that whenever we give heparin, we have to check ACT after 10 minutes. And that rule is being followed from that day only.
Yeah.
So we will invite, if any questions, if
After your first, you cross in your wire, so you check your first ACT after 10 minutes, after giving the heparin.
No. After we give, after taking the radial puncture, we inserting the sheath, we give the heparin. And then after 10 minutes, after 10 to 15 minutes, actually we check for the ACT. Every 15 minutes we have to check, during the procedure time we check for the ACT.
Generally for your, after your instrumentation, probably 10 minutes is the time that you would have already deployed your stent. So if your ACT is still suboptimal, you will not be able to.
No, before deploying the stent, we have made this protocol. Before stenting, we need to know about the current ACT. Before knowing the ACT, we do not deploy the stent.
so basically we take more than 10 minutes time due to this reason also. We assure first that our ACT is in a good range, then only we deploy the stent.
Before a
times,
stent
is,
deployment.
at times stent is in our hands and we wait for ACT whether it has crossed 250 or not. If it has crossed 250, then we start inserting into the guide catheter.
But the best part is that after 5 minutes you can check the ACT and you will get the results.
Yes.
So you can prevent the harms.
Yes. We made the mistake and we learned from the mistake.
It happens in operation theaters also. Sometimes some patients have antithrombin 3 deficiency and all that. So ACT is not achieved. So we have to get some this FFP and all that to achieve the ACT, repeated heparin, or sometimes we have to change the heparin also.
Yes.
Sure. So some other anticoagulant heparin resistance is there. So after 5 minutes, within 5 minutes ACT should be done. Sometimes within 4 minutes we do in operation theatre. OT we do after 3 minutes we announce heparin time to surgeon, and within next 60 seconds we withdraw the ACT.
So I'll tell you what really happens. The sisters have been trained to start asking for ACT at 5 minutes. So all of us will resist that. I'm trying to cross the wire, just wait for 1 more minute. But now at least after this incident, everyone has agreed that okay, we will not put the stent unless until we have got it. So within 10 minutes, most of the time, we get an ACT time. That is what.
And one piece of advice, whenever you are comfortable with particular company and particular brand, don't change the brand and don't change the batch numbers. If batch number changes, just compare it whether the batch has been changed. Yeah.
That is not in our hand.
But we can ask for that.
So we move on to the calcium session. We will be having Dr. Ashok Kumar sir as our first speaker, and Dr. Pramod sir will be moderating his presentation. I will request all the persons sitting on dash to be there. I will request Dr. Nishchal sir to chair this session. And I will also request Dr. James Nolan sir to chair this session. Yes.
Sir, na? Sir, 1 second.
And I will request Dr. Pawan Kumar boss to panel this session. So in this session, the case overview will be given by Dr. Ashok, and after that, how the next plan will be and how it will be executed. It will be given by Pramod sir for this case, and after that, finally, what has been done, it will be discussed by Ashok boss, and finally, question and answer session discussion will be done for 2 minutes. Thank you.
इसी से आगे पीछे होगा क्या? Okay. Good evening, respected chairperson, dignitaries on and off the dais. Thanks the organizing team, Medanta, especially Dr. Shamshad, for giving me this opportunity. Today I am going to discuss a case, multivessel PCI in heavily calcified coronary artery. So coming to a brief case history, 61-year-old male, known case of CID, heavily calcified triple vessel disease, having recent non-ST elevation myocardial infarction with recurrent post-MI angina, having comorbidities in forms of diabetes, hypertension, but non-alcoholic, but tobacco chewer. Troponin was positive, ejection fraction was normal, no significant, non-specific STT changes was there in ECG, and somehow patient was advised for CABG, but patient was not willing. Hemodynamically stable. I calculated the syntax score was 27, heavily calcified artery with diffuse disease, comorbidities, diabetes and hypertension. So this is anatomy. Heavily calcified right coronary artery, diffusely diseased, having tightest part at the carina, and in left system also circumflex having distal diffuse disease, LAD is heavily calcified, having disease in proximal and mid part, that is a critical one, and you will appreciate tightest part in mid LAD. So this is my coronary angiogram. So over to moderator Pramod sir. What could be done in this case?
I think you've started imaging. So that would be the first thing to do in both right and left, and then you plan it. See, I mean, there are guidelines both in IVUS and OCT how to go about it, whether you really need rotablation or orbital or IVL, depending on the extent of the calcification that you have. And if you feel that it doesn't need a rotablation, then there are very strong recommendations that if it's a fibrotic, more of fibrosis, then cutting balloon. If there is calcium, then high pressure balloons like OPN and all. In fact, the recent TCT trial actually showed that both rota and orbital are not superior to high pressure balloons or OPN balloons.
Yeah, Eclipse trial.
So it came as a very big surprise to everyone. So it's very important that you plan it after you have done the imaging. The second thing, whether we should really go for the circumflex or not, I will not be very keen to proceed with the circumflex. So RCA and LAD should be our targets.
Yeah. Thanks, sir. Actually, we did the same. Actually, on coronary angiogram, the RCA looks like very thin caliber, just at the caliber of catheter. So we used lots of technique in this angioplasty. So in imaging in forms of IVUS, for plaque modification used cutting balloon, Olverin. For heavy calcification, Rota and IVL. For stent delivery, we have to use guide extension catheter. What happened in RCA? Straightforward, we started dilating the lesion, but at the carina, the lesion doesn't give away. So we started with doing IVUS, and this is the picture. You will see 270-degree calcification in mid to proximal part of RCA, and the caliber was quite larger diameter as we estimated on only coronary angiogram. In proximal part, it was about 3.5. Yeah. So we decided to go with cutting balloon. We did aggressive cutting balloon from mid to proximal part with 3x15 Wolverine at multiple sites. After that, we deployed drug-eluting stent 2.5x32 distally and 3.5x48 mm proximally, but it was very difficult to negotiate a stent. That's why we used guide extension, and only then we will able to deliver the stent. After deploying the stent and post-dilating distal stent with 2.75x12 mm non-compliant balloon, we were able to achieve good result. Then finally we took IVUS to check the proper deployment of the stent, and in distal part it was good, but in mid part there was malapposition. Yeah. So again, we did aggressive post dilatation with larger balloon 4x12 mm non-compliant, and then this was the final result. After this, we went for left system, and as Pramod sir has already rightly said, we also plan to do LAD only. We tried to do imaging first, but unable to negotiate IVUS catheter. So we were exchanged with micro catheter and did a rota with 1.5 bar, 3 cycle rota was done, and then we will, yeah, this was the result after rota. Then again did IVUS, and you can see 360-degree calcification all around from mid to ostia. Then we have left with two options, either increase the size of burr or take IVL. We went with IVL. 3x12, 4 cycle, 10 pulse each. And after doing IVL, we deployed DES 3x38 from ostia because ostia was healthy, and this was the result. We post dilated with 3.5x12 mm non-compliant balloon. Final IVUS image was good position all around. And we achieved minimal luminal area of about 10 square mm. Then this is the final angiographic result. We left the circumflex. This was the lesson learned from the case. Plan before starting any procedure, make available different tools that may be needed, and always get ready to face complication beforehand. Thank you.
Very well done.
Thank you, sir.
So our next speaker will be Dr. Shaheen. Meanwhile, we will be having question and answer session till his presentation gets ready. So we want opinion of Dr. James Nolan, because the experience which he is having, nobody of us might be having that much.
That's a fantastic result. So that's all I can say to you. Congratulations, you did a really good job for your patient there, because that was challenging coronary angioplasty. You know, extensive circumferential calcification, So your employment of imaging and then modification of the vessels before committing to deploy the stents was, well, I would say it was exemplary practice.
Thank you, sir.
The only thing, I mean, for the sake of discussion, one can say is that after you had done the rota, you could have used a high pressure balloon. I mean, another calcium modification device, you might have saved some money for the patient.
Actually, sir, I will show a point was there. There was tight calcification, and that failed to negotiate even with OPNNC. That's why we
Post-rota.
Post-rota, sir. Post-rota.
Oh, you couldn't.
Prior to rota, it was very even IVUS catheter was not going.
Yeah.
No balloon was crossing, so we started with rota. And even after rota, there was a point. Otherwise, the calcification was thin. So we can go with high pressure OPNNC. But there was a point that failed to negotiate.
It's good to see that you didn't try to do the circumflex. That would be like chasing perfection, wouldn't it? And overcomplicating the procedure. I've seen the data from TCT about equivalent performance of high pressure balloons, IVL, rotablation, but it is a bit hard to believe, isn't it, that subjecting the heavily calcified artery to so much barotrauma from a high pressure balloon will be just as safe as the other methods. I mean, you can't dispute the data, but
I saw a case done by French operator Dr. Levere. You might be knowing him. Heavily calcified, 84-year-old lady, distal bifurcation, left main lesion, calcium both sides, no imaging, no rota, high pressure balloons on both sides, very good stent expansion, beautiful result. But the only thing he used was a very high pressure balloon on both sides. That's all.
Whether it's a cutting balloon was used or NC balloon? Only NC.
I saw some data, I think, in TCT recently about cutting balloon performance, and I think it was suggesting that high pressure dilatation with cutting balloons could be a good strategy, because the cutting balloon was always only inflate to moderate pressure, wasn't it?
So they have a new cutting balloon which can go up to very high pressures. Aperta, I mean, it goes to 24 atmospheres.
Hi, good evening everyone. My case is a post-CABG patient with class 3 angina. इससे होना है ये प्रेस case summary. This patient is a hypertensive and coronary artery disease with chronic stable angina class 3. So I did the angio. This patient I did the angio in 2022 and referred for the CABG. In 2022 CABG was done, Lima to LAD, SBG to proximal LAD and SBG to OM and OM2. There was no document, I can't remember whether the RCA was grafted or not. This patient was doing well for 3 years. Then in 2024, patient has acute LVF, stabilized in some other hospital. And after searching and tracing me, he came back to me again after 4 years. The post-stabilization, again patient has angina on exertion class 3 on going to washroom and after dinner, post-prandial walking, he is having symptoms. So after stabilization, echo was showing around 45% ejection fraction, 40-45. CT coronary was done, which showed native triple vessel disease, Lima to LAD and RSVG to proximal LAD patent, and other two RSVG were blocked. So this is her post CT. This is her his angio, which is showing the diseased LCX from ostium to distal with a tight ostial OM. And the LAD graft was patent, as you can see the competitive flow. And the RCA was completely occluded. this RSVG to proximal LED was patent, which was giving retrograde cholesterol to RCA. The grade 3 collaterals to RCA was present. So how to approach? To Dr. Neeraj sir. So Nolan sir, you can guide us.
Yeah, I mean, this is a challenging situation, isn't it? So you're probably going to have to do a CTO angioplasty.
So first here we can see the RCA was having is a chronic total occlusion, but the newly occluded grafts are of OM1 and OM2. Because of that, patient went into LVF and had acute coronary syndrome. So our plan was to open the LCX first and give the medical management, and if it's still symptomatic, then we will plan for the RCA. So we planned the angioplasty of LCX. As on angio, there is no, you can see in the proximal LED, there is a calcium. So we are expecting some difficulty in crossing the wire and ballooning, but we are not expecting too much difficulty. So our plan was to do femoral access, 7 French EBU, IVUS imaging, then decision to use calcium modifying tools, either cutting balloon versus rota ablation. So we wired it successfully. And you can see also that the OM1 was also having osteal disease. So we wired it and did POBA. And after that we crossed the LCX and OM2. But our balloon was not going. So we are not able to do the IVUS imaging before pre-procedure. So we straightforward went for the rota. We did the rota. We are expecting some more calcium in the proximal part, but surprisingly the calcium was more in the osteal OM side. So the whole proximal LCX to OM, we did the rota. This is the rota final run. And after the rota, we did the IVUS. You can see the concentric calcium is still there. And the left main size on the other image, left main size was around 4.8. So the post rota, we did the cutting balloon, multiple sessions and pre-dilatation to 2.75 from OM to proximal LCX. Hand.
So in between, while we fix this technical glitch, I will request Dr. Nolan and Dr. Nishchal. They are managing the calcium in the coronaries with multiple different techniques. So can you share your experience regarding this?
I mean, a lot of technology now has come along that's easier to use than the rotablator. So IVL, high pressure balloons, they're a lot easier to use than the rotor. But there are some cases in which only the rotablator will work. You need a forward drilling system. So, you know, for heavily calcified vessels, you have to have a range of technology available for you, including the rotablation, the IVL, and the high pressure balloon. I mean, in cases like this, post-bypass surgery angioplasty is always difficult, isn't it? And it should be directed at symptom control rather than complete revascularization. I was interested to see the RCT of CTO angioplasty or vein graft angioplasty that favored the vein graft angioplasty. Of course, when you look at the details of that, the vein grafts were quite simple angioplasties. They weren't those horrible degenerated vein grafts. But it was reassuring because the vein graft is often easier to treat than these kind of horribly calcified native vessels.
We have two scenarios. One is balloon uncrossable calcified lesion. One is balloon crossable calcified. So OPN was studies head-to-head to ROTA. So what is your experience in balloon crossable lesions? How OPN is effective and how it is comparable to ROTA?
Well, look, I mean, I think it's an evolution, isn't it? I've always, my view was always that it was better to use the rotor early, to use a smaller burr and to optimally prepare the vessel rather than using a highly traumatic, high-pressure balloons. But the data is probably moving that paradigm now. In you have more flexibility in the way you approach it.
So we put the stent in the distal LCX 2.75, 23 or 28, and then we stented the left main ostium to left main to LCX. We did the pot, and after deploying the stent, we did the IVUS again, with showing under opposed but under expanded stent. After post dilatation and doing pot again, this is the final result.
And you didn't require to do anything to the OM1, which is flowing very well.
Yes, sir.
Yeah, he opened it, but after that nothing happened to the OM1.
OM1 we did initially POBA, but putting the stent flow was there, so we did nothing. And after this was done in July. In November, after 5 months, patient is doing well, there is no angina. So our assumption of LCX was the culprit was right, and RCA was still, there is no issue with the RCA. So patient was doing well on medical management. After the final stenting, we did the IVUS again, well opposed stent, but video stuck, so I can't show.
Do you think it was important to go femorally and to use a large diameter guide there?
Pardon, sir?
Do you think it was important to use femoral access and a 7 French guide rather than a 6?
No, not necessary. We are using 7 French guide through the radial also. Yeah. But this patient has multiple angiography and all, so we keep it the simple. We go through the radial femoral approach with 7 French guide.
Yeah, okay.
Any further questions if somebody is having, because we are finally concluding the session. Dr. Ashish, I think he has left. So thank you everyone. By this we conclude this scientific session, and it was a wonderful deliberation by Dr. Shaheen on the last talk. So it's time to thank everyone because this conference would not have been a success. Whether it is success or not, it's all your opinion. It's not my opinion. So first of all, I thank our most important mentor, Dr. Naresh Trehan sir, who remained with us to get this conference a lot of benefits as well as success. Secondly, I thank all the organizers from the Medanta group. We thank Pramod Kumar sir, our HOD and director, Dr. Ravi Shankar Singh sir, who is our medical director at Jayaprabha Medanta Hospital, because it was his vision also that we have to organize such a big conference, and it was possible after his efforts also. We are thankful to Dr. Ajay Kumar Sinha sir, who is a very pivotal role in organizing the sessions. Dr. Shaheen Ahmad Boss, who is a director. We also thank our consultants from the department, Dr. Pawan Kumar Singh sir, Dr. Vijay Kumar sir, Dr. Shushil, Dr. Shreyash, Dr. Meetu, Dr. Shraddha, Dr. Deepa Shri, Dr. Poppy Bala, and Dr. Suman Prakash. Apart from this, we have a whole lot of our intensivists who work day and night in our CCUs. That's why these cases we are able to see, because we were able to do it effectively by their support. After this, I am very thankful to Dr. Rajan Narayan sir.
and Dr. James Nolan, sir, because through the efforts of Dr. Rajan Narayan, we were able to communicate with Dr. James Nolan and bring him here to share our knowledge. I also thank to Dr. Mithilesh Das, who joined us online, and Dr. Shamlal Umesh. We had 4 international faculties, and all of them joined with us in this conference. I am also thankful to all the senior cardiologists from Patna, Bihar, and all the senior cardiologists who joined from outside Bihar. Especially, we had almost all the interventional cardiologists from Nepal, whomever we contacted, and all of them were present here. Apart from this, we tried to contact cardiologists from all over India, from all the directions, from Mumbai, from Rajasthan, from Haryana, Punjab, Delhi, Uttar Pradesh, West Bengal, Tamil Nadu, Andhra Pradesh, Karnataka, Kochi. We had Dr. Edwin Francis from Kochi. So everyone joined us for this scientific extravaganza. This has not been possible without the efforts of our marketing team. I congratulate and thank the whole marketing team who was with me for all the 3 months. They did a lot of hard work to make this a big success. Apart from this, I also thank all the cath lab team. I thank all the cardiology nursing team. I want to thank the cardiac surgery team because we are doing these kind of complex interventions only by the backup of a good cardiac surgery team. Without a backup of a good cardiac surgery team, it is not possible to do rotablation day in and day out, to do CTO intervention day in and day out. So we are very thankful to our 24/7 big cardiac surgery team. Apart from this, I also thank to the audio-visual team, to the team from the Lemon Tree Hotel that they provided us with such a good hospitality. And marketing, what I said, Dr. Keur, who is leading the marketing team, along with Harsh. Harsh was with me day in and day out. I used to call him even at 12, at 1 in the night, and he was there with me. He was the one who contacted everyone, and he was almost 24/7 available to all the delegates and all the faculties who were coming from outside from India. I am also thankful to all the industries who helped to get this conference in such a big way. This time we organized simulation labs. It was the first of its kind in our state, and we had hands-on workshops on newer technologies which is available, that vascular closure devices, vascular angioseal, ProGlide. We had rota simulation available with a wet heart model. We had leadless pacemaker simulation available. We had made availability of bifurcation and bailout simulations and orbital atherectomy simulations. So this has been possible only because of support of the industry, which is in the field of intervention cardiology and also in the field of clinical cardiology. We had a number of stalwarts available and who responded to our calls, because it was very difficult every time that we call anyone to come to our state and they come so easily. But this time it was very much easy for me, and also because whenever I had any problem in contacting everyone, I asked Pramod sir, sir, you have to call them because either they are junior to you or they are your colleague. So it will be very easy to make sure that they are coming. So finally, on ending, I apologize if I have forgotten anybody's contribution in this big conclave, and I hope that in future we organize every year this kind of intervention cardiology as well as clinical cardiology meet, and next time we plan a more bigger one so that we involve more and more people in future. And finally, because everyone is here, I want everyone to join us for dinner. It will be a light dinner on first floor. So everyone kindly proceed for dinner, and let's meet and greet at the end of the program, everyone. Thank you.
Next year it's going to be bigger, and Pawan is going to be the organizing secretary. Right? Yes. Last but not the least, Samshad, who's done a wonderful job. Wonderful job. You know, there is always room for improvement. Everybody will say that yes, we will take all our this was grand. And all efforts by Samshad.
Yes. Thank you, sir. And I request everyone who is available with us that let's have a group photo. Ravi sir, because you played a pivotal role.
Also thank Pankaj Sani. He was after our life for a long time.
Very important.
Please come.
Very important thing which I want to say that this conference was a brainchild of Pankaj Sani sir, because it was a meeting done almost 7-8 months back when he said that we should have a big conference from cardiology team.
आ जाओ